Testing. Good morning. If everybody could please find your seats, we're ready to begin this morning's session. That means you in the back. There you go. Good morning. We would like to thank Terumo for sponsoring today's breakfast. We're going to have Stephen Dove, who is a CCP emeritus, talk about high-pressure excursions. Steve?
Thank you, Carla, and welcome. This is Breakfast with Steve, so hope you enjoy it. On behalf of Terumo, we want to thank you for your support and thank you for coming out this morning. We have, yes? So we're somewhere in Asia, it looks like. It's a beautiful beach.
It is. That's why we have it here for you. We had it before, did we? Yeah, we did.
Yeah.
Okay. So slideshow from beginning. We have nothing. Okay, so we have this. Let's open it up again.
Something over there on the left.
Okay. Okay. Okay, so you said did you have a spare computer with you?
Yeah.
And it's on it?
You want me to get it?
Just in case, please. I'll keep working on this.
Okay. All right.
I don't know. It was perfectly fine. It was perfectly fine.
It would be nice to be able to do this. Can I do this?
Let me just. You have your USB port. Hopefully, it's just plug and play.
That's going to go in presentation view. It's okay. We'll get through it.
Oh, your USB goes there?
So I use this.
Yes. Just plug it into your USB port, and it should work.
Ah, there you go. Okay, I just changed out my oxygenator, so we're ready to go. Good morning, and welcome again. So apologize for that. We had a little technical glitch with the laptop here. So wanted to, again, welcome everyone on behalf of Terumo Cardiovascular. And I'm going to be presenting a topic here today that, you know, when I travel around the country doing training on either disposables or hardware, whatever it might be, sometimes I'll ask, have you ever had a high-pressure excursion event, or do you have any experience with it? Do you know what it is? And a lot of times I'll get like this blank stare, or people look at me like I have three heads. So I'm just out of curiosity, if you could raise your hands, if you've ever personally experienced a high-pressure excursion event? Wow, very good. Okay, so I'll invite you up here and you can give your comments and experience. So, but actually for the most part though, for the majority of our profession, these are really unknown and have not been experienced. Really, the overall incidence, the highest incidence rate is around 3%. It's very low. So what we're going to do today is really go through what these events are, so you'll be able to define them, and also to understand what's happening actually inside the oxygenator itself. Also to understand what the pathophysiology and what perfusion techniques can actually contribute to these events, and to learn how to best monitor and mitigate these events. We want to understand the importance of monitoring pre- and post-membrane pressures, and we also want to understand the value in reporting to the respective oxygenator manufacturers. Something that we need to understand is this happens with every membrane oxygenator that's on the market. It's not particular to any manufacturer's design or any particular brand oxygenator that's out there. So what I wanted to do is kind of begin with a case. And this is a composite, if you will, of a couple of reports that we have received in the past. And so if in between bites, if you will, kind of maybe place yourself in the operating room right now. So this is our 8 o'clock case. And as I go through this case, maybe think about how would you manage what's going on here, or what would be going through your mind as far as troubleshooting, and what would be your plan of action. So our patient this morning is a 63-year-old male. He has hyperlipidemia. He has an EF of 35%, and his hematocrit's 38, and his BSA is 2.1. Our planned procedure today is a myocardial revascularization, 4 grafts, and our pre-bypass ACT is 688 seconds. So everything's going well, patient's hemodynamically stable, he's put to sleep, the lines are in, and then you go on pump. Shortly after initiating cardiopulmonary bypass, though, you notice that the typical flow RPM relationship or ratio on your centrifugal pump is not normal. Your arterial line pressure measured post-oxygenator is lower than normal, and your patient's systemic blood pressure is low as well. So you keep turning the RPMs up, trying to achieve your targeted flow, and now you're 3 minutes into this pump run. Your RPMs are about 3,100 RPMs, your blood flow is about 2.5 liters, and the patient's systemic pressure is 43. Your venous sat is 63%, and you're definitely trending in the wrong direction. And at this time, the surgeon's asking for the cross clamp. Interestingly, when you look at your CDI or your blood gases, they're normal. So you quickly scan your circuit, you look for anything obvious. You ask up at the field, are there any clamps on? Are there any kinks? Do you see any clot anywhere in the circuit? Nothing obvious. You're now 4 minutes into your pump run. You've just announced to the surgeon that you're continuing to have trouble. In fact, it's deteriorating. You've maxed out your RPMs and you're still not able to flow much above 2.5 liters. So you recommend holding off on cross-clamping the patient at that time. And in fact, what you do is ask can you come off pump and really evaluate the circuit and see if you can really solve this dilemma. So you tell the anesthesiologist, go ahead, start ventilating the patient. You bring the patient off pump. Off pump, the patient's hemodynamically stable, and then you start troubleshooting the circuit. So as you scan the tubing lengths and you look for obvious signs, again, of clot, any kinks, any obstruction of flow, you can't see anything. You remember your pre-bypass ACT was over 600. Your oxygenator seemed to be working fine. The blood color looked good. The gases were good. Then you think, okay, let me check out my centrifugal head. Wasn't making any noise, didn't appear to decouple. The drive itself seemed fine. There was no obvious noises coming from the motor. You uncouple it, you look in the back of the centrifugal head, there's no fluid behind the magnet, everything appears fine. But then you remember, you know, my line pressure was low. My post-membrane line pressure was awful low, you know. It must be the drive. It must be my centrifugal head. So you change the centrifugal head out. You go back on pump, and you have the same problem. So you say, well, what's next in line? It must be the oxygenator. So you come off pump, and you change the oxygenator. So obviously, changing out the centrifugal head was the wrong answer and did not really gain anything for you. So this scenario then describes a typical high-pressure excursion event. And the literature going back to the early 90s has described these events, but really what makes these events so challenging is it's a combination of factors involving a sequence of events attributed both to patient pathophysiology, but also in some cases perfusion techniques as well. So again, one of the challenges, and again, when I have conversations regarding high pressure excursion, and people look at me, and some of them have really never heard of this. And a lot of the problem is the nomenclature itself. If you go back and you look in the literature going back to the early 90s, these papers are titled, and they use different terms: transient pressure phenomenon, platelet-mediated pressure excursion, white clot syndrome, high transoxygenator pressures, fibrin discharge, high pressure drop phenomenon, and my favorite of these is oxygenator vasoconstriction. So, I mean, just on this slide here, what you see is if we would take an oxygenator in the membrane bundle and just basically cut it in a sagittal section and looking end on, you'll see those gray circles on the left side. That, again, is the lumen of the fibers within the oxygenator. And as blood flows into the membrane compartment, blood, of course, goes through the channels going around those fibers in a normal state. On the bottom there, I know it's hard to see, is that's the normal pressure drop. Every oxygenator manufactured, particularly in the United States today, if you look in the IFU, it has a pressure drop rating. They all have it. It's inherent in the design of that particular oxygenator. What brain pressure gradients be actually used as an accurate tool or diagnostic tool to assess the function of the oxygenator during clinical bypass. The second part was essentially what they were looking at is what was the rate of occurrence of these events in this series. They used 9 different oxygenators. 5 were used at more than one of the facilities that they did the study at. The gradient was abnormally raised in 16 cases, or 1 in every 230 cases, or an incidence of about 0.4%, which actually, even in the literature, and we'll go through this in a second, is rather low. So what happened is they kind of defined 3 different types in this series. In 9 of these incidences, the pressure gradient was normal immediately upon going on bypass, but rose rapidly to a plateau value and then spontaneously returned to normal within about 40 minutes. And that's another characteristic of high pressure excursion events. The majority are self-limiting. And so what happens is, in those cases, most of the times you do not need to change out an oxygenator. If you can get through the event, it is self-limiting, and we'll talk a little bit more about that when we talk about mitigations. 3 of their cases, that pressure gradient was raised immediately upon going on bypass and then also rapidly returned to baseline. Now, they had one case where the pressure gradient was increased on going on bypass, but stayed high during the remainder of the case. And so, let me show you, these are graphs, and again, it's kind of difficult to see up there, but these are each of the 3 types that they had experienced. The first type, type 1, they had an increase in pressure in the beginning of the pump run and then a slow resolution back to baseline. The second, again, an increase at the beginning and then a more rapid descent during the case. And then that type 3, it was raised and then it remained high during the conduct of perfusion. What they finally found out in case 3, when they did more of a forensic look at that case, was that was actually iatrogenic. They had actually entrained clot in the oxygenator. They apparently had turned the suckers on before they had done systemic heparinization of the patient. And so they had entrained unanticoagulated blood into the circuit. So really what they had, from a pathophysiologic standpoint, they really had 2 primary types of HPE. So this was the incident across all 8 different hospitals. You notice there's a variety as far as the incident rate among the hospitals. And then they took a look at the series up to that time of what the incident was that was in the literature at that time, not only of the overall incidence, but of the incidence of oxygenator changeout. And again, incidence of oxygenator changeout tends to be very low. Overall in the literature, the incidence of HPE is a low of 0.4% to a high of 2.4%. So the next paper I wanted to take a look at was Myers and his colleagues published this in JECT in 2003, same year. It was a multi-center investigation into the occurrence of high-pressure excursions. So this study looked at, this was a retrospective study that looked at close to 2,700 patients at 3 Canadian tertiary care centers. They looked, what they were trying to find out, was there some magic bullet, if you will? Was there some causative agent or causative precipitating event that helped lead to these events? So they looked at 21 different preoperative, intraoperative, and postoperative variables during these cases. They had a total of 35 patients experience HPE during their pump runs, but they only had comprehensive data on 31 of those patients. This was an era before electronic medical records, and so all of these were paper records that they went through. So 2 types of oxygenators were used in this series. The Sorin monolith was the majority, and then a smaller number of Medtronic affinity oxygenators. All circuits were uncoated, and there was no albumin used in the prime in this series. All of these circuits, they used roller heads, and they monitored both pre- and post-membrane pressures. And the patients were not actively cooled. So these are all the types of variables they took a look at, both the types of operation that was done, the equipment that was used, the different oxygenators, filters. They looked at the perfusates. They looked at the medications that were added to the perfusates during their pump runs. They looked at preoperative variables, all the demographics, and they looked at also the preoperative medications. And in addition, other pre-bypass variables, including looking at the ACT, the type of ACTs that were done, as far as what platform they were using. They looked at pre-bypass anesthesia techniques, and they looked at also on-bypass variables and all the different medications that were administered. Essentially what they found was there was no secret sauce. There was nothing there that really pointed specifically to a specific variable or singular variable that could lead to an HPE event. But what did they find? They found they had an overall incidence of 1.3%. They found that the population of patients who experienced high pressure excursion was predominantly male, 87.1%. They also found that the majority had coronary artery disease. Almost 97% of the cases of HPE had coronary artery disease. Propofol was used in 74% of the cases. They found no relationship to perfusate temperature, and sometimes people are surprised by that because we think of cold agglutinin disease. Cold agglutinin disease can lead to an HPE-like event in an oxygenator, but as a generic HPE event, there's really no correlation, if you will, to temperature. Platelet counts, and this I think was a significant finding, and we'll talk about this when we talk about mitigations. Platelet counts were reduced between 62 and 98% in these patients. And so this gets back to when you change the oxygenator out, what are you doing? You're throwing out upwards of 98% of the circulating platelets of that patient into the trash. So that's why we want to do whatever we can to avoid changing out these oxygenators. So this was a paper published by Carol Hamilton and her colleagues from Germany in 2019. And this was entitled, Taking a Critical Look at Priming of Oxygenators and Air Removal, the Missing Link to High Pressure Excursions. So a little background on this paper. So Carol and her group, they had been using a particular oxygenator for a number of years and then made a decision to change that oxygenator and go to a different manufacturer and a different oxygenator. This was in October 2012. Within 4 months, they had had 3 HPE events. And again, historically, they had had none. So they immediately thought, well, what is going on here? Let's go back, forensically look at these cases and see what have we done differently, what's changed. So when they looked at the cases, all had adequate anticoagulation. Their ACTs were over 400 seconds. Their lowest temperature on CPB was 34 degrees, so they were not profound hypothermia cases. But they did recognize that they had noticed when they were priming this oxygenator that it appeared that there was residual air in the oxygenator, that it was detected in the bubble trap, the pre-membrane bubble trap. So their hypothesis was, could this retained air within these oxygenators be causing these HPE events? So Carol actually went back and looked at some early work that had been done in the late 70s and early 80s, looking at the effect of air on blood and complement activation, platelet activation, and it had been documented that it was well known that that air within compartments like that could activate blood and blood components. So their hypothesis was then, was this retained air in these oxygenators causing these HPE events? So what they did is they devised their own priming technique, if you will, to prime these oxygenators to make sure that they were completely de-aired. So after they developed the priming technique, they made sure everyone was trained on the technique and they all began to prime their oxygenators the same way using this technique. So after doing this and monitoring these cases, up to the time that this paper was published, after 4,500 cases, they had no further incidents of HPE. Now, there was no control group in this, so we cannot say from a purely scientific or statistical, we can't say that for sure there was a direct cause and effect. But certainly it's highly suspicious that air did play a role in this series and in what they experienced. So I wanted to share this with you. This was a graph out of her paper that they presented. And the interesting thing about this graph is I think it's a great pictorial, it reveals really what's going on in the relationship within the oxygenator between pre and post-membrane pressure and temperature. So in other words, if you look at the red line there, and that's the post-membrane pressure, and ignore the blue and the gray for just a second, that's pretty much what 98% of heart centers monitor in the US. We just monitor post-membrane pressure. So during these cases, if you're just looking at that one piece of data, you're gonna think there's nothing wrong. What's going on inside this oxygenator? You have no idea. So let's look at the relationship then between the blue line, which is the pre-membrane pressure, and the gray line, which is temperature. And notice when they go on in this particular case, the temperature, they're cooling the patient, and then you immediately start to see a rise in pre-membrane pressure. Again, notice the red line, it's linear. There's no change at all. And then notice the relationship between the change in temperature when they begin to rewarm. Notice you start to see a resolution of the pre-membrane pressure. And so the pressure gradient then normalizes. And so this is, to me, it's a powerful visual. It shows you the power and the value, if you will, of monitoring both pre- and post-membrane pressures during cardiopulmonary bypass. Not only does it allow you to diagnose and pick up on these HPE events earlier, but and we'll see when we talk about mitigations, it helps you monitor how are your mitigations doing. Are you affecting any change? Are you doing what you need to do? And do you maybe need to try something different? So this is a paper that was recently published in Perfusion in 2021. The group out of Switzerland, I believe, Sweden, I'm sorry, Swiss group. And I don't know if this has appeared in publication yet. This was published online. This was a retrospective observational study looking at over 2,000 patients. All patients underwent cardiac surgery on bypass at a single center. CPB was conducted with roller heads, coated circuits, but no albumin in the prime. They had 37 patients, or an incident rate of 1.8%, and their independent predictors statistically of HPE were large BSAs over 2.1, high hematocrit on bypass, greater than 30%, previous stroke, and acute or emergent surgery or urgent surgery. There was no difference in mortality between these two groups, with the groups that had HPE and that did not. But what was interesting is they had a much higher stroke rate in the HPE group. This is postoperative stroke rate, 8.1% versus 1.8%. Now, their treatment modalities included hemodilution and/or extra heparin and/or epoprostenol, but they had no oxygenator changeouts in their series. They defined, and I know these graphs are kind of hard to see up there, but they defined two types, very similar to what Fisher had described in their types. Again, but more of a slower increase. Pre-oxygenator pressure exceeded 600 millimeters of mercury, they would change out the oxygenator. Now you might ask, well, why 600 millimeters of mercury? I know for many of our oxygenators are inlet pressure rated up to 1,000 millimeters of mercury. The problem is your connections. Your connections will not survive 1,000 millimeters of mercury. Generally, if you get much above 600 millimeters of mercury, you're going to start blowing connections, even if they're tie-banded. So they elected to do that as far as their management algorithm is to change out at that level. But they did not have to do that during this series. For crits greater than 28, they would go ahead and hemodilute their patients using either albumin or crystalloid, and then they would reevaluate. So what has been Terumo's experience with high-pressure excursion? And so what we did, we went back and we looked at our reported complaints going back to September 2009 through March of this year. We've had a total of 29 reported incidents. These reports come in as either low-flow reports or high-pressure reports. And you can see how they're divided between the timing of the issue and the type of pump that was involved in the issue. So majority you'll see are at the initiation of CPB, and again, the majority happen in centrifugal pumps. So, and if we combine these complaints, again, we see the timing of the issue. Majority of these cases are at initiation of cardiopulmonary bypass, and again, the majority of times it's with a centrifugal pump. Our overall, if you look at the overall incident rates for Terumo, it's 0.0021%, very, very low. These are rare occurrences. So what do we know about high-pressure excursion? Based on the literature, based on our complaint history, based on what's been published. We know the incidence in coated oxygenators is much lower than uncoated oxygenators. So coating is your friend. Coating will help, is protective against these events. We also know that coronary artery disease plays a significant role in these events. Between 89 and 97% of HPE incidences reported present with coronary artery disease. Well, why is that? It's felt it could be related to two factors: increased lipid levels and also increased amounts of von Willebrand's factor that's associated with coronary artery disease. The von Willebrand's factor acts as a mediator between platelet adhesion and fiber and thrombogenic surfaces, and it is also a carrier for procoagulant factor VIII. So when we talk about centrifugal pumps versus roller pumps, in our complaint history, we have a significant trend toward higher reported rate when a centrifugal pump is used. And this just simply makes sense because centrifugal pumps are afterload dependent. So it's not that the centrifugal pumps, though, are just much more sensitive to any increase in afterload versus a roller pump, which is a positive displacement pump, which is independent of afterload changes. The other thing that we've noticed is centrifugal pumps, you'll tend to pick this up much earlier. You'll probably within the first 5 to 15 minutes of bypass, you'll pick this up, again, because of that changes in afterload. In the roller pump complaints, they tend to occur later on in the bypass run, and again, predominantly because you can continue to pump. You're not afterload dependent, so you just basically keep pumping through the membrane. And again, because in the United States, majority of perfusion cases, we don't monitor pre and post membrane pressures. So we have no idea, especially when you're using a roller pump, that this event's not even occurring. Albumin. We know that albumin is protective, and something else, a trend that's happened in the United States is over the years is that we've been using more and more coated circuits, more people have gotten away from using albumin in the prime, and that's probably a mistake. We probably need to go back to putting albumin back in our primes because it is protective against these events. Temperature effects. It's important to understand that HPE can occur whether you're warm, whether you're cold, or anywhere in between. But what we do know, though, that warming a patient is therapeutic and does help. And so instead of getting in that situation where you're thinking about changing out an oxygenator, what do? You cool the patient. That just makes the situation much worse. And so it's almost counterintuitive. You want to warm the patient. Even warming 1 to 2 degrees makes a big difference. And what happens is the platelets can relax, and then they release off the membrane and they go back into circulation. You remember what happened to those platelet counts on that series in that one study. We have between a 60 and 90% reduction of platelet counts during these incidents, and it's all because those platelets are bound either to the membrane or the heat exchanger compartment. Propofol. So some of the research implicates it, some don't, some say maybe. But what we do know is that the emulsion that propofol is mixed in, it's a lipid-based emulsion. And so what that can do and has done, and I've seen it clinically myself, it can coat an oxygenator. It's transient. I've actually seen one oxygenator almost turn black. I worked with an anesthesiologist. He always would bolus propofol when we started rewarming, and he would put it on the sidearm of the Swan. And it came right down the venous line, right into the oxygenator, just turned dark. But it was transient. It would last for maybe 3 or 4 minutes, and then it would return to normal. So whether propofol contributes to these events or not is debatable, but certainly just be mindful of that. Putting propofol into an oxygenator is not a good thing. Oxygenator design and specific de-airing techniques. Again, we think back to Carol Hamilton and her experience with her group in Germany. Does oxygenator design, could it potentially lead to these events? Again, when you think about entrapment of air and your ability to prime oxygenators adequately, and also another thing that we maybe have gotten away from is CO2 flushing. And so maybe CO2 flushing is something we need to go back to, again, because could retained air play a role in these events? Most assuredly, probably does. How much, we don't really know. So let's talk about mitigation. And again, Arpe in Switzerland, he had this case report utilizing epoprostenol as a treatment for HPE. He published this in 2018 in Perfusion. This case report involved a 59-year-old gentleman undergoing an aortic root replacement. This case they used an Inspire 8, and during the first 15 minutes of the bypass run, there was a small increase in pressure drop, and then it just continued to increase over time, maxing out at a pre-membrane pressure of 544 millimeters of mercury with a pressure drop of close to 300. This is a graph depicting this case, and you'll notice the transmembrane pressure is the dark line and the pre-membrane pressure is the dotted line at the top. And then notice when they administered the epoprostenol, there's almost an immediate response where those platelets just release and they go back into circulation. They come off the membrane and then the pressures drop right away. So it was quite an event. So they continued to use epoprostenol for treatment of these events. So when we talk about mitigation, what can we do to manage these events when they happen during cardiopulmonary bypass? One of the things we can do during our priming is raise the circuit pressure and let the circuit recirculate over a period of time. We want to move that air across that membrane bundle, across that membrane compartment, and get it out of the oxygenator. So increasing that pressure gradient across the circuit during priming will help. And also to develop specific priming protocols. I mean, one of the things that we run into too, it's a habit. We were trained to prime membrane oxygenators a certain way, and maybe we've taken that habit, if you will, and we've used it throughout our career. The problem is the design and how oxygenators are made are completely different now. In the last 10 years, there's been a marked change in oxygenator design. The membrane compartments are smaller, the fiber bundles are wound differently, the surface areas have changed, and the transmembrane pressures within the oxygenators are inherently have changed as far as the design. But have our priming techniques changed to accommodate that? And one of the things that we need to do is go back to the IFU itself. Have you read the IFU? Each manufacturer has a priming technique that they have listed in their IFU. Are you following that priming technique, or are you just priming because this is the way I've always primed an oxygenator? So these are important considerations that you want to go back, look at the IFU for your particular oxygenator, review the priming steps, and follow them. And make sure everyone on your team is doing the same thing. Epoprostenol, it's a synthetic equivalent to prostacycline. It's a powerful vasodilator and platelet inhibitor and has a very short half-life, like I said, about 6 minutes. This, of course, is off-label use, so I can't recommend any dosages or anything, but you can search the literature and find out what they used and how they used it. Another drug that has been used in the literature is sodium nitroprusside or nipride. Also has an antiplatelet effect. Boluses have been used, and then they would continue with a drip and have had some success using that as well. Again, rewarming, simply rewarming, even 1 to 2 degrees will be helpful. And so again, that immediate and initial reaction as you're in these events, you want to cool because you're thinking in the back of your mind, I'm going to change this oxygenator out. In these events, it's the worst thing you can do. It's just going to make the problem worse. And remember, if you look back in the literature, most of these events, probably over 95% of them, are self-limiting. They will go away. They will correct themselves, if you will, if you can just get through that high-pressure phase. Albumin added to the prime is certainly protective and has been proven to be protective, so we should put albumin back in our primes. Avoid high hematocrits on cardiopulmonary bypass. Consider hemodilution. So and again, we've had this whole trend in the profession. We want higher and higher hematocrits. You know, hemodilution is not your friend. And I think we need to strike a balance because not only is it affecting, it affects the oxygenators, but I think we've forgotten about capillary perfusion and microperfusion within the patient itself. So there is a sweet spot I think we need to find with our hematocrits as far as targeting our hematocrits. But certainly if you find yourselves during one of these HPE events and you have higher crits on pump, try hemodiluting, okay? Viscous blood certainly is just going to have a higher pressure gradient going across the membrane than lower red cell mass blood. If you suspect an HP event, if you can think of it, one of the first things you need to do is draw a platelet count on pump. Why? Because this can almost be diagnostic as well, or at least confirm the event for you. If you draw that platelet count and all of a sudden you've gone from 250,000 to maybe 40,000, you know a significant number of those platelets are probably resting in your oxygenator. So it's valuable information to help, again, put together the pieces, and it's also valuable information to share with the manufacturer as well. We know that to help manufacturers, to help in oxygenator design both now and in the future, we need to report these events. You know, a lot of people, I've talked to people who've had these events, and I'll ask them, did you report this to your respective manufacturer? And they say, no. We need to report these events to the manufacturers. It's the only way we can collect accurate data and really get an accurate sense of what the true incidence is. One of the reasons I think the incidence is so low in the United States is simply because, one, we don't monitor pre and post membrane pressures, but two, we're under-reporting. So report these events, even if you suspect it. Remember, most HPE events resolve on their own. Most of these are self-limiting, and most of them you can get through without changing out the oxygenator. But if your pre-membrane line pressures do exceed 600 millimeters of mercury, certainly, and that most likely you're using a roller head in those instances, and or you cannot obtain adequate forward flow to maintain adequate DO2 for the patient, then you need to change out the oxygenator. But if you change out the oxygenator, you also want to check your platelet count post-CPB, because more than likely you've probably thrown out upwards of 90% of those circulating platelets for the patient, and more than likely they're going to need a platelet transfusion. So this is a graph. This was from Meyer's series, and what this was, they had polled 52 North American cardiac centers who did heart surgery, and asked them basically, what pressures do you monitor on pump? And so you look at the number of centers that monitor pre-membrane, post-membrane, pre and post-membrane, and none. And the vast majority in North America at this time just monitor post-membrane pressures. And this is part of the problem. The culture in Europe, and our colleagues in Europe have been monitoring pre and post-membrane pressures for years, and that's why if you look at the literature, the majority of literature that's been published in this area has come from Europe. It's because they monitor these pressures and they pick it up. In the US, we simply don't do this. And so for the avoidance of interrupting cardiopulmonary bypass for an oxygenator changeout, that's the goal with this. But to achieve that goal, we need to monitor pre and post-membrane pressures. It's critical information. It's not only necessary to diagnose what's going on within the oxygenator for HPE, but it's critical in really assessing the effectiveness of our mitigations. Whatever you're doing, be it raising temperature, be it raising the temperature and doing the other epoprostenol or other therapeutic modalities, how do we know? This is the only barometer we know, indicator that we have of the health or what's going on inside that membrane compartment. So in conclusion, what can we say? First, there are really no clear-cut answers. There's no silver bullet, if you will, when we talk about high-pressure excursion events. They remain sporadic, they remain a very low incidence, they're unpredictable, And a lot of them go undetected simply because we don't monitor pre and post membrane pressures. The information in the literature until recently is from a different generation of techniques and technology. Some of the techniques being routinely practiced today were recognized back then when a lot of the early papers came out in the early 90s as actually being contributing factors to HPE. So we need new data and we need new studies. It's difficult to quickly diagnose. Again, I've droning on about this, but it's very important. It's hard to diagnose these events and assess the effectiveness of your mitigations simply without monitoring pre and post membrane pressures. All HPE events should be reported to your respective oxygenator manufacturers. It's the only way, number one, we get an accurate sense of what is the true incidence of these events, but also to help the engineers and help design better oxygenators to help maybe avoid some of these events in the future. So I want to thank you for your time. I'll leave those are the references I used for this talk. If you'd like to take a picture of those, I'll leave those up, and if there's any questions. Thank you very much.
We have a few online questions. First one's from Leah Hayden. She wants to know, do you notice a correlation of higher pressure events with the length of time a pump has been primed, and does this play a role?
Has not been looked at that I've seen in the literature or in talking to people. I think there's been no correlation between time of prime.
Okay, then we have one more question from Marietta. She asked, does going on with the dry venous line and vacuum increase the incidence of HPE?
Interesting question. Theoretically, you could say yes, but again, we have no literature that shows us a cause and effect, and this is part of the problem with HPE. It's we're throwing things up against the wall and seeing what sticks. We just don't know. We just don't have enough good literature to really guide us, to really say with any certainty that these things do contribute to the problem. Just don't know. But certainly we do know that air can play a role, and air does activate both complement and platelets within the membrane compartment.
Hi, Luke Buzz from Iowa. I used to be a perfusionist in Europe, and my experience, we had quite a lot of experience with these HPA events, and I would like to applaud you and Terumo for bringing this out, because we believe it's a real problem or something that needs to be taken care of, or just be knowledgeable. I could talk to you all day about this because it's really interesting. But first of all, there's something about the air that stays in the oxygenators. And there's going to be a publication coming out soon in Azayo, and it has nothing to do with high pressure excursions, but it's a group that uses a repriming technique.
Right.
And what they also start with a dry venous line. Well, they prime everything, and then before connecting it, they empty the venous line, and they do a series of things. They wanted to see if there were more emboli by doing that, and what they found was that actually if you manipulate your oxygenator and you let blood go through it during that procedure, they had less emboli when starting with the venous line and using vacuum.
Yeah.
So there's something about that air that retains there, and then I think we've reached the maximum of how fibers are wound up in an oxygenator. At some point you cannot get closer to each other, and you're not pumping anything through. And sorry for my long remarks. But
no, they're important points.
Yeah.
Yeah. Especially, I think we're reaching the critical mass on oxygenator design, and what we're able to do, as far as the surface area of the membrane in this fixed compartment that's gotten smaller and smaller because we're going for the holy grail of low prime. Something's got to give. And so are we starting to see effects of these designs clinically? That we just don't know. We can guess, But we need additional research to really know.
So I just have two or three more remarks. So apparently it doesn't happen with quadrox oxygenators. So it's only with cylindrical membrane oxygenators. I don't know if you're familiar with that.
Say that again. I'm sorry.
It only happens with cylindrical oxygenators.
Cylindrical. Okay.
So the quadrox, we haven't heard any events there.
Yeah.
Maybe they're not reported, but
Well, is it the same type of membrane material?
well, the design of how they are.
The design,
Yeah,
yeah.
yeah.
But, I get this question quite frequently, well, do you see this in ECMO? A couple of differences in ECMO. One, patient population probably trends a little younger. How many of those patients have coronary disease that are on ECMO? Second thing is really membrane type, the type of fiber used in the membrane. They're different. The membrane material is different. So again, to compare them is apples and oranges, really. And then the other thing, the temperatures, you're staying warm. And so it's really a different animal. And then I also go back is on ECMO, we do see elevated transmembrane pressure gradients. In fact, that's why you have to change out an oxygenator sometimes. So, but it is a different animal than what we see on traditional cardiopulmonary bypass. So.
And then for the monitoring of pre and post oxy, we actually put that in the European guidelines for perfusion.
I'm glad
So
you mentioned that.
That's really
I think that's something that,
recommendation.
how many of you are involved in perfusion education here? Raise your hand. Why we do not teach this in schools? Why do we not support this in perfusion training? It just is beyond me. To monitor pre and post membrane pressures. It just, for some reason in the United States, I know even when I was trained, we've never done it on routine cases. Oh, you don't need to do that. It's a short pump run. Why would you do that? Well, this is why. You have no idea what's going on inside that membrane compartment at all, and no way to assess it, nor no way to assess your mitigations. We're shooting in the dark, and I think it leads to a lot of unnecessary oxygenator changeouts in the U.S. I think the other thing, we've done such a great job of training the students now. They're very adept and very good at doing changeouts. But on the flip side, I think you can almost be a little bit flippant about it in your decision. Okay, well, I can do that. That's really easy. And we forget about the potential morbidity that we're exposing the patients to, both from infection or potential air emboli during these events. And so we have to ask ourselves, do we really need to change this oxygenator out? I know I can do it, but that doesn't mean I should do it. And so that's the whole point, I think. We do a great job at training them to change it out, but we're not training people and emphasizing the importance of monitoring the health of the oxygenator itself, the pre and post membrane pressure. Outside of ECMO.
Last question, I promise. When we had it, we were searching for remedies, and we found on some perfusion blog that we gave a bolus of magnesium. We didn't know how it worked, but in like 50 to 60% of the cases, it would work. It would resolve the problem. Just a bolus of 3 grams of magnesium.
How did you come to that conclusion? I mean, what?
We read it somewhere, and we were like, well, we cannot harm the patient by injecting, bolus of magnesium. So we tried it, and maybe we were lucky, and it worked the first time.
Oh, great. Thank you.
My name is Jim Patterson, and I'm from Lakeland, Florida. And we do have a bypass line around the oxygenator, and we transduce off that bypass line so we can get pre and post by just moving a clamp. We did have one experience. In my 28 years of perfusion, this is the first time I've seen it. We went on bypass with a high crit for cabbage, big BSA, and immediately, the RPMs were going up, the flows were going down. So we moved the clamp, saw that we had a inlet pressure of almost 500, and we had drifted to about 35. And we aggressively started rewarming, gave a little albumin, and within about 5 minutes it resolved. Now, whether it resolved because of what we did? I don't know. But that leads to my question. You're saying we probably should have albumin in our prime. We don't, but we retrograde prime everybody. So the patient's albumin should help coat that oxygenator. So I'm not sure if, again, if we did what we did and it resolved the problem, but I'm not sure if that, if that, what we did to mitigate it actually worked.
Right.
So.
I mean, even if you wrap, I would still dump the albumin in the prime to recirculate it, coat the fiber, and then you're going to wrap.
Well, see, this was my first experience in 28 years. And when I first arrived at the hospital, I took albumin out of our prime because I saved the hospital $40,000 a year. And should we go back to treat every patient with albumin? I mean, like I said, I saw in the literature up to 3%, but I have not had that experience personally in my life. So.
Right. Again, two things is we don't know the true incidence primarily because in the United States we don't monitor. So we don't know. We really don't know. So we can't say what the true incidence is. It's probably low. Anecdotally, I think probably in the last 5 years we've heard more occurrences happening. Why that is, I don't know. So there's just too many unknowns really to say for sure. We just know statistically speaking, based on the literature that we have, albumin is protective. It appears to be protective.
Well, it resolved, so maybe it was the albumin, I don't know. But.
Yeah, or more than, you said you're warm too. That probably also played a large role. Yes.
Our last question.
Mike Forster from York, Pennsylvania. I was wondering if we are shooting ourselves in the foot by being overly aggressive with wrapping now. Seemingly, we've been, as a community, from what I understand, from other nearby hospitals as well as our own, we're pretty aggressive with wrapping the patient, wrapping the pump.
Right. I mean, does that have a direct correlation to HPE? I have no idea, but it's interesting. It does raise the question. We keep driving the hematocrits up on pump. And again, when you think about microvascular perfusion at the capillary level, what are we doing? Even at 32, 34 degrees, the blood becomes more viscous. And at that level, do you have microvascular sludging, potentially, or shunting, or increased shunting? So, when I was trained, hemodilution was your friend to a certain extent, and it's like now it's a bad word, and I think there's a happy medium there. I think that's been shown in this latest paper that came out looking at HPE. That's one of the therapeutic modalities that apparently worked because they had no oxygenator changeouts. So it's an interesting question, but again, it's something that we need to look at objectively and scientifically. Thank you.
Steve, that was a wonderful talk. Thank you. There are plenty of seats in the front. If any of you standing would like to come down and grab a seat. So, good morning. My name is Carla Mall, and I will be moderating today. For those of you who are watching us virtually, we understand that we have had a couple of freezes. We are getting a new streaming box, so this will be corrected very soon. So please bear with us. Just a couple of housekeeping notes for those of you whose BLS, ACLS, PALS, or anything else that rhymes with that is about to expire. We have them here on site for you to renew your certification. There is a sign up at the office, and they are located directly across from us, right behind. We are going after the break today. We're going to come back here for another keynote speaker, but we will be having our Shark Tank by the pool. So if during the break you want to go run grab your sunglasses, that would be great. If not, we have sunglasses at the perfusion.com booth. So just come by before, we will hand you a pair of sunglasses, and all would be good with the world. Did everybody take our keynote's advice yesterday and look in the mirror and say today's going to be an amazing day? Yeah, because today is going to be an amazing day, because our first speaker is going to be the Robert Walker story. We've had a lot of things in the last 2 years. I know that in my position with Perfusion.com, I received so many phone calls wanting to know, do we have a bed available? Do we have an ECMO available? And always having to say no really took a toll. I know that the death fatigue has been real on everybody in our organization. All the perfusionists, the ECMO specialists, we've all experienced it. But now we have a wonderful outcome of a story, and this is thinking outside of the box. You ready? So we have Angela Sakal, who is the chief perfusionist from St. Francis Hospital, a member of Trinity Health, and Dr. Gallagher. Welcome.
Thank you.
Just give us 1 second to get set up.
Sorry. That's better.
There we go.
Oh, that's better. Are we good?
This one becomes set. Now we're good.
We're getting there. Almost there. Technical difficulties. I love technology. Good morning. As Carla said, my name is Angela, and I'm the chief perfusionist for Trinity Health of New England for St. Francis Hospital and St. Mary's Hospital. There's 3 of us presenting this topic today. With me, I have our chief of cardiothoracic surgery, Dr. Gallagher, and wife of our patient, Robbie Walker, Susan Walker. Helps if I turn this on. So we have no disclosures or special interests. A little bit about us. I don't know how many of you are from New England. We are a 617-bed level 1 trauma center in Hartford, Connecticut. We have a cardiac case volume of about 500 cases a year, and we do somewhere between 30 and 40 ECMOs. We have 5 to 6 bed ECMO capacity, and to date, since the COVID pandemic, we've taken care of 28 COVID ECMO patients. Today we have a story about one of our COVID ECMO patients, and you're going to hear a story about how his family went to extremes to find him the help that he needed, and how in an uncanny kind of set of events, two groups of people got together that were miles and miles apart, and then what life is like in the aftermath of COVID. Before I go any further, I want to ask you guys a question. Anyone check in with their social media before you got here this morning? Snapchat, TikTok, no one? Facebook, Discord, my kids love this. Instagram, and recently acquired by Elon Musk, Twitter. Probably more people than care to admit, but I think we all spend a lot of time on our social media, which is kind of important for the story, but I'll get back to that. Let's talk a little bit about how we make medical decisions. Do we rely on hunches and opinions? We don't. We look for scientific evidence. We want proof. We want to see what the studies are showing, what the data is showing, right? That's kind of how we move forward. So let me ask you this question. How many of you would think this is an ECMO candidate? COVID positive? Okay. Unvaccinated? No significant past medical history? Single organ failure? Now what if I told you he was 52 years old? Intubated for 14 days? Pretty much everyone in this room would say no. Because back in the summer 2021, this patient would have a really hard time finding somebody to accept him for ECMO. There was a lot of COVID patients in the South. The hospitals were full. Everybody was at capacity. If you weren't at capacity, you were being really selective. Some of the other considerations, was this patient a transplant candidate? Because big transplant centers, how many beds did you have? Did you want somebody who was going to be there that was not a transplant candidate? Most likely back then you didn't. Because Elsa was telling us the best outcomes for our COVID ECMO patients were some of these criteria. A BMI of less than 30, less than 50 years old, although some centers were making the cutoff at 45. Intubation time less than 3 days. That was a big one. A lot of time people heard a week, nah, no go. Single organ failure. Now what about vaccination status? Anybody consider vaccination status for COVID criteria? 98% of our patients back in 2021 were unvaccinated, with only a handful of patients that were partially vaccinated. So now you're all saying 52-year-old intubated 14 days, not doing it. Now what if you saw this?
Like you said, he's in ICU. He's been ventilated since the 25th of July. He is currently, he's on a ventilator. And he is in dire need of an ECMO treatment, which is not available at the hospital that he is in. And to transfer him to a hospital in Florida is next to him.
So I'm going to play you the audio. Apparently the audio video is not matching today. I'm sorry you couldn't see the video, but That was the audio for the CNN interview that Susan did. Anybody change their minds about whether they want to take him for ECMO? No? All right, let's go back to Facebook. Anyone ever heard of Face Mash? Well, if you didn't, it's because in 2003 it was taken down after 2 days. Mark Zuckerberg started it as a prank website from Harvard University. He was a sophomore and he wanted to rank the attractiveness of his fellow classmates. It was otherwise known as Hot or Not. Well, the university didn't appreciate this. They thought he violated all kinds of copyrights and privacy laws, so they almost expelled him from school. Well, lucky for us, a year later he launched the Facebook platform, legally this time, by the way. I bet you that when he did this in 2004, from his college dorm room, that he would never expected that 17 years later that this platform would have the power to actually save somebody's life. Because on August 8th, 2021, Facebook and CNN helped bring the Walker family together with us in Hartford, Connecticut. This is Robbie Walker. He's a Florida native and a father of 6. On July 4th, he went to a family party. 5 days later, he tested positive for COVID. He was feeling not so well, fever, cough, weakness, so he had a telemedicine conference and he was given an inhaler and prednisone and told to go home and isolate. On July 15th, he was in the emergency room. He wanted a chest x-ray, but they said his lungs were clear and they didn't need to do an x-ray, so they sent him home. They said continue to isolate. 2 days later, he was back in the ED. Now they did the x-ray. He was still feeling bad, deteriorating. He was diagnosed with COVID pneumonia and admitted to the hospital. They started him on a course of remdesivir and Decadron, a high-flow nasal cannula. Unfortunately, he continued to deteriorate, and he was eventually moved to the ICU and placed on BiPAP. In the time that Robbie was with us, Susan and I had many conversations, and one of the things that she said to me that will always stay with me is that you leave the house with the TV on and the dog on the couch, but you know your life, it's never guaranteed. And I bet you in their wildest nightmares, the Walker family never imagined what would happen to them in the weeks and months to follow. Because on July 25th, Robbie Walker was intubated. He called his family. He was thinking maybe he was saying goodbye. He didn't know if he was ever going to see them again. Over the next week, the hospital that they were in said that the idea was to perform a tracheostomy and then move him to a long-term care facility who would wean him, eventually take him off the vent. But unfortunately, a couple days later, the hospital changed their minds. They told the family that his lung damage was irreversible. He would not survive the wait for a lung transplant, that he was not an ECMO candidate, and he was very likely going to die. Well, Susan heard the word ECMO. Well, what is ECMO? What is that? Is that something that can help? So her and her family, they formed a call center, and they called dozens of hospitals across Florida and up and down the eastern seaboard. But every time they were told, no, he's not a candidate. No, he's been intubated too long. No, he's not even a transplant candidate. So, out of an act of almost desperation, on August 8th in the morning, she did a CNN interview. Later that morning, I was getting ready for a Sunday, and it was nice up in Connecticut, good day for a hike, and I get this text from Dr. Gallagher. What about this family? And a link to the CNN interview. So I look at it, and I said, A few weeks earlier, we had had a bad experience with trying to transfer a patient from Florida for ECMO. We waited 5 days for insurance authorization. Literally, the team was on the tarmac waiting to take off to go get him, and he went into cardiac arrest. He was 45 years old and the father of 2. So I'm looking at this and I'm going, I hope that turns out better than the last one. How do I find his family? We didn't call them. They didn't call us. We saw them on TV. The CNN interview, it was very compelling, but there was no information, no way to contact anyone. So what do? Well, I went to my friend Google, and I Googled CNN, and I found a hotline number, and I called it, and I left a message, and I'm still waiting for them to call me back. So I said, okay, what about email? I found an email address, and I left an email message. By the way, still waiting for that one. Have not heard back from anyone. Maybe one day. Dr. Gallagher actually went back on Facebook trying to find Susan Walker, about how many Susan Walkers are probably out there. So he tried to send a message, but after a couple hours, I was just getting frustrated. I don't even know if I can get anywhere with this. I have a perfusionist friend down in Florida, and I called her. I said, Erin, you got to help me. I don't know how to find this family. So she said, hold on, I'll get back to you. So a couple hours later, Erin got lucky. After many misses, she finally got a hit. She connected with Robbie's daughter, Molly, and she told her that although she was in Florida, there was a doctor up in Connecticut that was willing to help, that she just needed a number or a name of someone to talk to, and this is how I got Susan's cell phone number. So I said to Erin, I said, will she even talk to me? She said, yeah, she's waiting for you to call. Go ahead and call her. Later that afternoon, I finally called Susan. Now, what would your reaction be if you appeared on TV and a stranger calls you out of the blue and says, I have the treatment that you're looking for? Is this for real? Well, yeah. I tried to reassure her that I was not a crazy person and this was not a hoax and that we were willing to help. We just needed some more information. This is what we knew about Robbie Walker that day. We knew that he was a 52-year-old male with no significant past medical history. He had a BSA of 2.2 and a BMI 28. He had bilateral COVID pneumonia on the chest x-ray, although we had not seen one. They could not do a CT scan because they felt he was too unstable to transport to CT, so they didn't have one for us. He was on ROC, on and off Levo, Versed, and fentanyl. He had completed a 10-day course of Decadron and remdesivir. He had sub-Q emphysema since July 26 and no history of cardiac arrest. His vital signs were stable with normal sinus rhythm in the 80s and acceptable blood pressure and a slightly elevated temperature. His blood cultures were negative. His ventilator was pushing its limits. His peak inspiratory pressures were in the 30s, plateaus in the 20s. He was getting decent tidal volumes at 5 cc's per kilo or so, but they messed around with his IE ratio to try to ventilate him. He was having a progressive respiratory acidosis with hypoxemia, and they told us this was just getting worse over the past several days. They did have Flolan in use, and continuously, they did try prone ventilation, but they said he didn't tolerate it, was unsuccessful, and actually made the blood gases worse. Looking at his labs, there was nothing really that stood out to us. So Dr. Gallagher made the decision to accept him. We only had one patient on ECMO at the time, so we had some room. Now, I told Susan I could not guarantee her an outcome because I didn't know what the outcome was going to be. COVID was very unpredictable. We had 30-year-olds that didn't do so well, and we had 50-year-olds that did very well. We had patients that were on for a couple of weeks, and then patients that were on, at that time, 90 days was our longest successful COVID ECMO, so it could have been months. I mean, since then, we've surpassed that at 131 days for a successful COVID ECMO, but back then, who knew? So I told her it was unpredictable and that the road's gonna be long. And I knew from past experiences trying to transfer long-distance ECMO patients that there's gonna be many hurdles. Transport, in-hospital, rehab, many things. She said to me, I have to try. If it was your husband, would you try? Of course I would. So what do we do then? What were our next steps? We had to get him from South Florida to New England. Well, the team that we normally contract with, and we had to contract because we're limited by distance, our mobile ECMO team could only go maybe a little bit outside of Connecticut, but not very far. So we contract. And the team we normally use, they were unavailable. So who do we use now? This is where Susan did a lot of the legwork for me. We spent hours on the phone trying to figure this out. We wound up with innovative ECMO concepts. By the way, a shout out to Alex and his team. Very, very good job. Thank you, guys. This was our biggest hurdle, insurance authorization. If anybody's ever dealt with insurance companies for ECMO transports, now if you're a big transplant center, you probably just get the call, go out and get them, it's easy. But if you're contracting this out, you need insurance authorization for discharge, for acceptance at your hospital. But the biggest gorilla in the room is for transport. These are not everyday transports, and they need something called a single case agreement to do this, and it takes days to get authorization for this. So we were on the phone countless times, and I think insurance company called us at St. Francis 3 or 4 times over those 2 days. But we finally got it done, and maybe Susan is gonna wanna share later how we finally got it done, but we did. Now what about cannulation? We couldn't very well send Dr. Gallagher down there because Florida is a little squirrely about who they give privileges to for cannulation. You have to be medically licensed in the state of Florida. You have to be credentialed. You have to have hospital privileges, rules, guidelines, details. So we had to find a local physician willing to do this. And once again, between Susan and my friend Erin, we were able to get somebody to cannulate Robbie so that we can bring him up to us for ECMO. 3 days after Susan and I made contact, which wasn't so bad, Robbie finally got to us up in Connecticut, and a day later, she arrived right behind him. Now, she'd been driving for 1,300 miles, 2 days, and a pickup truck through New York City. So I'm from New York City, and this is really, really brave, and no small feat. But she got to us, and he was critically ill, and she was out of state in a place that she's never been before, and there was no guarantee that any of this would even work. What have I done? Was kind of her reaction. Well, what she did was, she never gave up, and the family never gave up, and they found him the help that he needed, a place willing to accept him. Let's talk a little bit about what we did, because now it was our turn. We got him here, so what do? We used the 2nd generation Centromag as our ECMO platform. We had the Seacrest blender, we used the Quadrax oxygenator, the Cincinnati Sub-Zero Blind Control 3 for a heater cooler. He was cannulated in the right IJ with a 21 French Biomedicus and the right femoral vein with a 25 French Biomedicus. Now this they had done in Florida. We recannulated him 2 weeks later with a Medtronic Crescent for mobility and physical therapy. They had given him 13,000 units of heparin bolus during cannulation, and we continued the infusion until we ran into a problem with bleeding from his tracheostomy, where we stopped it for about 10 days. Our PTT goal was 40 to 60, and then when we restarted, we actually restarted bivalve. Maybe Dr. Gallagher will touch on why we did that. We only had one oxygenator change out during that whole time. 22 days is how long he was on ECMO, which for us wasn't very long at that time. I mean, I was expecting a lot longer. This is a very first look at his chest x-ray. Now, we had not seen one yet, so we didn't know what to expect. I remember looking at this with Dr. Gallagher, and we're looking at each other going, that's not so bad. I mean, we've seen a lot worse for our COVID ECMO patients. And he's going to talk later about his chest x-ray progression, but we were going, okay. I know some of you in the back probably can't see this, so I'm going to do a quick run through our ECMO run. Now, we were on full ECMO support for about 6 days. We had a flow of about 4 to 4.5 liters per minute with FiO2 and 100% and a sweep between 3 and 4. Now, after about 6 days, his PO2s were over 100 and his CO2s were stable, so we decided let's try to wean. We didn't know how long it was going to take, but let's give it a shot. We performed the tracheostomy about 5 days into it, and the next day started a slow wean. We were able to quickly wean his FiO2, but the sweep, we took our time with that because in our experience, the COVID patients took a while for their lungs to be able to pick up that CO2 clearance. So we didn't want to push it. We took our time. We ran into problems with bleeding from the tracheostomy. We had to go back up on ECMO support. He needed a transfusion, a re-exploration. It took us about a week to figure that out. And this was not uncommon for our COVID ECMO patients. A lot of them bled from everywhere, chest tubes, trachs, wherever. So this was not unexpected, and I did warn Susan that we may have some complications. When we finally got that under control, we were able to start a wean again. But we still, once again, we took it slow. We wanted to make sure we had gone this far, they've come this far, that this was actually gonna work. Once again, we were able to wean him down to half a liter and 21%. And right before Labor Day, we decannulated. Now, a few days before that, he had been on pressure control ventilation on the vent, and we had switched him to CPAP, and he did very well. Eventually, he progressed to 40% trach mask. And that's where he went to the step-down unit, and that's where he went to rehab.
Do you have anything to say to your
No
wife?
audio.
Say it. Say it. Don't
I think for the next
lip
section,
it.
we can try that. So, I don't know if you can read his lips, but when he can talk, she took a video
All right,
and
we're
he
gonna
says,
take
I
a break
love
for
you.
today, okay? Good job.
On September 14th, Robbie was discharged from our facility
Do you have
to a
anything to
rehab
say to your
facility.
wife?
Like I said, on 40% treatment.
Say it. Say it.
29
Don't
days
don't
after
lip
that,
it.
he went home with no O2 requirement at all. He was a little hesitant about leaving us. He didn't want to go,
All right, we're gonna
but we
take a
said,
break for
it's
today,
time for Birdie
okay?
to fly.
Good job.
I'm going to turn this next one over to Dr. Gallagher.
Good morning. When Robbie got to us, we took obviously basic labs, and there wasn't anything particularly remarkable. His hematocrit was a little low, probably because he had just been cannulated and transported to us. He never really had much of an issue with regard to that, other than the time when he bled from his tracheostomy. The rest of his labs really were not that remarkable, and I think that was one of the things that makes a difference in the recovery of these patients, is that they don't go on to develop multi-organ system failure. His creatinine was about 1.5. It never got much above that, dropped down to fairly normal levels. His lactic acid was never elevated. He never had liver dysfunction. He did develop positive sputum cultures with gram-positive rods and gram-positive cocci, and he was treated for that, but it never really evolved into a full-blown pneumonia, and his liver functions were pretty normal. His echo really was unremarkable. He had good right and left ventricular function, no evidence of any kind of valvular abnormalities. And this is, I'm sure, really hard for you to see, so I'll sort of go through it. But basically, when he got to us after cannulation, he had reasonably good tidal volumes on relatively acceptable pressures. So his inspiratory pressure started out at around 20 with a PEEP of 10. Respiratory rate was 14 and an FiO2 of 60%. His peak pressure was 31, and his plateau was about 34. So a little bit on the high side, but still not bad. And I think the striking thing with these numbers really is the tidal volumes that he was able to generate at those inspiratory pressure volumes. And I think this speaks to the fact that his compliance was relatively good, even though his ability to exchange gases was not. And then he went on, as you can see through the course of his events. We switched him out to a crescent cannula after about 2 weeks with his standard cannulation with femoral venous drainage, and returned to the right IJ. The idea was that it makes him more mobile, and as he began to wake up and interact more, we thought we'd be able to mobilize him more. But he wasn't really on ECMO much for about a week after that. So he, in terms of the benefit from the switch out to the crescent, maybe not as optimal as it might have been. But ultimately, his course progressed quite quickly, and he was able to be decannulated. And as Angela mentioned, the chest X-ray when we first saw it was not nearly as bad as some of the ECMO patients, the COVID-related ECMO patients that we had. So we were impressed by the fact that he didn't have a complete whiteout of his lungs. And as you can see through this series of X-rays, he never really got any worse. He never developed overlying pneumonia on top of his underlying ARDS from COVID, and I think that goes along with the with the tidal volumes that he was able to achieve and the compliance that he demonstrated. Unfortunately, I don't have the actual CT scan to show you, but if you look at the bottom of this report, it says there was virtually complete opacification of the dependent portions of both lungs. And I think that's something that we see so often in these patients. And it's so disheartening to see in some of our COVID patients that they go on to develop complete opacification, and then they develop necrotic areas in their lungs and pneumatoceles. And you can see these develop. The lungs are whited out, and these kind of areas that are clearly, and they look like maybe the lung is starting to recover, but really what it is there's air that's trapped in a necrotic section of the lung, and that's just going to predispose the patient probably to a pneumothorax or other complications. He later underwent a cardiac catheterization during the course of his hospitalization for a rapid atrial rhythm and some ST segment changes, but his coronaries were normal. He really had a very stable, progressive course throughout his time with us, and we wish that most of our patients who went on ECMO progressed the way Robbie did throughout his course, so we were quite pleased. And the time on ECMO was relatively short compared to some of our other runs. He did have a small sacral pressure ulcer that developed, and then some pressure along the right ear where we had to secure his cannula. The main complication, as Angela had mentioned, was bleeding from the tracheostomy site that required ultimately removal of the trach, reintubation, and the packing of the tracheostomy site, and then ultimately going back to revise it and control whatever was bleeding, and then reinsert the trach. So that was really the main setback that he experienced, and probably his time on ECMO would have even been shorter had that not occurred. So what have we learned in treating COVID patients on ECMO? I think we've learned a lot, and I think there's a lot more to learn in general with COVID-related ARDS and ECMO in general. But with regard to COVID-related ARDS, who survives and who doesn't, ECMO does an amazing job sustaining the life of a patient with ARDS. I mean, we've kept patients alive for months, but it's ultimately the host response to the inflammatory cascade that determines survival. So we've kept patients on ECMO with pristine numbers, and ultimately if the lungs don't come back, they're not transplant candidates, you're at an impasse, and it's a very, very difficult situation. And the treatment options are not great. I mean, none of these really work very well. Steroids, remdesivir, convalescent plasma, monoclonal antibodies, surfactant, diuretics, none of these help. We have noticed that patients, they do have a basement membrane capillary leak that goes on for weeks and weeks. So if they get a little positive with their fluid balance, the lungs, the next day, you see the lungs are starting to get white again. You try and dry them out, the kidneys start to take a hit. So it's really a balance. So fluid management is important, but it's certainly not going to be what allows the patient to recover. This is not a fluid overload situation. And antibiotics for overriding infections obviously are important, but they don't really have an impact on the COVID-related portion of this. There have been demonstrated compliance phenotypes in early ARDS. Some of the patients demonstrated dissociation between the degree of hypoxemia and the compliance of their lungs, and I think that's what Robbie had demonstrated. And they've noted that that those who retain their compliance or regain their compliance relatively quickly have an improved survival. Lung protective strategies have been described, and these include plateau pressures less than or equal to 25, a respiratory rate between 5 and 10, PEEP somewhere between 10 and 15, an inspiratory pressure less than 15, and an FiO2 of 50%. And these, I think, are helpful, but I think one of the things we learned with regard to quote-unquote resting the lungs is that if you rest the lungs the way we thought of resting the ventricle when people are put on left ventricular assist devices, you lose ground, because if you go too low, if the inspiratory pressures are too low, if the PEEP is too low, what you find is the patient's lungs de-recruit, and when they de-recruit, it's sometimes very difficult to get the lung re-expanded again. So we would drop the ventilator settings and the inspiratory pressure down to minimal levels, and when we'd come back the next day, we'd find that the tidal volume was almost completely gone, and the lungs look whited out on chest X-ray. So we found that there needs to be a happy medium. You want to avoid the barotrauma that's related to high inspiratory pressures and high PEEP, but you don't want to go so low that you lose alveolar ventilation. So in the course of treating some of these patients, and as Angela mentioned, we had a lot of bleeding complications, no matter what we did: percutaneous tracheostomies, open tracheostomies, chest tube insertions by very experienced PAs that put in hundreds of chest tubes. Patients bled on ECMO. Was it specific to COVID? Was it specific to, or was it just in general on ECMO? But there's this phenomenon of acquired von Willebrand syndrome. And virtually every patient on ECMO seems to develop this acquired von Willebrand. It leads to profound platelet dysfunction, and the incidence of bleeding complications increases significantly. As I mentioned, trachs, chest tubes. We had just putting in a feeding tube. We had so many patients that ended up with nasal bleeding and ended up with ENT consults and nasal packing for days or weeks. So it's really a serious problem. In this study, there were 59 patients on VV ECMO, and they did light transmission aggregometry of the platelets and flow cytometric quantification of platelet granule secretion. And what they found is that all patients developed severe acquired von Willebrand syndrome within hours of initiating ECMO. So there were 60% of the patients were noted to have abnormal numbers within 3 hours, 86% in a day, and by the second day, virtually everyone had it. So in other words, you have platelets, you can measure a platelet number, but none of those platelets are working. And so these patients are really at risk for bleeding complications. So you have this, this dilemma of we need to anticoagulate them. So on top of this profound platelet dysfunction, you're either heparinizing them or putting them on other anticoagulants to try and maintain them on ECMO. The etiology of the acquired von Willebrands is caused by shear stress inside the ECMO circuit or the MCS device. So we see this in ventricular assist device patients as well, not just ECMO patients. And it's characterized by loss of high molecular weight multimers of the von Willebrand factor and decreased collagen binding to the von Willebrand factor. So the treatment options are relatively limited. You can give von Willebrand factor and factor VIII concentrates. You can use antifibrinolytics. It doesn't really affect the platelets so much, but what it does is it affects the breakdown of the clot that you do form. GDAVP doesn't really work very well in this situation. There's only a 10% response rate in ECMO patients. And other options such as plasmapheresis or gamma globulin don't work in ECMO patients. It works in acquired von Willebrands for other etiologies, but not for patients on ECMO. So just in terms of this concept of out-of-the-box strategies, a couple other things, and Angela, if she has time, may want to touch on these. A couple of things we've done with patients when we were really at wit's end in terms of what to do when we couldn't oxygenate them was go to a dual oxygenator. So I had a second oxygenator in line, which got us to the point where we were at survivable PO2s and and to the point where we could sustain that patient to the point where when they started to turn around, we could keep them, at a reasonable, PO2 and CO2 to keep them alive until they could recover. And then the second thing was adding a second venous cannula to drain the upper body. We had particularly one patient who we just couldn't get the flows. She had PO2s in the 40s. We had added nitric oxide to see if we could get, improved oxygenation through her lungs. And the idea was, if you think about what we do when we go on pump and we use bicable cannulas, and we're basically controlling all of the venous drainage, running it, as if we put cable tapes on and running it through the pump, and you can control all of the venous return. But in this situation, when we have a femoral venous cannula and we're returning through the IJ, we're not really draining the upper body. So we placed the subclavian cannula. We were able to get only a little bit over a liter from that, but it was enough to get us to a point where we could improve our flows and improve our oxygenation. And then as the patient started to improve, we were able to remove that cannula at a later point in time. So what have we learned? Well, we've learned to push the boundaries. We've learned to share our experiences at meetings such as this so we can really all learn and grow. We've learned that guidelines are just that, guidelines. They're not rules, they're guidelines, and that they're meant to be tested and pushed. And only those who risk going too far can possibly find out how far one can go. So now I'd like to invite Mrs. Walker up to give her thoughts on this experience that she and her husband went through.
This is Susan Walker, and you've heard enough about us, and now you're going to hear from her. But before we hear from her, the rehab facility that Robbie was in made this video after he was discharged, and we're going to try our best to get this going. Because I think if you don't have tissues, you may want to grab some.
Make sure it plays.
Play. Ready?
1 second. Okay, 1 second. There you go. All the way back.
Okay.
Are you ready? 1,
Yeah.
2, 3.
Hello, my name is Robert Walker. I'm here at Gaylord, and I'm here recovering from COVID. I was very active. I had my own business. We were either boating or doing things. We live on the water, so we were always a very active family. I had no underlying conditions or anything like that, so I had no reason to think that it would be anything.
Robbie contracted COVID in early July 2021, this past summer. We ended up at the ER for chest x-rays on the 17th, and he was admitted into the hospital with bilateral lung pneumonia. He ended up in ICU, and on the 25th he was intubated.
The last memory I have is calling my kids and my wife and telling them that I loved them. And to let them know that I had signed to get intubated. So I was hoping that I wasn't saying goodbye.
We were told on August 4th that he was not going to survive COVID. From there, desperately seeking out our options, we searched out hospitals that could provide a greater care of treatment for him, which was ECMO. We say 169. It was probably over 169, but that's kind of the final count that we have. After we've been denied by every hospital that we reached out to, my son-in-law happens to work for CNN. My daughter said, "Mom, go on CNN. Let's use that platform to tell them that we need ECMO." We did an interview, and it aired early that morning. Dr. Gallagher from St. Francis Hospital happened to see it around 2 o'clock that afternoon as he was just thumbing through social media. He reached out to his chief perfusionist. So Dr. Gallagher and Angela agreed to look at his records and see what he looked like as a patient, not as a formula. And thank God they did, because they agreed to take his case. So we went through the process of getting him transferred, and he was cannulated for ECMO in Florida and then airlifted by medical jet to Connecticut, where he then stayed at St. Francis Hospital for his ECMO treatment.
It saved my life totally. St. Francis took a chance on me as a person instead of a statistic, and then Gaylord is hopefully giving me my way of life back. And everything that I've done here so far has been great. The people are very caring, very attentive, very uplifting, but they push you. It feels that they genuinely care. I would definitely recommend Gaylord.
We knew that he was going to have to go into a rehabilitation, so we toured, and Gaylord was our top choice. Gaylord came highly recommended, both by Dr. Gallagher and by Angela and the staff at St. Francis. It's almost like you have your own personal physical therapist and your own personal occupational therapist, because you're not just a number. You know, they take their time, they explain things to you, they work well with you, they care. There's a lot of compassion. The doctors stop by the room. Unfortunately, Robbie was not vaccinated. Neither one of us were. We had talked about it, but we were not vaccinated.
From what I understand, if you're vaccinated, you may get sick, but you're not going to be like this. Again, I understand everybody has a choice, and I don't want to tell people they have to get vaccinated. My suggestion is that you do get vaccinated.
My hope is that we return to life as usual, that we find our new normal, and Robbie has the patience and the strength just to get better, and we just live our life together. There's just so much that we need to be thankful for in the moment, and that's what we're going to do.
It's beyond miraculous. She's my hero. You know, she started this whole process, and then other people stepped in and helped with it.
Clicking. I'm clicking. Keep clicking.
Bottom right. There we go.
Good morning. It's a true honor and privilege to be here. I'm probably going to repeat a lot of what was just displayed in today's presentation, because I wrote my story without seeing everything come together. So I apologize. As Angela and Dr. Gallagher just mentioned, my husband was hospitalized and intubated in Central Florida Hospital for bilateral COVID lung pneumonia. Robbie was isolated for 2 weeks with only one 30-minute visit per day. As his days in isolation continued, panic and anxiety set in. He was fearful. he would not make it out alive. When Robbie was first intubated on July 25th, he was told that by being intubated, it would give his body relief so he could heal. He was not intubated out of emergent necessity at the time. So he signed the papers and agreed to be intubated. He called me that morning, right before, and told me what he was going to do. I begged him not to, but by the time I got to the hospital, the procedure was already underway. The hospital was at full capacity, and doctors rounded before visiting hours, so it made communicating with them very difficult. I kept a journal from the very beginning, and I logged on to Robbie's medical portal multiple times a day and began learning what tests they were performing, why and when, how often, medicines he was receiving, his stats, what was good, what was bad. I had an ICU nurse friend in South Florida that would guide me in what they were doing in their facility for their COVID patients. Proning, ivermectin, daily ABGs, testing, and so on. I would Google other treatments and ask doctors about medicines they've not yet prescribed. And I was quickly becoming Robbie's advocate, his voice. As the 9 days went on, being intubated, Robbie stayed primarily stable. I was told multiple times by doctors and staff that the plan was to have Robbie trached by week's end and then transferred to a long-term acute care facility for weaning purposes. They suggested I become proactive and take steps to make sure that he had a place to go when the time was ready. So I did. But on day 11 of being intubated, I was told Robbie had irreversible lung damage and that he would not survive COVID. Just 2 days prior, he was stable, and I had visited and decided on an acute care facility in Gainesville, Florida, to send him for trach weaning. As you can imagine, instant devastation. I could only think to myself, how could this be? What was I missing? What were they missing? Outside of COVID, he was a 50-year-old man. As he laid there and for the past 19 days, he actually looked good. His skin color was good. He was urinating and defecating on his own. He was not on any diuretics, not having any signs of cardiac issues, no liver failure, no kidney issues. He had one failing organ, his lungs. So still confused by the news, I asked about a lung transplant. I was told he wouldn't survive the wait list and that he would need to qualify for a treatment called ECMO, and that unfortunately he didn't fit the criteria for ECMO. But furthermore, they didn't offer it. So I asked if we could transfer him to a facility that did offer ECMO. The chief intensivist that day told me he was too unstable to transport. I felt defeated. If you've ever lost someone you love, then you know how helpless it feels when someone you rely on tells you that they have exhausted all treatments for your survival and that the journey is over. It ends here. Well, not for us. At least not yet. I relocated to a hotel room close to the hospital Robbie was in from the time he was intubated, so that I had easy access to him, so if the ICU desk didn't answer the desk phone or a doctor didn't return my call in 8 hours, I would go to the hospital and get my answers. The morning after we were told to make other plans for Robbie, I woke up and decided to turn my hotel room into a makeshift call center. And families and friends gathered around, and we called over 160 hospitals in the state of Florida and surrounding the neighboring states. Once we exhausted all the hospitals in Florida that offered ECMO, we did find about a dozen beds that would look at Robbie's case, but everyone denied him. I was told first it was because he was intubated too long, and second, it was his age. 14 days intubated and the stars started to align. As you heard, my son-in-law works for CNN, and he made a phone call to one of the writers asking if they would take our story. I offered up an interview of to why me and Robbie were not vaccinated, and we would speak out and encourage people to be vaccinated. When Robbie called me to tell me he was being intubated, he begged me to go and get vaccinated and told me how regretful he was of not leading our family that way. So the next day I did. I was vaccinated. I went on CNN on August 8th to explain why we were not vaccinated and to plead for a doctor to help my husband that was lying there helplessly. I guess I'm supposed to be clicking these pictures too. 2 p.m. that day, I was contacted through social media by a colleague of Angela's that there was a possibility of an available bed and treatment for ECMO. There was hope. Dr. Gallagher reviewed my husband's records and accepted him. 16 days intubated. If Dr. Gallagher and Angela would have seen him as a formula and not outside of the parameters that were against him, Robbie's life would have been over. Robbie joins me today in the back of the room, standing in the yellow shirt. Ecstatic over the news, I raced to the hospital for my visiting hour to make sure that hospital that Robbie was in was communicating with the hospital that Robbie was going to be transferred to, St. Francis Hospital in Hartford, Connecticut. As I entered the ICU wing with an attitude of celebration, I could instantly feel the tension toward me from the hospital's doctors and staff. I was immediately approached by the chief intensivist with frustration and discouragement of my fight to have my husband transferred and have him treated with ECMO. It was obvious she had already heard the news of my national interview, and she had also heard from Dr. Gallagher and Angela's willingness to try and give Robbie a chance. She continued to tell me he was most likely going to die in transit and that I really didn't want to do this. I really couldn't understand at the time why they too were not excited for us, and it still surprises me that they actually tried to talk me out of fighting for my husband. I personally couldn't just sit there and watch him slowly start to shut down. In my mind, why not give him a fighting chance and let him die trying than to not try at all? It took 3 additional days from that point to organize insurance for transfer, force ECMO cannulation at the hospital he was in so he could survive the flight, and arrange the medical air flight and medical air staff. Angela warned me on Sunday that the next 24 to 48 hours were going to take persistence. But little did I know my biggest fight and pushback would be from the hospital that he was in to help me get him cannulated so he could be flown to the hospital for his possible life-saving treatment. Their stance with me at the time was because they did not offer ECMO, they did not have a cardiac surgeon that was able to cannulate Robbie. Well, that led me into sitting at the bottom of the stairs of administration for hours until a hospital staff came down to talk to me about their hospital ethics and humanity. I wanted answers as to how they were going to help me get my husband cannulated instead of blocking Robbie from getting the help he has been offered and deserved. The administrator, the CEO, spent some time listening to me, and I was told that she understood our position and would make some contacts and see what they could do. In the meantime, and still desperate and no time to spare, I contacted a head doctor from another hospital who could not believe the fight that we were in. He agreed to cannulate Robbie and stabilize him in order to transfer him to the facility that has already accepted him. So I again raced back to the hospital in high hopes that we could resolve this, and suggested we bring in a doctor in from another hospital that was local. They took the position that the hospital board would not allow an outside doctor to come in and cannulate without state-approved emergency privileges for liability reasons. The outside doctor I had contacted was furious and even attempted a phone conference with me with the hospital's administration. He even went as far to tell them that we could discharge Robbie in ICU and that they would cannulate him bedside and transfer him to the airport to have him flown out to St. Francis, where Dr. Gallagher and Angela were eagerly awaiting him. I am an ordinary person, and this fight should not have been this hard. I was just a wife who didn't want her husband to die. I can only imagine how many other families out there lost loved ones because of a set criteria. I was fighting insurance to expedite transferring and arrange for medical flight approval, at the same time calling meetings with CEO and higher staff officials at the hospital he was in because they did not have a house doctor that was willing to cannulate for ECMO, but nor would they allow a doctor to come in from the outside that was willing. We missed 2 insurance-approved flight opportunities during those 3 days because we couldn't get everything aligned. 17 days at Robbie's bedside, 4 p.m., a doctor from the hospital walked in and told me they found a doctor that would cannulate my husband if I could arrange for him to be transferred the next day. So with no time to spare, I couldn't rely on the insurance to approve the flight. I had already contacted and spoke to several transport companies when Angela and I first spoke. With no time to risk, I called Innovative ECMO Air Team, and within 60 minutes, he was scheduled for transport. The flight was $92,000 out of pocket. Robbie and I had just cashed in our IRAs, ironically, a week before he got sick. 18 days intubated, and by the grace of God, Robbie was cannulated for ECMO, transferred by ambulance to a local airport, and medically flown to St. Francis Hospital in Hartford, Connecticut to begin treatment. Despite the criteria odds of my husband receiving ECMO, Dr. Gallagher and Angela took a chance and saved Robbie's life. Robbie did not need a lung transplant after all and returned home 3 months after contracting COVID. His pulmonary function in December of last year was 46%, and today he has improved to 66%. He continues to improve every day. He is not on any oxygen and was weaned from prescribed metoprolol 2 weeks ago. He has been released from doctor's care and will return annually for checkups. He is not taking any medications at this time. We are forever grateful for the efforts of everyone involved to help save Robbie's life, but especially to Dr. Gallagher and Angela for thinking outside the box. Thank you. Thank you. Just finish this off. This is Robbie and I in our makeshift gym that we created in our garage. Us having a little fun after we got home. This was around Thanksgiving, having a family game night. Robbie and I love to airboat. We were able to take the airboat out for the first time last month and enjoy some Florida sunshine. I got my husband to spend Christmas with me again. And we just thank you from the bottom of our hearts.
Thank you so much for sharing that. That just makes all of us feel so good about what it is we do to see these amazing outcomes. What an inspiration, and what an awesome team that you are to be able to pull this off. So thank you. And you look amazing, Robbie. You look absolutely wonderful. So awesome. So we're going to take a 10-minute break. Don't forget, if you don't have sunglasses, go to our perfusion.com booth, grab them. We're going to come back here, meet in 10 minutes, and then after this session, we're going to go poolside for our lunch and for the Quest Shark Tank Thank you.
this month, and for the first time ever, wind produced more American electricity than coal or nuclear, and was second only to natural gas. On the coast. Now has 1,000.
Welcome back from the break, everybody. Sorry about some technical difficulties up here, but knowing Candace the way she is, she'll be able to wing those and make it a really useful talk. Candace McAdams is a mental health coach with Lyra Health, a leading mental health care benefits company. She's also the CEO of the Soulful Journey, which is her personal coaching company dedicated to serving healthcare workers and those struggling with compassion fatigue, which we'll hear a lot of here. And I have been affected by it, and I'm sure many of you had as well. She has a deep passion for exploring what makes us human and helping others live a more empowered and inspiring life. She is a graduate of New York University and a certified ICF coach with extensive training in evidence-based practices in cognitive behavior. My commentary, my goodness, how us healthcare workers have been through the ringer over the past few years with the pandemic, initially by taking care of patients We risked our own lives and the lives of our families from a virus the likes of which, as a scientific community, we were unsure of. Some clinicians lost their lives, while many others, even now, suffer the long-term physical effects of this damn thing, as in long hauler syndrome. Medical personnel were often called heroes and thanked by the public for our sacrifices. Then, we, as healthcare workers, were then trapped in the politicization of the virus with vaccine and mask mandates, while often vilified by the public in doing what we thought was right for our own lives and those of our patients. Few individuals outside of medicine can truly understand what we healthcare workers have gone through caring for our patients while so often watching once viable human beings of all ages waste away and succumb to the disease, despite our best efforts for the changing science as we know it at the time. There's no doubt in my mind that many of us continue to carry that trauma in our everyday lives. There's Candace McAdams spoke last year at our virtual Sanibel meeting, and we have invited her to reconnect and help us with coping skills to understand what we have all gone through and how, if unchecked, we may still be affected in our lives going forward. So before I bring Candace up, I just wanted to announce that Candace McAdams has graciously offered to meet with individuals one-on-one for 25-minute private consultations at specific hours that are out at the registration desk for the next 2 days or so. Now, PDC is offering the first 10 people to sign up a free 25-minute session, and after that, she has also graciously then, after 10 people, everybody else will still get a discounted rate of, I think, $35 for the 25 minutes, which is incredible for her. So she has a bunch of times out at the registration desk. You can put your name down, first 10 free, private consultation. We have a room set up, all that kind of thing, and it's really, she's remarkable. That's all I can say right now. I've known her for years, and so respect her wisdom, intuition, and comforting ways. I would encourage anyone to take advantage of these sessions if anything in your life is out of kilter, or you want a stepping stone toward a balanced inner peace. You can sign up at the front registration desk. Now, her talk is entitled "The Impact and Urgency of Prioritizing the Mental Health and Well-Being of Perfusionists." My lovely friend, Candace McAdams.
Hi, everyone. Thank you, William, for that beautiful introduction. William is a very good friend that I've known for many years. And I thank all of you for this opportunity to share. It's an incredible honor. I feel a true sense of purpose and growing passion to be able to share my knowledge of mental health today, especially with this community. I look forward to continuing the conversation around healing an industry that gravely needs our help and attention. But first, I want to start off with one of the most powerful forms of healing, and that's storytelling. Every one of us has a story, and many of the stories you're about to see are ones that may not look that different to ones you've experienced in your profession from time to time, especially in the past 2 years. I believe in film, and I believe it has the power to mirror back to us cracks in our own foundations and create a sense of empathy in our human experience. I also believe sharing and listening to stories creates powerful waves of change. So without further ado, I'd like to share a few highlights I put together from the film First Wave, directed by Matt Heineman.
The melting is expected to continue almost everywhere for the rest of the century, but scientists are especially concerned about the water.
That's not me. Okay, there we go.
And the ice shelves that are located in Antarctica, if that would melt, then we would put it into the ocean. The sea level would rise about 58 meters.
Okay, just 1 second, guys. I think we have a browser issue. Hold on. There we go. I'll go ahead and close it. There we are. Okay, just technical glitches. Here we go. Here we go. Just give me a second. There we go. Let's pull it back up. Okay. Take 2, as they say in film.
Every day, we look death right in its eye. And the scary part is it looks right back at you. It's a storm that nobody's ever been in before. There's no playbook for this. There are no directions.
I'm curious how you guys are feeling. Well, we're all pretty new to LIJ.
and they sent us to the floors to help out at first. And then we started doing the eye test. I don't want to get emotional because it's actually been hard, because to see the families upset.
When you're the only one there while their family's on video chat and they're crying because they can't hold their hands, you're trying your best to like accommodate for them not being able to be there, and like you become their family member. And I feel like it's like I'm losing my family members through the phone. So like that builds up with you.
He was the only one. Like, I kept looking at him, and I just, every time I look at him, I see those little kids, and I just, like, I needed him to do well. He said, I'm so young, and I have a young family. Please don't let me die. He's two little kids, like I do. And so I just wanted to see him do well. I don't know. Every day we go home and I think about how I might be bringing this home to my own husband and how that could have been him. And so I just wanted to see him do well.
So you guys are calling it?
What time is it?
7:03.
This one? Okay.
Oh my God.
Can you just have a quick moment of silence before everyone leaves?
Oh, this is so. I saw him this morning.
That's what everyone says. They were
Like
fine this
I
morning.
would just, we just, because he saw me, it's like, what are you doing? He was,
It's crazy.
I'm sorry to tell you this, but we've tried multiple rounds of CPR, and we were unable to bring him back. It's just been a long ass day. Just so fucking long. It's just, you hear it in their voices, but you have no sense of reassurance for these people. I can't give that to them. Like, it's just, I'm so used to saying, oh, this is what tends to happen. But every moment it's like, you don't know, you thought they were fine. You call their daughter like, oh, he's relatively stable, and then you get a call like, oh shit, like, he's dead. It's like you're always on edge. You can never have a sigh of relief. And if I feel like this, you just think of the family, you can't see them. You can't hear them. Like, half of these people, we don't even have fucking phone chargers. There's not even, all these people, they have their phones, the shit's dead. No one has a phone charger for them. If you try, people don't want to get cross-contaminated. You're so fucking isolated. I'm sorry, I'm supposed to curse, I'm sorry. But it's just like, what am I supposed to do? So it's just like, you just feel so helpless. And like, it's so nice, yes, people say thank you, you're saving lives. Before I felt like I was saving lives. Before you felt like, okay, this person had a heart attack, you give them the medicine, there's a good shot for them. But here, it's like you got nothing. You just hope and pray that shit doesn't happen to you. Every day, it's like, it's so ridiculous. It's just every day. I'm sorry. It's every day.
This is a character test for us individually. It's a character test for us collectively as a society. What did you do at that moment when all around you lost their head?
Some powerful stuff. What you as a community have been through has been terrifying, horrific, and traumatic. Yet many of you in this room, especially in the past several years, have had to normalize the realities in order to cope. We live in a keep it moving culture, as they say. So right now, I'm gonna stop that, and I'm gonna ask us to have one of our first tools that we'll be exploring today, a mindful moment. So I'm just gonna invite you all, you can close your eyes or not, just to do a little check-in. And I want you to really start to relax your body and just start to check in and see what you're noticing. Did any of this resonate for anybody in this room? Did you see yourself in any of these experiences? A friend, a colleague? How does it feel to know that this has happened or is happening in your community every day? What does that bring up for you? How do you feel? Just check in. I'm going to give you a moment. Give yourself that moment. Does it bring up any thoughts? Is there a more helpful thought right now that can help you to continue this presentation today as we start to explore some of the realities, some of the traumas, and we move towards a solution? Reach for that thought. And let's keep going. For 2 years, you both have been, for 2 years, you as a culture have been, like I said, forced to keep it moving. It's important that we take time out, even if it's what we just did, 2 minutes, in order to check in with our own spirit and ask what it needs. In a culture where the paradigm is I am fine, I am here as a mental health coach to challenge that notion. The industry is not fine. It's actually in serious trouble. In fact, I would even dare to say critical condition. So today, my aim is to spread awareness about current mental health challenges in healthcare, put a spotlight on mental health issues that might be behind these shifts, educate you on the potential threats to your own well-being and what to do about them, inspire you to demand support before it's too late, support you in creating a practice of self-care, tools that can expand your well-being, and yes, I will leave you with hope for a brighter future. I know that was some heavy stuff. But here's the reality, and I want to speak to it first. Over 500,000 and counting health workers have left since 2020, in 2 years. We're talking brilliant, talented, incredible human beings that have dedicated their lives to their work. But this is not a new problem. Prior to the pandemic, 48% of clinicians were planning to leave their careers due to overwhelm, burnout, pessimism of the future, and 49% would not recommend it to their own children. Now, where is this all going? This year, a new study was released. It said 75% of healthcare workers are predicted to leave the healthcare industry by 2025. That's 3 years. Oh, These are some pretty big numbers, guys. Why is that? Well, we have the normal stressors that we had prior to COVID, and now we're just adding to the plate. Ongoing trauma that's not getting processed, PTSD, moral injury, vaccine mandates, short staffing, burnout, compassion fatigue, which we talked about last year, putting your loved ones and your own life at risk, and much, much more. Like I said, like it is in this picture, it's like pushing a rock up a mountain, just not sustainable. So I want to put a few of these issues in the spotlight today, one being moral injury, which some of you may or may not know about, vaccines that are creating mistrust and apathy, and unresolved trauma, which is the big one we really need to focus on. First, I want to talk about the idea of what we're gathering to do. We're gathering to understand and to accept. A lot of my clients come to me, one of the principles we work on is acceptance as a way to cope with the realities of life. And a lot of people think acceptance is just accepting our reality as it is. It's actually the first step in order to recover. I always like to use the analogy of having a house fire. If we stand and we look at the house fire, it's going to grow into a bigger problem if we're not in the acceptance of it. But the moment we accept, we go out, we make sure that our families are okay, safe and protected, our pets, and we call 911 and we start to do something about it. So that's what I'm really asking for today, is that we move towards acceptance. I want to talk to you a little bit about moral injury as our first step. Moral injury is the damage done to one's conscience or moral compass when the person perpetrates, witnesses, or fails to prevent acts that transgress one's own moral beliefs, values, or ethical codes of conduct. It's a disruption in individuals' confidence and expectations about one's own or others' motivation. Now, this community many times has been compared to the Vietnam War. It was not properly equipped to fight COVID, just as those men were not properly equipped to fight in Vietnam. What is the problem with moral injury over time? Moral injury can take the life of those suffering from it, metaphorically and literally. I remember once being on a ride in Tennessee, and my driver was from Vietnam, and he had a cap on. And so I sort of leaned in. I always like to ask vets their stories. But this man had a very particularly harrowing story. When he was in Vietnam, he was faced with a choice. There was a 5-year-old child holding a grenade on the opposite end and his platoon behind him. He had to make the terrible split-second decision to shoot this child or lose his entire platoon. That man lost something that day. As he described it, he said, "I'm here, but I'm just existing. I left my life that day in Vietnam." Many times, there have been these decisions during COVID where somebody had to take a life and say, "I'm not sure that this person's going to survive, and so I'm going to have to put a ventilator on somebody else." These are very difficult decisions, and over time, really, really hard to process. It leaves one feeling with a powerlessness, like there's no one to turn to. How do you go home and tell your wife this? And one often feels guilt and shame, even if they're not connected to it, because they don't believe anybody would understand, especially their normal support system. It can lead to serious emotional distress, depression, and suicide if left untreated. Moral injury, in summary, debilitates people and prevents them from living a normal, healthy life. So what is trauma? Many of you in this room know what trauma is. On a basic level, it's a deeply distressing or disturbing experience. But then we get to unresolved trauma. Oops, sorry. Those are nightmares that get scarred into your mind, body, and soul. Something that can hide in us and suddenly appear just long enough to mess us up. Something that changes the footprint of our life. Something painful, devastating, disappointing that changes your life forever. Or a catastrophic event that hijacks your brain. It's a deep imprint on your soul. Prior to COVID, you may have felt this with some patient. It could have been a patient that was a young child, some parents that lost a young child, or somebody you just had that connection with. But during COVID, this has been amplified again and again and again with no end in sight. So that develops into some very serious issues: complex trauma and PTSD. Often, complex trauma happens repeatedly, and the effects are cumulative. So the traumatic experience transpires within a particular time frame, within a specific setting, which is COVID. And we've talked a lot about PTSD in the public, which I think is a really good thing, because a lot of people are starting to have flashbacks. And I really want to note about post-traumatic stress disorder is it can happen at any time. So even if you feel that you are fine, you may not be. And so it's really important that we look out and process our feelings, or at least check in with ourselves. Oops. Trauma is personal. It does not disappear if it is not validated. When it is ignored or invalidated, the silent screams continually internally heard only by the one held captive. When someone enters the pain and hears the screams, healing can then begin. So I just want to make a point that we cannot just keep it moving anymore. We really have to check in with these experiences. Emotions are like very good friends. What would happen if your best friend showed up at the door and said, "I'm not okay"? Well, of course, you would invite them in, you would process with them, you'd make sure they feel better before they leave, right? Well, that's exactly how emotions are. They require our attention, they demand it. And in fact, if we don't listen to it, they will make sure that we do. By breaking down, it could be our bodies, it could be into a mental illness, and for some, if they're not careful, it can be very dire consequences. I want you to kind of put it in perspective. Think of if that friend were to show up at your door and said, "Hey, I just got a divorce, I'm devastated, I need some help." And you just said, "Well, listen, I have something else to do, I'm so sorry, I'll get back to you," and then you just ignored them for 2 years. What would happen to that friendship? Avoidance just creates disconnection. And when I say disconnection, it's the connection to our vital resources. Because when we start to drop in and lean into these feelings, we start to feel more connected to ourselves and we find a path forward. We are actually incredibly resilient, and all of you in this room know all about resilience because you've been that way your whole life. But the avoidance starts to disconnect. The same is true in relationships. If your partner has agreed and promised to wash those dishes and they don't wash the dishes, what happens? We start to feel disconnected from them. It's a promise. Or if you don't email your boss back after a month, what would happen to your job? It's important to remember these things. And here's why. I'm going to go through, over time, what starts to happen with unresolved trauma. You could have anxiety or panic attacks in seemingly normal situations. Flashbacks, nightmares, and body memories regarding the traumatic event. Addiction and eating disorders are all born with unresolved trauma in an attempt to escape or numb negative emotions. We have sleeping issues, including trouble going to sleep or staying asleep, suffering from feelings of detachment or feeling dead inside. Disassociation as a real disconnect in situations and conversations. A constant feeling of feeling on guard, just like you saw the doctor. uncontrollable anger and acting on it out of nowhere, not being able to tolerate conflicts, unexplained irrational fears of people, places, things, feeling of shame, suffering from chronic or ongoing depression. I mean, the list goes on, and it can even lead to taking your own life. It's that serious. Then we have the wonderful vaccine mandates, and I won't go too much into it. There's two sides of the coin, and they're both to be understood, recognized, and held the space for. But the problem is that many healthcare workers, doesn't matter which side of the coin you're on, felt a sense of betrayal. It could either be from their patients to do so. So I'd encourage you to spread awareness with your colleagues about new laws, because knowledge is your power. Encourage your organization to do something. A lot of new organizations are hiring a chief well-being officer to oversee mental health programs. And if right now, like I said, you or somebody you need needs help, hire a therapist or coach, or encourage others to do the same. As I say here, you may not be fine today, but together in the future, you can be. Can you play? Sorry.
I'm talking to you, telling you that you're losing a loved one.
We have the potential to lose an entire generation of healthcare workers. And I think we'll continue to see the long tail of trauma that's apparent, trauma that's deeply buried inside of us, trauma that we want to acknowledge, trauma that we don't want to acknowledge.
We kind of have to just keep going, even though we're struggling mentally with a lot of the things that we've gone through in the past. And it's kind of hard to like get over trauma when you're like day to day still in the trenches.
It's very easy when we get through these things to say, okay, we're all better now. And the people who actually were the most vulnerable and or putting their lives on the line, we just sort of assume that they're okay too.
There's absolutely no question that they've all been changed forever. We've all been changed forever. But what they went through, what they saw, the magnitude of the death that they witnessed day in, day out, especially in New York, especially during the first wave.
We go to work and some of us suffer from depression. We go to work and some of us have anxiety that we're going through. The focus doesn't necessarily have to be redirected per se, but can we just get a wider lens? Can we get a bigger picture?
During this pandemic, it's not just a job. It's our passion, and this is like our service.
We struggle too. We really do have to amplify the voices of healthcare workers, because we're not the majority. And a lot of us have left the field. Right to the CEOs, the CMOs, right to how can we make this hospital better? By investing in the human workforce. That's doable. It's not asking much. But those are the steps to make ultimate culture change, because it needs to be a culture change, not just a policy too.
These healthcare workers put their lives on the line, but they ultimately are human. They're fragile, they break too. What makes them heroes is that they keep going. They get back up and do it again. And I think it's easy to forget about what they've gone through in all of this.
Great. And I would like to add to that a quote by Mr. Rogers that says, anything that is human is mentionable. And when anything that is mentionable can be more manageable. And when we talk about our feelings, they become less overwhelming, less upsetting, and less scary. The people we trust with that important talk can help us know we are not alone. So, change begins with you. And I'm going to give you a couple of tools to take away today where we can start to zoom in on our own experience and never underestimate the power of you taking good care of yourself and the waves of change that that can also create. I want to talk about mindfulness for a moment. What is mindfulness? It's a mental state achieved by focusing one's awareness on the present moment, while calmly acknowledging and accepting one's feelings, thoughts, and bodily sensations just as they are. It's very important as we have these daily stressors for anybody on the planet, but especially you, to take a moment to just allow yourself to be, just like we did in the beginning of the presentation. Just connect to what you're feeling, and that creates consciousness and awareness. The other thing that I will mention is if any of you want a good book, it's called The Body Knows a Score. It is a book on trauma and how to heal it and how to do that through connecting to the body. And this man wrote, mindfulness not only makes it possible to survey our internal landscape with compassion and curiosity, but also actively steers us in the right direction for self-care. It also increases emotional regulation, decreased depression, better memory, cognitive improvements, stronger relationships, better physical health, less emotional reactivity, deeper sleep, better quality of life, and much, much more. Now we're seeing the curve go back up. In other words, mindfulness is being here now. I love children and I love little babies, and you just see them. They allow their feelings. They laugh, they giggle, they cry, they burp. They do whatever it is that needs to happen, and they just allow for their own experience. I think there are teachers. It's important to remember that you are a human being. We get so caught up in the do, I have to do, the next thing I need to do. Just spend 10 minutes being. A lot of people think mindfulness is sitting in a very uncomfortable posture for 10 minutes. No, on the contrary, it's just be in your experience. Notice when you're pulled somewhere else, and just come back to the moment. Also notice which time zone you're on. Anxiety lives, by the way, in the future or the past. It does not live in the present moment. I want you to just stop for 1 second and just notice what's good about this moment. Just take a deep breath. Everything's fine right here, right now. The mind does not like suffering. And so what it does is it likes to do anything it can to protect you from that experience. But actually, suffering can be good for us, believe it or not. It's where we learn our most important lessons. So don't let the mind rob you of that potential. Just be here now. Also, it's important to connect to our thoughts and notice what they're doing. Sometimes, especially with moral injury, there's a lot of negative self-talk. And I always tell clients, how can we rewrite the story? How can we reframe that thought into something that's going to be more useful and helpful? And then you got to just let the rest go. It's important to take time to take care of your body. This is obvious: exercise, sleep, diet. But also just to listen to the body, because the body is a messenger. So if you're feeling tension in your body, close your eyes and ask your body what it's trying to tell you. I do it all the time with my clients. Where is your stress? Oh, it's in my neck. Lean into that. What is it trying to tell you? You'd be surprised at the answers you will get. Maybe there's just something you have to take off your plate. Stress is an emotion that simply says, maybe there's another way to do this. And by connecting to the body, you start to remember that. Once you start approaching the body with a curiosity. I love curiosity. Curiosity is a friendly energy. It really is a great combatant to fear. What's going on? And just ask and allow those answers to come. That's what creates the shifts. Also connect with nature. It's really, really important that we get out. I love the lessons. Right now I'm staying up in the mountains, and the trees are still kind of bare, and there's still snow up there, and every day I see little buds of coming in, and I'm just reminded that life is always in perpetual change. It's the only constant in our life. So when we're going through a tough time, connecting to nature can give us all those reminders that, yes, it may be bare right now. Yes, I may not feel whole, but spring is coming. So get out there and connect. This is a big one and has helped all of my clients during COVID, but it's under the acceptance umbrella. Just make a list, decide what is in my control and what isn't. The list is always longer of what you can control. Guess what? 99% of life we can control, including situations, people, and what happens to us. But our response is the one thing we always get to control. It is always ours. And that is such a gift and such a blessing. And it always brings us peace when we get back to our own solution. Anxiety, when I ask people where their anxiety, where their thoughts are coming from, it's always in the future or it's things they can't control. So when we're feeling anxious, just remember, again, we got to get back to the moment and we've got to let go of all those things we can't control. I also really believe in the power of values. They are very, very, very strong anchors that help us navigate really powerful storms. Underneath, there is always something that is core and central to your being. And if you're feeling lost in a moment, connect to your values. I do this work a lot with my clients, and I think it's very, very powerful in grounding us in times of turbulence. Also with depression, what we've noticed is when we connect people with something larger than their own experience, they start to feel better. So even if it's just going out and looking at the stars or volunteering in some other capacity outside of the work you do, helping a friend move, do something bigger than your own life, and it will start to reconnect you to the human experience. And really important is visualizing yourself at peace. Visualization has a lot of power. Even if you're not in a good moment, as I said before, I may not be fine today, but I will be. And it's important to live this mantra when you're going through difficult times. And to imagine yourself. Imagine yourself in other moments where you were okay and you got through difficult times. And I always like to say, as an analogy for my clients who always ask me what coaching experience is all about, that as a coach, I really believe that you are the sun behind the clouds. You are powerful, resourceful, resilient. And the clouds are just experiences that are coming in, moving in. And sometimes we can say to ourselves, well, that is just not, it's not a sunny day, it's a terrible day. But just remembering that you're still in there and that these clouds will move, they will change, they will shift. And we will get back to when we come home to ourselves, we know that and we feel powerful again. In closing, I would just like to share a poem I call The Hope by Ellen Bass. The hope. To love life, to love it even when you have no stomach for it, and everything you've held dear crumbles like burnt paper in your hands, your throat filled to the silt of it. When grief sits with you, its tropical heat thickening the air heavy as water, more fit for gills than lungs. When grief waits you like your own flesh, only more of it, an obesity of grief, you think, how can a body withstand this? Then you hold life like a face between your palms, a plain face, no charming smile, no violet eyes, but you say, yes, I will take you, and I will love you again. We all suffer. Suffering is where we get the gold. We might have to mine for it years later, but there's something in there waiting for us. There's nothing to be afraid of in our suffering because we never know what that's going to mean to our life later on. The importance is to lean into it, to accept it, to move towards solutions and to a better day. I think some of the bravest people I've ever known have been through the most suffering. But in the end, it's your response to that suffering that matters. And we already know what your response has been to suffering. And you have always been heroic in your response to the suffering of others. The healthcare industry is chock full of heroes. And you're still our heroes, and we need you. For now, we need you to be heroes to yourself and your community while there's still time. Thank you so much for today. I really appreciate it.
Short people. Thank you, Candace. That was wonderful. If anyone is interested, which I'm sure a lot of you are, in having some one-on-one with Candace, please go out to the registration desk where we have sign up. Remember, the first 10 people that sign up, PDC is picking up the fee. After that, there is a small fee that you can discuss with Candace. So everyone get their sunglasses on. Let's go outside. Lunch is ready. And for those of you at home, we will resume back here at 2 p.m. Thank you. testing.
Truthfully,
Was that on YouTube?
Well, we respect the people who are here,
Absolutely. No, I agree, but I was going to just have them round it up. All right, you ready? Let's do it. All right. All right. Welcome back to our Emerging Technology session. I'm your moderator, Carla Mall. Our next speaker is the use of ECMO during the coronavirus pandemic, lessons learned from a multi-institutional database of 670 patients. Our next speaker really doesn't need an introduction. He was the president when I was president-elect of EMSECT, and so I had large shoes to follow. So without further ado, Al Stammers.
Wonderful. Thank you. Oh, no, you don't have to do that. Thank you so much, Carla. And I'd like to thank Carla, Susan, the entire organizing committee for this meeting. But most of all, the people who are here. You either forgot your sunblock and didn't want to be at the pool, or you're actually here trying to listen to the speakers that follow me, who are going to present some very interesting information. But what I'm going to do for the next 25 or 30 minutes or so, we'll go over the use of registry data in regards to what went on during the COVID pandemic, with specifics looking at COVID patients who were placed on ECMO, which are very challenging, as we've heard this morning, of course, with the Walker story and all throughout the meeting. Just a couple of goals that we're going to go after today. We're going to review some of the aspects of the management of these difficult patients and the associated challenges that occur once they're on ECMO. We all know the disease processes associated with COVID are different than we've been really exposed to for most of our careers. We're going to look at what occurred over the 24 months, and as I mentioned, look at registry data. When you start talking about ECMO, a lot of this is experiential. It's something that we basically learn. There's so many courses that are out there. I worked at the University of Michigan with Dr. Bartlett back in the 80s and had an opportunity to train with him and learn. But even then, we really didn't know a lot of what was going on. And I think Pete Seeger, those are folkies in the audience right now, probably have heard some of his songs. But, he really said it best, is like education is when you read the fine print, and experience is what you do when you don't. And I think that really sums up a lot what goes on with ECMO. So let's talk a little about the history of the pandemic for ECMO. This paper, was basically an editorial that came out in JAMA early on, and said be cautious and apply ECMO only to those individuals who you really feel have a fighting chance. And remember, 2.5 years ago, or 2 years and 3 or 4 months, we really didn't have a good idea of what the outcomes would be with people putting on ECMO. Thank goodness we do now. But there were also editorials, letter to the editors, that occurred that said, you know what, these patients don't do well when they're placed on ECMO, so really carefully consider whether or not you should be applying ECMO. Everybody in this room here has had some experience with COVID patients. They've come not only from an ECMO perspective, but in the operating room, and there's been loads of papers in cardiac surgical management as well as surgical management of COVID that shows us that there's a unique aspect to it. So many of us develop these type of protocols. This one was thumbed up in an operating room. Actually, it was an ICU in regards to how to manage COVID patients. And then, as was already discussed earlier today and throughout the meeting, guidelines are ubiquitous. I mean, there's loads of guidelines out there on what should and should not be done. And what's important to keep in mind is this is an evolving data set. And some of the information that I'm going to share with you shows what really is unprecedented with most of us that have been involved in either a surgery, intensive care, perfusion over the last 40 years, because the rapidity of which this information is appearing has resulted in a lot of misinformation that is out there, and changes within pharmaceutical regimen treatments of these patients that we had not seen before. Normally there's multiple randomized clinical trials that are controlled, blinded, and really very few actually exist for COVID. And this is a summary slide of that. There's close to 1,400 publications on the use of ECMO with COVID. And there's so much heterogeneity within them. I mean, they exist from a single centers, and when you get to single centers, you'll see that they have the best results. When you can tightly control what patients you're going to be placing on ECMO and following, whatever guidelines, either national or your own, that you've established, your outcomes are going to be better. There's no doubt about that. But when you get into multi-institutional or registry data, that's probably a better depiction of what's going on throughout throughout the industry, and perhaps using those recommendations from those single center studies. But more importantly, we know and we've heard, the Walker story this morning was phenomenal. We've all experienced this. This is definitely rationing of medicine. We all know that the recent Vanderbilt study has shown that most of these patients are dying. And I should actually back up a second, because right now we're really on the tail end of the COVID phenomena. Dr. Fauci yesterday came out and stated that the pandemic was over. And in fact, our numbers, which I'll show in just a little minute, in the last several months we have 92 hospitals doing ECMO, 61 did COVID patients. We're seeing a real tail off, thank goodness, thank God that that's occurring. So let's move into what I'm going to discuss once we get into the data, and that is the utilization of a registry to go ahead and collect information and then to place it into a central location where data scientists can get at it and provide advanced statistical methodologies so that it can be utilized. And we've written a number of papers on this. I think we're up to 9 right now. 3 or 4 are in revisions, but these are the ones that are at least are out there that have been published. And I'm going to summarize a lot of that information here as we go quickly through the slides. Early on, our first 32 patients, what we found was that there was a relationship with the age of the patient that was being placed on, the length of time that a patient was placed on, with survivors spending longer on ECMO than non-survivors. Followed up with 100 patients, that was 32. Then when we looked at 100 patients, we found that the individuals who were surviving actually were younger, and we'll talk a little bit more about that in just a second. Once we reached just under 200 patients, we looked at some of the pharmaceutical changes, medicine changes that were occurring across these 60 hospitals across America, and it was a seesaw pattern. This is so unusual and unprecedented in medicine. This is not something that we see often. Perhaps during Ebola or other pandemics that were breaking out, you saw the rapidity with which information and knowledge was being generated, and we found, of course, in retrospect, that knowledge probably was not accurate at times. So let's look at where these particular centers are. The graphic on the left just shows the states where these 61 hospitals were located at, and the blue stars just indicate where we've got centers that are doing 50 or more COVID ECMO procedures. We do about 1,100 ECMOs per year in our organization. And then the distribution curve on the right just shows the number, and there's a lot of variability here with outcome information that's related to the number of cases that are done. A lot of the modeling I'm going to present from here on out, it really isn't a confidence interval, it's credible interval. We shift to a Bayesian type of approach to our statistical analysis, which is what most of publications now are going to, or they will be going to in the next few years. So when you see these type of graphics that come up, traditionally they're a median and confidence interval. This now is credible interval, which is a little bit higher opportunity to predict how an outcome will be. And so what you can see is that over the time period of the pandemic, the number of cases that you're doing at the hospital has a direct relationship to overall survivability of the patients. What I'm going to do to summarize the next data that I'll be presenting is we're going to look at 700 and just under 40 patients. A bunch of them were lost. We didn't have outcomes, but we did have outcomes on 624, which are separated into a survivor category and a non-survivor category. If we look at the time that cases were placed on ECMO, this graphic right here, the horizontal axis on several of these will come up. We'll show you the months and the years. And I ended really at February. March is shown there, but it was really the end of February. And then if you superimpose on these particular graphs what was going on in regards to the various variants, I don't have more recent ones on here, but definitely Delta and the Omicron corresponded with those peaks that we saw with individuals being placed on ECMO. Majority of patients are suffering pneumonia. ARDS is the primary concern of these individuals. No surprise because of the target tissue that the coronavirus is focusing in on. Most of these patients are male. If you actually look up from a genetic perspective, women have an enhanced immune system. And since this is primarily immune dysfunction that is occurring with this particular type of pathology, women tend to be less affected in this than men. And then, of course, looking at the ages on the right-hand side, you can see that looking at the average, not the median, somewhere in the mid-40s. But if you distribute the categories shown on the x-axis here just by age, our IRB approval is 18 and above, so that's what we set at. And you can see the majority of patients are located somewhere between 30 and almost 60 years of age. Unfortunately, our research and others have shown that the older you are, the outcomes will change dramatically in regard to this. Again, no surprise, and I keep on referring to the Walker story with the 52-year-old Robbie, being perhaps at the cusp of whether or not he should receive ECMO. Ethnic distribution. We're going to talk a little bit about this more. This has become more prominent in the major journals. JAMA, New England Journal of Medicine, are requiring that any type of submissions right now do have an ethnic component and race, and we can see that this is primarily affecting the non-white population. But I'm going to keep this as a caveat because in a few minutes we'll go over the sequence of the pandemic because this has changed dramatically from when we initially started looking at this information. Most of these patients are veno-venous cannulated, 91%, and of those that are cannulated, 75% are using a dual cannula technique, with about a quarter using one of the single dual stage catheters that are in place, and the distribution shown there with Protect, Crescent, and Avalon at the bottom. And we'll talk a little bit about more of that in just a second. As far as the time on ECMO, here's a distribution with VV versus VA. VA patients are spending about 5 days less on ECMO in regards to a median and an average. But if you look at the outcomes here, clearly if you have multi-organ involvement, which most of these individuals do, a lot of them have myocarditis, you'll find that there's less survivability within that particular type of cannula group. What devices are being used today? I'm sure everybody here, if we were to ask, you would say, yeah, I'm using the Rotaflow, the Centromag, or the CardiaHelp. In fact, 75–80% of all the cases are using one or more of these devices, and then a small utilization of others that are out there. What about thromboprophylaxis? We know that anticoagulation is extremely important due to the disease processes associated with the hyperinflammatory response that we see. And that inflammation, of course, has tremendous crosstalk with any of the coagulation pathways, including platelet interactions. So coagulation management is huge. 2/3 of our patients are given heparin, and then we have about 20% or so that are using a direct thrombin inhibitor, either bivalirudin or agatroban. I wasn't able to find any others within our database. But if you look over on the right-hand side, from the mid to the right, you see that we have a transfer of patients who were on heparin and then went to bival, or they're on heparin and went to argatroban. Keep that in mind because that's a really important aspect, as opposed to when you read studies, and there are a few of them that are out there, more are being generated, that looking at specifically a DTI for managing these patients. Some centers have just gone to DTI and don't use heparin at all. But some of the outcomes you have to be careful with. So we did a sub-study, this one's in review right now, of about 1,500 patients, and we broke them down into heparin only, a DTI only, or a heparin then DTI. And we combined bival and argatroban in small numbers there. And then we looked at subgroup analysis. So on the bottom left here, you can see heparin only, direct thrombin inhibitors, and heparin following with a direct thrombin inhibitor. And so we looked at primary endpoints of circuit failure and then some pathophysiological endpoints. And what we had shown was, if you look on the horizontal axis here, we've got the 3 categories. This is by disease state, heparin only, DTI, and DTI after heparin. And the majority of patients in the ARDS group that are not suffering from COVID are receiving heparin primarily, with less patients in the COVID group are receiving heparin primarily. But a fair number, almost a quarter of the patients on the far right-hand side, the percentile, are getting a DTI after they received heparin. So what are some of the outcome measures? Initially, before we regressed this information with multiple linear regression, we found that there is a trend towards more circuit changeouts, 50% versus 24 in the heparin groups, and this is both groups combined, and that the number of circuit changeouts as an average per ECMO run was much higher in the DTI after heparin group. So once you start basically controlling for multiple factors, time on ECMO is a huge one, for example, which will be shown in the next slide. Once you get rid of all those, we still see this effect as prominent, where if you start with the DTI, if you start with heparin and then go to a DTI, you have a much higher likelihood of changing out a circuit. And this information also was consistent with some of the outcome measures, renal hepatic dysfunction, and as well as mortality. In fact, as I just mentioned, the odds ratio of going ahead and having a circuit change out was related to time. This is reported by others as well. You have a 7-fold greater increase of having a circuit change out the longer you're on ECMO, and our ECMO times for ARDS versus COVID are approximately twice as long with the COVID group. But once you control for that time, you still see a 2-fold increase with individuals who are getting higher circuit changeouts, regardless of the time on ECMO, as opposed to individuals either given heparin or a direct thrombin inhibitor itself. So clearly something to be concerned with in your centers when you have this, and probably it's something that would continue if you are putting an ARDS patient on and your COVID numbers decline. So what about outcomes? Overall, our survival rate is just under 39% for those 680 patients or so, 682. And if you look on the right-hand side, 91% of the patients are failed to wean. You can't separate them from ECMO, while about 10%, just under 10%, were weaned and then died more than 24 hours thereafter. So it's something that once you do get a patient off of ECMO, some of them are weaned from a compassionate perspective, expected to pass away right away, and they hadn't. But some, were weaned successfully and then succumbed later on, usually to thrombotic events. When you look at what caused the death itself, respiratory failure, failure to improve your outcomes, about 50% of the patients. And then the next 3 categories make up about 35%. Multi-system organ failure, cardiac arrest, and central nervous system injury. And a lot of that injury is related to thrombotic events, so it was hard to separate them out and tease them. When did people die? I know I didn't, I went quickly through the pandemic structure that's reported by Johns Hopkins, but if you look at those peaks with deaths, they correspond to usually 4 to 6 weeks after the COVID Delta variant and also the Omicron. So let's look at some of the changes that we had found. Most of this is descriptive until we get into a more finite analysis. We see that patients in the survivor group are younger, about 7.5 years younger than the non-survivors, more men in the non-survivor group, and then also, again, getting back to ethnicity. And why ethnicity is important, this paper just published in JAMA a few weeks ago looked at comparing the Mississippi inpatient-outpatient database, and I think it was 18,000 patients. And what they had found was when you compare whites, blacks, indigenous populations, Alaskans, even when you start controlling for factors such as the Native Americans and Alaskans are younger on admission and younger when died for COVID, and they're more likely to die in the hospital, this was not related to comorbidities. This was not related to a sicker population that was coming for intervention. And this is not ECMO patients. I'm sorry I didn't mention that. This is COVID in general. So there's something else going on related to genotypes that need further examination, because it's not just saying that this was more comorbid patients. We assessed the pre-ECMO comorbidities, and you can see the list on the left-hand side over here and the distribution. And when you look at them individually, there's no difference, but when you do a composite analysis, you group them all together, we have about a 6% increase that is occurring, and this has actually changed over the pandemic. Which is interesting. So once we get into the sequential outcomes, maybe this will help explain what we're seeing. And then, of course, we have all of these traditional ELSO type measures, and there was no difference in most of these categories, and when we started looking at them individually or through regression analysis to see if there was a relationship. But this I draw to everybody's attention, and this is a dumb moment for me because you've all experienced this more than anybody, is the number of circuit changeouts. Over 35% of all patients, whether you're a survivor or non-survivor, had a circuit changeout. And if you look at the number of circuits, the number of patients who've had multiple changeouts, it really is impressive to see. And we know this is related to time on ECMO, but it is, those of us in perfusionists, I've been close to 40 years as a perfusionist. I've changed one oxygenator out of my life, in my career. And that one really did, when blood was pouring out of the exhaust port of the oxygenator, it's probably a good idea to go ahead and change it. But I'd never changed one. I've never come close to changing one any time in my entire career. If you're doing ECMO, if you're an ECMO specialist, which you're probably all next door, or a perfusionist doing ECMO, you're changing these things out quite frequently. Looking at some of the pharmacological changes, I just took a snippet of them. These are quarters during the pandemic. Q1 20, which is when our first patient was March 17th, 2020, and then ended this past fourth quarter. You see this seesaw pattern that's occurring with pharmaceuticals, and it's really frustrating because a number of our intensivists and surgeons say if you've seen one ECMO run, you've seen one ECMO run. They're all so individualized. It's tough to make generalized statements on them. But if you look at veno-venous versus VA, we can see that in the non-survivor group, these are primarily multi-organ failure individuals dealing from a cardiac or hepatic and renal perspective. And sure enough, if you then look at survivors versus non-survivors in regards to timing, this first graph is diagnosis to intubation, from the time period that they were diagnosed with COVID till they were intubated. And we can see that the x-axis, which you can't read on the far graphic, that's time. And this is time from cannulation. So we see over the entire pandemic, the longer you spent from the diagnosis to go ahead and intervention being intubated, the worse your outcomes. Now, everybody in the room here is knowledgeable, of course, with barotrauma and mechanical ventilation, the duration being a prominent effector in regards to a negative outcome. But this is, even before you're intubated, that's shown this relationship. But once you were intubated and you're placed on ECMO, that relationship diminishes. In fact, if you look at, from about, I think that's 2 days out, there's really no benefit in regards to survivability once you get beyond just a few days from intubation to ECMO. And you can see the descriptive statistics on the left, about 4 days is what the time period is. So that helps. It helped us earlier in the pandemic to alert intensivists and the group if somebody wasn't getting better with the interventions that were being done. You've got about 2 or 3 days to get your ECMO resources in line. Support time, this is the blue is the average, the red is the median. And so on the left-hand side, you can see that non-survivors are on longer. It makes sense. You're trying to do everything you can, give them an extra couple of days. No difference in tracheostomies. There's a lot of research that comes out and says, perhaps we should trach these patients right away. Perhaps we shouldn't trach them. Perhaps no intubation should occur. If we look at discharge summary, now this is partial. I only have 142 patients that we have accurate data on, but there's really 6 places they can go: long-term care facilities, home, rehab, referring hospital, onto a transplant, and unknown. And then on the right-hand side is the days. So once you're off ECMO, the shortest days are usually the ones that are sent back to a referring hospital. Once they're left our facilities, we no longer have an opportunity to follow up on them. But you can figure between 25 and 30 days from the time period you're weaned off ECMO till discharge to the long-term care facility, or some patients actually home. What about the probability of survival over the pandemic? So if you look on the months and years on the very bottom and then fit that into a regression analysis, we can see this phenomenon. This is very unique. Something that we've submitted, and it's being revised right now to the Journal of Thoracic and Cardiovascular Surgery, and it shows this U-shaped phenomena. The ELSO data was presented in Lancet about a year ago, and they had looked up till about the mid-level and shown that there was a decline in overall survivability of these patients. Well, we've shown that exact same decline that occurred, but now it's trending upwards again, and I'm sure the ELSO people will publish on this as well. So let's look at some of the really dramatic changes that have occurred throughout the pandemic. On the left-hand side, again, March 2020 was our first patient, and that's February, a couple of months ago this year. And look at the average age of patients that are declining. that we're placing on ECMO, and that could perhaps tell us why we're seeing that inflection with more patients surviving during ECMO. And now, if we look at some of the changes, look at the ethnicity changes. You know, Latinos were the primary group that were found in a total descriptive statistical analysis by summarizing all data, and they're actually dropping off significantly. And more whites, Caucasians, are actually ending up being placed on COVID as an overall percentile, and the African Americans are following those same trends with Latinos. As far as some of the drugs used, and I put this up because it shows the seesaw pattern. Here's a percentile, right? But if you look at what occurred, this paper, 2 papers came out in the New England Journal of Medicine. The first one, basically damned monoclonal antibodies as being effective in patients who are critically ill suffering from COVID pneumonia. But then, at this time period, you could see the red arrow is actually showing when the publication occurred. This showed the opposite, that actually IL-6 antagonists actually probably are beneficial. So you get this sawtooth pattern in drugs that are occurring. Now, if you're a researcher and you've been involved in the pharmaceutical industry for years, the x-axis here isn't in months, it's in years. You know, phase 1, phase 2, phase 3 trials, phase 4 trials. It could take 20 years for this information to develop. Here we're developing it in a very short period of time. So it's something to keep in mind. This is unprecedented, at least in my 40 years in my career. No surprise, hydroxychloroquine. It's interesting, though, that some patients are still coming and are being given it in a few centers. And then on the right-hand side, steroids. You know, it was a dollar fix. It was something that's been shown to be very effective in managing COVID, and so most people are doing that right now. Convalescent plasma, this was really thwarted to be a really phenomenal achievement, especially from a blood banking perspective. Unfortunately, some good data threw a curveball at that wonderful theory and caused it to be to regress. And so now you can see, in fact, in our last 4 or 5 months, nobody has received convalescent plasma. Cytosobe filters, these were, you know, they make perfect sense to use them. I mean, there's nobody who can argue against that. There's been a lot of European trials, some here in the country, that have shown they've been efficacious, not only in COVID, but in severe inflammatory response syndromes and others. Just nobody's using them. We just don't have any utilization. And all that could mean is that the hospitals that are in this data set don't use it because others have really embraced the technology. And here's just a paper that came out and said that they probably are not effective. Looking at some of the subcategories before I conclude, this is pregnant patients. And we had 15% of all of our women in our trial were pregnant or peripartum. These were individuals, and you can see 28 of them were postpartum, and then the C-sections and fetal death and a few unknowns. 55% survivability, which is 15% higher than our average for the entire population. So, and these are young patients. Their average median, was 32. Most of them are on VV ECMO. And then you can see the distribution of time period, including the days of support. The majority of these patients were Latino, and that makes sense. And if you look at some of the recent data that has been published on pregnant outcomes with individuals placed on ECMO with COVID, you can see that the very top distribution on this forest plot is showing survivability is much greater, is high with these individual patients, women who were pregnant post, which is great. And the very bottom here is renal complications, acute renal failure. New onset renal failure was also significantly less if you were pregnant. So really good things to know and offering hope. Some of the outcomes that don't fit into any type of graphic, our longest survivor support time was 128 days, but our longest patient is still on today is at 453 days. And if my memory serves me right, there have been no circuit change outs. I don't know if any of the clinicians involved with this management is a Floridian patient. No circuits have been changed in over 300 days on ECMO, which, correct me if I'm wrong if any of the clinicians are here. Shortest time on ECMO, 2.4 days. We don't include 1 day. If you're on ECMO for 1 day in COVID, you get placed in a different database, for a number of reasons that I won't necessarily go over. And then off ECMO, but then reinitiate a very small percentage, where you're off and then come in. So to conclude, just a few summary slides, and this is really the unknowns. There's so much that we don't know with this particular management, even though we're now over 50 years using ECMO as a modality for treating these very sick patients. Do you extubate them? Do you intubate them? Do you perform a tracheostomy? Do not? What's the effective timing here? We all know it's better to be placed on ECMO sooner than later. What about the selection criteria? What type of risk modeling are you doing to determine who should be placed on ECMO or not? There's a number of these. that are out there, and then what type of cannulation are you going to use. So over the 24 months, some of the findings, there have been a change in pharmacological interventions that have occurred. There's circuit changeouts that are really important to keep in mind. And even though ELSO says, yeah, it's just related to your time on ECMO, that's not found. One of our studies had control for that time on ECMO and found still that there were more circuit changeouts with COVID. The use of DTIs is growing. More centers are at least going to it. Unfortunately, if it's done after you started with heparin, the outcomes tend not to be as good in regards to circuit, keeping the circuit intact. Survivors are younger, female, supported with VV more than veno-arterial. They have shorter time periods, and they also have lower pre-ECMO comorbidities. So the take-home message is ECMO is definitely a viable option. I think that's been well established by multiple studies that are out in the literature right now. Early hesitancy with applying ECMO has really been found to be not true. Adjunctive therapies are occurring at a rapid rate. I mean, that's why if you look at how this is being published, it's remarkable that the editors of the journals and reviewers that review these papers allow some of them to come through. And I've noticed over the last few, maybe year and a half, it's a lot harder to get papers published today right now. In fact, I got a review today from one of the editors, and he said, he goes, basically this is redundant. Which you hate to say, especially to an editor. Well, replication, scientific methodology is based upon replication, so it may be redundant, but maybe you just don't want to put paper to pen here and have it published. That's my little rant. But I mean, it is important to realize that this is evolving knowledge that is occurring over time. And the results of higher circuit complications are something we just need to be aware of. Maya Angelou, wonderful individual, Dr. Maya Angelou, wonderful quotes. I've learned that people will forget what you said, but they won't forget what you did and how you made them feel. And I think this morning's story that we were so lucky to hear probably brings that home. So with that, I want to thank you. This was last night's from our hotel room. My wife and I sit out with a glass of wine and watch this, and we just happened to catch this pelican going by. In Pennsylvania, where I live in the mountains, we don't have many pelicans, and we surely don't have many harbors. So it was a pleasure, and I want to again thank Carla and Susan and the entire committee for allowing me to be part of this conference. Thank you.
Hi, Al. So you have some online questions. From Colleen Grondalski. She asked, are your perfusionists changing oxygenators with ICU nurses, specialists, or with an attending/fellow?
Yeah, that's a good question. And I would say about half of these procedures are run by perfusionists and half by ECMO specialists. We happen to have I think it's somewhere around 150 ECMO specialists, which are nurses and RTs for the most part. So it's about half and half. And usually when these occur, if it is something, it's usually not a one and done where the device failed, immediately required change out. You see it occurring, sighing, doing all the normal routines to make sure the device is functioning normally. You have some time so you can prepare for it, and they do. They'll have RTs at the bedside and as well as intensivists, but about 50-50 in regards to perfusionists and specialists.
Perfect. That actually leads into another question by C. Sealer. She asked, what parameters do you use to determine when to change out an oxygenator on ECMO?
Yeah, that's a great question. And most of it is right down to either oxygen or carbon dioxide exchange. Most of it is a failed oxygenation, although a fair number of the cases have been involved with hypercarbia. And it's individual. One of the problems with registry data like this, especially 61 centers, we didn't standardize a protocol for change out across either. We could never do that. So it's a better holistic snapshot of what's going on. But clearly, I would say the majority of individuals are hypoxemia or low oxygen delivery levels, and then the others are just the opposite, hypercarbia.
Hi, Dr. Günaydın from Turkey. Thank you very much for this database and presentation. It's very valuable information. I also want to underline another patient population now we recently are facing. Patients undergoing cardiac surgery with a recent history of COVID. like less than 1 month or around 1 month, have very unexpected clinical, results. Like some of them have some coagulation defects that we cannot, understand why this happens, or cold agglutinins during surgery. So in those patients, then we become very much careful in the management, because many unexpected complications in those type of patients. So what do you think about them?
Yeah, Dr. Gunainen, thank you very much for that comment. Dr. Gunainen is the first author on one of the initial publications on what to be aware of with managing patients specifically placed on bypass undergoing cardiac surgery. And a lot of his prognostic suggestions, which were done using current knowledge at the time, which was almost 2 years ago, I feel have come to be true. And we've actually followed one of Dr. Gunainen's publications with our own publication that showed that the risk of failures, circuit failures and complications associated on cardiopulmonary bypass with COVID-positive patients, and Dr. Gunainen said a month. Ours didn't look at the exact timing. It was either yes or no by PCR test for COVID positive, were 4 to 5-fold higher complications with individuals placed on COVID. So what he had suggested to be aware of and to follow at each of our institutions using a data registry of ours of 60,000 patients showed to be true. And I would imagine if, I don't think the STS was quick to change their metrics and to add those variables. They may have, I don't know. We were able to very quickly incorporate that into our registry and use those to track that information. So if you have a little bit more flexible registry type data, you can do that more so than the big standard one. So I think you're exactly right. I think that these individuals and perhaps our next speaker could also comment on that as well.
Thank you.
Thank you very much. Okay, thank you.
Thank you, Al. Our next speaker is back again from last year. Pleasure to have you back, Dr. Hayanga. He is from West Virginia University. He is here to discuss COVID and ECMO, change in the orthodoxy. Dr. Hayanga.
Distinguished moderators, ladies and gentlemen, thank you for this invitation to present today. At the start of the COVID-19 pandemic, the CDC declared that West Virginia would have the highest mortality in the Union of the States, and that this was something that we should anticipate, expect, and prepare for. I'm not going to bore you with the fundamentals of ECMO, the configurations, the cannulas. You understand the history. You remember Dr. Bartlett. These are all things that from a historical perspective are important, but which you likely have already covered. I will draw your attention to the two pandemics that have happened in the past. The first of which is the H1N1 influenza, which really spurred on a lot of the discussion and the rationale behind the Caesar trial, and also the conclusions of the Aeolia trial, which was published in the New England Journal of Medicine in 2018. A lot of these things happened as neonatology and post-cardiotomy support kept the flame of ECMO burning. And so when we started to use, as a matter of routine, centrifugal pumps, quadrox oxygenators, heparin-bonded circuits, lower ACTs, sometimes not using heparin, these are things that have evolved over the past 12 to 15 years that allowed us to prepare for what we needed ECMO to do. Now at West Virginia, we started the program about 4 years ago, and this was designed to support a quaternary cardiothoracic program. We are steeped in a tradition of coal mining in the Appalachian landscape, and we have a significant burden of comorbidity. We designed this program to be a bridge to transplantation and started a heart transplantation program with a view now to starting a lung transplantation program. And this is the backdrop against which we were faced with a pandemic. Now, in terms of structure, we use 2 EC-145 helicopters, and we cover all 55 counties in West Virginia. We also cover a 5-state region, and our mandate is to protect and to treat patients who have acute severe pulmonary and cardiac failure. We went live in 2018. We've done 100,000 hours worth of work, and we have a multidisciplinary team, and the emphasis there is on team. The ECMO volume globally has grown dramatically over the past 2 years, but this is a trend that has been over the past decade, and at West Virginia we saw about a 55% increase in volume every year since our outset. We predominantly started with post-cardiotomy support, but we evolved. And as we evolved, we began to use ECMO more and more for pulmonary reasons, to treat pulmonary failure. And by 2019, we were doing 57% VV ECMO versus VA ECMO. There was a lot of scrutiny with the program starting and the amount of capital outlay that went into setting it up, and so we had to pay attention to our outcomes. Now, outcomes are always measured against benchmark, and so ELSO was our standard. We all know what we're supposed to achieve in terms of outcomes, but as a young program and to gain credibility, we had to be better than the benchmark. And so when we started, we were very stringent with our criteria, and we managed survival to decannulation rates which were standard deviations above ELSO. 72% in 2021, survival to decannulation and survival to discharge was also close to 70%. When we looked at our outcomes and we declared that these outcomes were better than ELSO, the natural question is, well, are your patients as sick as everyone else's? And you know, we always thought this was an ironic question because we are always told that we have the most unhealthy patients in the country. But when the results didn't show that, we were forced to go back and do a complete risk stratification using RASP, Murray, Apache, SOFA, SAVE scores, and of course we found that we do have the sickest patients in the country. The expected to observed rates were, however, in our favor, and really this is a significant team effort to make sure that the resources that we were given by the state were being used appropriately. In order to determine who we would have at the bedside, we modeled our on volume. So the disposables that we use, for example, would be fixed costs. They are driven by volume. The break-even point is that point where your revenue covers both the fixed costs and the direct costs, and then anything above that is profit, so to speak, and anything below that is loss. The break-even point we found for us was 10 cases per year. We had to do 10 cases per year to justify the program. Now, this is different for different programs and different contract negotiations and costs, but that itself is a formula for programs to determine how much they need to do and what it would cost. When we switched from perfusionist at the bedside to specialist at the bedside, the natural question was, but is the quality the same? Are we compromising safety? Are we compromising patient safety and quality? And so we had to prove that nothing would change, that we would have the same quality at the bedside, whether nurses or perfusionists were rendering the care. The costs meant that we were able to save on rental because there was an opportunity to stop renting all the equipment because many of our vendors allied with us and provided some of the equipment for free. This was very important because at the time of the pandemic, there were a lot of supply chain issues and a lot of shortages in equipment and personnel. But equipment ended up not being a problem. The data had begun to show that there were a lot of cases happening, and whereas previously we would see 2 patients for every 1 patient we put on ECMO, by the time the pandemic came around, we were seeing almost 12 patients for every 1 that we could place on ECMO. And the sobering reality of this was that all the patients that we evaluated that we could not place on ECMO because of volume, they all died. Data are interesting, and here, each bar represents ECMO mortality by state. And it is a comparison between the first quarter of 2020 versus the first quarter of 2019, meaning before the pandemic and after the pandemic. And any line that deviates to the right-hand side means that in the first quarter of 2020, there was more ECMO mortality, a greater number of ECMO deaths than there were the year before. And you can see across the United States, there was an increase in mortality. Very few states didn't actually see this in comparison to those that saw an increase in mortality. And these kind of trends may not look very dramatic, but they only happen in the context of 2 things, either war or natural disaster. So these were signals that certainly even within the ECMO population, we were seeing a large number of people dying. And ECMO is not the only thing that caters to patients who are sick in the course of a pandemic. And indeed, in the state, we saw these data. Each of these dots is a day in the ED. It's a volume of patients presenting with influenza-like illness. So each dot means a day in the week. And you see Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. There's a drop every weekend. People don't seem to get influenza-like illnesses then. But you can see a pattern that it shows some regularity. In the state, when we instituted public mask wearing and social distancing, there was actually a decrease in the number of people presenting with these illnesses. And so there are other measures outside ECMO that were in play and in place. But certainly for the year 2021, the majority of our ECMO cases were COVID related. And this was true for what we were seeing across the state, and indeed it mirrored what was happening across the country. The number of cases was dramatic in 2021. But what we found was that not only were we seeing a lot of patients, there were other things about this that were significant. The median age was falling, and the acuity of illness, the severity of illness was going up. So we were seeing younger patients, and yet they were sicker. They were sicker than they had been. The illness was somewhat stereotypic. It was a destruction of the lung parenchyma, and it resulted in this diffuse ARDS. A diffuse ARDS that rendered the lungs almost liver-like in consistency and really unable to exchange oxygen and release carbon dioxide. We were forced to change our tack. We had to deal with patients who were younger. We had to cannulate patients. First, we drew a line at age 60, then we reduced this to 55, and then 45. We couldn't manage to treat patients with existing comorbidities because they didn't survive. We realized that in the context of other end organ damage, we were at a loss in terms of ECMO use, and it just was not working in these patients. The BMI was a contentious issue because it wasn't that the size itself was a problem, it was just our inability to perfuse patients who were a certain size. We just could not achieve adequate flows. Smoking became a contraindication because that kind of risk of COPD was one of the problems that we had in terms of decannulating these patients. And if a patient arrested prior to cannulation, we considered that a contraindication. We were just not able to save that kind of patient. We also found that if we waited longer than 3 days on mechanical ventilation, our chances of saving the patient were slim to none. So we changed our criteria, and this is in the context of other challenges because a lot of things were going on. There were vaccination efforts, and vaccination efforts were somewhat of a paradox in West Virginia because West Virginia has a no exemption policy for school-going children. West Virginia is used to using vaccinations and uses them with regularity and as a matter of routine. And so the rollout of the COVID-19 vaccine was actually quite extraordinarily successful. The state didn't wait for the federal government to distribute the vaccine. They used mama and papa's pharmacies. We used the National Guard to help in the distribution. There was a strategic approach whereby it was a community-based effort rather than leaving it to the government. And the leadership was by a pulmonary doctor himself, who was our COVID czar, the dean of the medical school. And so when we started off, it was a good rollout. There was a successful vaccination program, and people were getting vaccinated. But then somewhat surprisingly, it stalled. And it became a matter of politics. And at that point, the vaccination effort reached a plateau that was never breached thereafter. And we quickly dropped to the bottom ranks of the vaccination within the state. We changed our approach to ventilation during the course of the pandemic because we had previously assumed that all patients could do well with once on an ECMO with an FiO2 of 30%, a PEEP of 10, a pressure support of 10, and limiting plateau pressure to 30. But as we dealt with more and more obese patients, we realized that maybe that's not the best approach. And we started to look at things in terms of intrinsic PEEP. How much PEEP is necessary to keep the lungs open but not affect venous return? And if that is the case, if there is an individualization in how the different bodies respond to different amounts of PEEP, then maybe we should approach it the same way when it comes to ventilator settings. Now, in the context of transplantation, when we perform an organ procurement, one sees that a pressure support of 10 may not necessarily keep your lungs patent and those lower lobes expanded. In fact, in order to get the lungs expanded in their entirety, you typically have to do some pretty aggressive recruitment maneuvers in order to get the lower lobes up and running. And so we started to use esophageal manometry to tell us how much PEEP is required in each patient, and we would titrate the PEEP accordingly. And this really fits the science behind the different types of COVID-19, where you have H and L types, which have different levels of recruitability and require different levels of PEEP. So we challenged the status quo in that fashion. We went down on age. We decreased the interval between intubation and cannulation. We considered adjuncts. I mean, you've heard in the previous talk by Al Stamers about convalescent plasma, remdesivir, steroids, hydroxychloroquine. Well, we considered all those within the algorithm and set a time limit so that we weren't stuck on the proning pulmonary vasodilator stage of treatment and waiting to cannulate for too long, we abbreviated that so that we would cannulate early. We changed our ventilatory strategies as described above, and we considered the use of cytoreductive techniques. Now, previously, we had an experience with plasmapheresis, but during the pandemic, via an emergency use authorization, we were able to use CytoSorb specifically for this. And in this way, we were able to dredge out molecules between 5 and 50 kilodaltons, and in this manner address this as a cytokine storm that it is. In fact, when we look at IL-6, ferritin, D-dimers, all these numbers are elevated in the context of a cytokine storm. So it seemed to make logical sense that we would add a filter to the circuit and in this way dredge out these molecules that were causing a lot of inflammatory noise within the body. We had plasmapheresis going, and we were able to compare the two because we had them right up against each other. And CytoSorb was by a very strict protocol by the FDA, and we used this in combination with plasmapheresis sometimes. But we were able to separate out the two and even consider how much it was costing the system. And whereas we had always believed that plasmapheresis was a cost-effective mechanism of doing this, we quickly realized that with plasmapheresis, we had to have blood, FFP, we had to have personnel at the bedside, and it ended up on a cost comparison being the less affordable of the two, with $16,000 per patient burden, as opposed to one that was much lower than that. And in the results of the CytoSorb registry, it is clear that the survival of this multi-institutional registry reflects very closely to our own experience, where the survival was 70%. We established an objective pre-cannulation probability of survival, meaning that when you have a patient and you're trying to decide, should you put the patient on ECMO, the three things that we thought were most useful in determining that was, one, age. Age was extraordinarily powerful in a model, and also the days of mechanical ventilation and whether or not the patient had other comorbidities. And the lower these were, the higher the probability that that patient would survive ECMO. We looked at our results during the pandemic versus before the pandemic, and we saw a near identical survival. This is very different from the ELSO experience. As the ELSO experience went from Alpha to Delta to Omicron, the mortality escalated and survival was very low. At one point, in March this year, the in-hospital death was 48%. That's almost a 50-50. Now, we were seeing an in-hospital death rate of 16%, which was significantly lower. And so we continue doing what we were doing, because in the context of a poor state with a high burden of sick patients, we wanted to make sure that we could get these patients across to the other side. We looked at our own data, and by logistic regression, we found that age 47 was a cutoff, and patients older than that had a higher chance of dying. We were part of multi-institutional registry, but really, we drew our data from lung transplantation. Our ECMO program is designed to be a bridge to lung transplantation, and these are the data that drove our intent and our rationale. We'd seen, just like the use of ECMO as a bridge to lung transplantation had continued to improve over the past 15 years, and that the early era versus the latter era, when you compare 2005 to 2012 versus 2000 to 2005, survival had improved. And when you compare the 2000 to the 1990s, it was a huge difference. There was a much greater survival in the latter years. And overall, mortality was falling. So ECMO was becoming safer and safer with each passing year. And we'd proven this in 2018, the cover article in the American Journal of Transplantation, to show that ECMO can be used very successfully as a bridge to lung transplantation, meaning that if you have a patient who has lungs that absolutely do not work, ECMO is an excellent option until they get transplanted. And our beliefs and our suspicions seem to be reflected across the landscape of the country the past 4 years, because the number of patients strictly on mechanical ventilation prior to transplantation is falling, and the use of ECMO predictably is growing. Volume, as always, is very interesting because the higher volume is associated with better results, but it's much more complicated than that. When you look at the statistics, the C statistic, the measure that tells you how much the predictor actually predicts the outcome, the C statistic is only about 0.6. 60% of this is volume, but it's something else involved. When you have high volume, that means you have other resources available. You have interventional radiology, you have interventional cardiology, you have people on standby to help in a multi-dimensional way that helps the outcomes irrespective of volume alone. And once again, the team theme plays out. From our ECMO transplantation experience, we know that VA ECMO has a much higher mortality than VV ECMO. And so this drove our ethos that if a patient needed VA ECMO for COVID-19 disease, they were not a candidate for ECMO. In our multidisciplinary group, we worked to ambulate our patients. So that meant that somehow we had to get them extubated or with a tracheostomy, and that was another way in which we challenged the orthodoxy. We brought in the early tracheostomy, but even before that, with the availability of vaccines and with the availability of PPE and other medications too, in the context of treating the disease, we started to have a direct outside hospital to OR transfer. So we had initially cannulated everyone in the ICU, but now, because our providers were afforded protection, we brought in the anesthesiologists to the algorithm so that they would receive the patient status, help manage the patient, and we'd bring the patient directly to the operating room for purposes of cannulation. And so this introduced another teammate into our algorithm, whereby the OR transfer was now in communication with the anesthesiology team. And this allowed us then to pivot from dual site cannulation to single site cannulation. And so for more and more of these cases, we used the single site cannulation technique. And again, this is something that would require fluoroscopy and anesthesia, TEE, to direct the jet towards the tricuspid valve. And this was something which we relied on our cardiac anesthesiologists to provide. So these cases were now done in the operating room, and with that, we saw a big decrease in any septic complications, and we did 50 of these in a row, and the anesthesiologists are publishing this series. Not only allowing us purposes of access and transfer, but we were able to identify new pathologies, ASDs, core triatum. We were able to identify echocardiographic findings that would not have been possible without TEE, would not have been suspected even. And 3 or 4 times it actually changed our cannulation strategy. So for example, we were able to identify why a guide wire would not traverse into the IVC because, for example, of the presence of a right atrial thrombus or an SVC thrombus, in which case we were able to say, no, there's no need to waste any further time with trying to cannulate this patient using a single cannula. Let's go for the dual site technique. All these are important because all of this costs a lot of money. It costs a lot of money in a state that doesn't have that much money. And we are constantly asked to pay attention to our payers. Employer-based insurance is not a big feature of the payer system in West Virginia. Indeed, the majority of patients are Medicare, Medicaid. Now, the importance of using those federal dollars wisely cannot be overstated. And when we looked at our own payer mix, we were extremely surprised to find that Medicare and Medicaid were not the majority of patients who were being brought to the university for ECMO. And that calls to mind a whole argument about access and social determinants of health that we have been challenged to address. Because if we are a state that is Medicare, Medicaid heavy, then our ECMO program patients should also reflect that. Now, 70% of our patients come from outside, and we're agnostic to their insurance status, but it calls to mind a question about how we should best address this, because in a state where we're 47th in healthcare, 45th in education, 48th in the economy, and dead last for infrastructure, these are questions that must be answered. Our policy is to cannulate, to extubate, and to ambulate, and we do this routinely, and it sometimes surprises people that regardless of the cannulation strategy, the patient will be extubated or will have a tracheostomy and will walk. And we push this with our physical therapists, and we change our decision-making regarding sedation. We use ketamine and non-narcotics, and we make this a primary goal for the entire team. These notions challenge the orthodoxy, and we have to teach our ethos to ourselves, to our partners, to our referring hospitals, and that means that there are a lot of road trips, a lot of classroom sessions, a lot of didactics, and a lot of wet labs. It has resulted in a mentoring situation in which we mentor now, I believe at last count, 52 institutions around the United States and Canada. And we've had the opportunity to publish what our experience has been over the course of COVID-19, and had the pleasure of writing the consensus guidelines for the use of ECMO in the course of COVID-19, which is published this week in the Journal of Thoracic and Cardiovascular Surgery. We, as a result, have been able to address the problem of COVID-19 in a state that, again, was predicted to have the worst outcomes. And people ask, well, what's your ethos, apart from cannulate, extubate, ambulate? And we base candidacy, we say, not on the probability of choosing the right individual, but on the consequences of choosing the wrong one, because we're terrified that we will squander the resources that we have been given. So we say that a patient needs to be sick enough that they need ECMO, and they need to be cannulated, but they should not be so sick that they cannot be decannulated. Simon Sinek wrote the book, Start With Why, and so for us, it's a valid question. When you look at the IHI and the quadruple aim, it says the aim within healthcare and healthcare delivery should be to improve outcomes, to improve the patient experience, the clinician experience, and to lower costs. So we use that as a driving force to say, why do we do this? Well, we want to take the patient from the precipice of life and death in this extraordinary situation of a pandemic and guide them, treat them, help them, wait for the lungs to heal enough so that they can go back to their communities, go back to the lives that they knew, go back to the people that they love. And sometimes this means that you take what you already know and use that. But sometimes it means that you take what you already know and what is the norm, and you challenge the orthodoxy, and you change it to suit the specific needs, particularly in extenuating circumstances. Thank you, ladies and gentlemen.
Testing.
Thank you, Dr. Hanga. We have some questions for you from the online community. Mark Preval asks, what determines who qualifies and doesn't for ECMO at WVU?
What determines who qualifies?
And who does not?
That's a good question, because it is about candidacy. And it's a loaded question because there are multiple aspects to it. There is a panel of physician staff that receive the consults, and that panel adjudicates the candidacy. But in order to make it less a subjective process and more objective ones, so that the same decision is made about different patients regardless of who receives the call, we define our criteria very stringently. The patient would have to be less than a certain age. The patient would have to be less than a certain duration on the ventilator, the patient would have to have no comorbidities. And so it became less of a debate at the start of the pandemic, but things went further when ECMO was declared a scarce resource within the university system. And then it was a dictate that if there was a debate about whether a patient was a candidate or not between two clinicians, then it was bumped up, it was escalated to the committee, and the resource triage committee came up with a SOFA-based algorithm to determine candidacy for any resource that was considered a scarce resource. So this included ICU beds, and it included ECMO. So it evolved with time, but the short answer is a panel within the team who were cognizant of what resources were available at any given time had the responsibility to determine candidacy.
Right. Thank you so much. James Kim asks, how many ECMOs per year do you feel would be enough to keep the competency of nurses, ECMO specialists, and is it hard for a community hospital to keep them competent?
Another great question. I think that a lot of ECMO programs now work in a hub and spoke model, and so we can rely on each other to keep volume going. So for example, if we have a community hospital in Huntington, West Virginia that does 8 ECMOs a year, they're still important because they can place patients on ECMO and send them to us. It is in our best interest that we keep those nurses and perfusionists comfortable with managing ECMO. So we would encourage them to cycle in to our program and maintain their competency by using the volume that we have to keep their skills up to where they need to be, rather than let them lapse because of a delay in having an ECMO patient. So I think a lot of that can be handled by collaboration, so that one's competency is not dependent solely on the volume that you see in that institution, and that there surely is a partner out there who is willing to help with that. And we certainly are very happy to help with this, regardless of geographical location.
Great answer. Thank you so much. Any questions from the audience?
Thank you very much.
I'll take it. Thank you. Thank you, Dr. Hanja. Our next speaker is going to be Casey D., who is from Teleflex. Her lecture is going to be on cardiac output computation from arterial pressure, initial proof of concept. Casey?
Good afternoon, everyone. Thank you. So hemodynamic monitoring, we know, is a critical component of caring for critically ill patients. An early goal-directed therapy that incorporates optimization of cardiac output to assist in guiding therapeutic decision-making requires a measured cardiac output that is reliable and accurate. Now, preferably the cardiac output measurement should be available continuously to rapidly detect hemodynamic changes. The complex and challenging nature of our patients requiring our MCS devices is well known. Now, monitoring patient response to selected MCS devices is critical in determining efficacy, adequacy, and appropriateness of the selected device. This discussion will focus on the development of a novel method for calculating stroke volume and cardiac output from aortic flow which is obtained from a high-fidelity aortic arterial pressure signal. Sorry about that. I will be reviewing the proof of concept of the algorithm and the test results from patient data in a variety of conditions. Now, yes, full disclosure, I am a Teleflex employee. However, this is not about our products today currently on market. This talk is about preclinical work that is a distance from application in clinical settings. And while this work was done in collaboration with physicians and scientists, there are no clinical implications at this time. Early monitoring of patients on MCS therapy, especially the balloon pump, is critical to determine if the device is adequate to support the patient. In many cases, the patient may not have advanced monitoring devices available, and many decisions are made solely on blood pressure or other indirect measures of LV performance, such as cardiac output. When available, cardiac output is the most commonly used measure of LV performance and the basis of many treatment decisions. Having this information from the start of therapy automatically would enhance clinical decision-making. Now, certain balloon pump systems currently calculate aortic flow, which is based on stroke volume from a high-fidelity arterial pressure signal. Information from the flow is used in the time domain to set inflation timing on an intra-beat basis. However, if flow can be calibrated for volume, it would indicate the stroke volume on a beat-to-beat basis. Now, working again with several leading scientists and physicians, we developed a method to calibrate the flow wave for volume and confirmed that even in the presence of the balloon pump, it can calculate stroke volume from the native left ventricle, providing a measure of hemodynamic impact from the balloon pump. Now, there are currently 2 accepted methods for cardiac output calculations, and thermodilution and pulse contour analysis. The most commonly used is thermodilution method using the Stewart-Hamilton equation. This method calculates the volume that occurs to change the temperature in the blood at 2 points along a catheter. Now, this method can be done by either an injection method or a continuous catheter-based method and is considered the gold standard for cardiac output measurement. It is important to note that the accepted accuracy range on thermodilution is plus minus 15%. Now, more recently, several companies have developed a method using pulse contour analysis. In this method, the area under the systolic component of the arterial pressure waveform is measured and converted to volume. However, in the presence of MCS devices, specifically the balloon pump, the pulse contour method has been shown to be inaccurate because it adds volume displaced during augmentation to the stroke volume. While this can indicate an improvement in systemic perfusion, it does not specifically inform the clinician about LV performance. Now, investigations with FlowTrack from Edwards Life Sciences and Pico Systems out of Germany, those have indicated that continuous cardiac output measurements using pulse wave analysis becomes unreliable in the presence of a balloon pump. The method developed based on the aortic flow wave algorithm addresses this issue. Now, in order to obtain the aortic flow wave, a high-fidelity arterial pressure waveform was used with the 3 elements of the Windkessel model being applied. Essentially, the process was worked backwards by applying the 3 factors affecting the arterial system: impedance, compliance, and resistance. Now, the algorithm converts the measured arterial pressure to flow within the beat as the beat occurs. And since peak flow always precedes peak pressure and the downslope or reduction in flow always precedes the reduction in pressure, we can use that time difference to determine the position of the aortic valve closure or the dichrotic notch. Now, this is still only showing the work in the time domain. Now, when calibrating the flow wave to volume, there are situations that can cause an abnormality in the waveform. And counterpulsation or phasic support, most commonly from a balloon pump, causes such abnormalities. However, other devices could also impact the waveform's morphology. In evaluating counterpulsation impact, though, a novel method has been developed to calibrate the flow wave for volume using the arterial pressure and to remove the inflation impact or augmentation from the volume calculation. In the left graph above, a non-assisted arterial pressure waveform and associated flow wave are shown. This information is used to determine the start and end of the systolic portion of the waveform. Now, on the flow wave, the aortic valve closure point to the stable or flat portion of the flow is also determined. The information is used to determine the relationship between pressure and volume. In the right graphs above, during the assisted beat, the position of the aortic valve closure is used to fit a line in red. If you can see that red up there, it's pretty fine, between the aortic valve closure and the end of diastole, or lowest point on the AP. This iteration removes the augmentation pressure from being added as volume from the left ventricle. The flow wave fit from the unassisted beat is applied to aortic valve closure to essentially zero the flow and remove it from the calculation of volume. Now, these iterations are run multiple times to get to the baseline and then continuously on a beat-to-beat basis to allow the calculation of stroke volume and cardiac output. Now, this is an example of an early version of the algorithm's performance, and the top graph there shows the assisted arterial pressure waveform in a 1 to 2, something we're all used to looking at. And it is important to note that if you can see the colors, the red and the blue markers accurately detect the start and end of the systolic component of the beat, with red obviously noting the aortic valve opening and then blue the aortic valve closure. This step is critical to ensure only volume from the left ventricle is used for the calculation of stroke volume. Only the area between the red and the blue markers is included. The second graph, the middle one there, shows measured stroke volume from the conductance catheter, which is placed in the LV against the calculated stroke volume from the algorithm. The plus sign indicates the measured volume, and the circle is the calculated volume. In the early version of the algorithm, the comparison indicated good ability to follow the change in stroke volume, but the separation, reduction, and accuracy of the stroke volume measurement. Now, further iterations, further runnings of that algorithm did reduce this difference between the two. The third graph shows the left ventricular volume change measured by the conductance catheter. The red marker indicates the beginning of systolic ejection, and the blue marker at the end of systolic ejection. Remember again, LV volume is inverse of aortic pressure. So this measurement is used to determine the measured stroke volume for comparison to the stroke volume calculated by the algorithm. Now, this slide shows the performance of the current algorithm during vena caval occlusion, and this produces obviously a very large change in stroke volume. The top graph on the left shows the arterial pressure waveform in assisted 1 to 2 with the beginning and end of the systolic component of the waveform marked, and you can see the reduced pressure at the end of the trace after that occlusion. The second graph is left ventricular volume, again measured from the conductance catheter, showing the reduction in stroke volume at the end of the trace. And the third graph shows the measured stroke volume, plus sign, and calculated stroke volume with the circle, and you can see that the updated algorithm, completing further iterations for each beat, shows the stroke volume is much closer to the measured volume and correctly follows the change in stroke volume. Calculated precision here of the algorithm is 4.3%. The upper right box shows the data for each individual patient data that we used, and the line represents the mean stroke volume, and the data points closely follow the line for each patient. The Bland-Altman analysis shows the level of agreement of the calculated stroke volume is within plus minus 5 milliliters of the measured stroke volume. Most importantly, the ability of the algorithm to follow the change in the stroke volume is confirmed with a high precision or accuracy. Now, here's our favorite kind of patient on a balloon pump. You have those arrhythmic patients, and this is going to show the performance of the current algorithm during significant arrhythmia. And we all recognize again that arrhythmias can produce significant variations in stroke volume from beat to beat. The top graph shows the assisted arterial pressure waveform in a 1-to-1 assist with the beginning and end of systole, again component waveform marked as before, and you can see the reduced pressure at the end of the trace. Second graph again is measured stroke volume compared to our calculated stroke volume, and you can see that the updated algorithm for stroke volume is much closer to the measured volume and correctly follows the change in the stroke volume on a beat-to-beat basis. Calculated precision here is 7.6%. The upper right box shows the data for each individual patient, and you can see that the data points follow closely along the line for each patient. Bland-Altman shows that the level of agreement of the calculated stroke volume is within plus 8 mLs and minus 5 mLs of the measured stroke volume. The ability of the algorithm is clear to see that we can follow the change in stroke volume, confirming even in the presence of beat-to-beat stroke volume changes such as an arrhythmia. Now, in the worst case of stroke volume changes, this is really showing us the final example here is from the balloon pump going off to on from a single patient. So this is just one patient data. This event produces the most dramatic and abrupt change in stroke volume over the shortest time for patients. Now, the top graph shows the arterial pressure waveform when therapy is initiated. Again, the beginning and end of systolic component of the waveform is marked, and you can see the reduced pressure at the end of the trace after the balloon pump has been initiated. That's our goal. The second graph is left ventricular volume measured by conductance catheter, and again, you can see those changes there in stroke volume. And the third shows measured compared to calculated. You can see that the updated algorithm stroke volume is much closer to the measured volume and correctly follows the change in stroke volume. However, for a few of these beats, as the pumping is initiated, the separation of the data is visible. Now, calculated precision or accuracy is 11.2% during the change, so initiation of therapy, but does return to 4% after the stroke volume is stable. This is the highest degree of inaccuracy seen, which is still within the accepted performance of thermodilution cardiac output at plus and minus 15%. The upper right box shows the data for this individual patient, and the line represents the mean stroke volume, and the data points obviously follow along closely. Bland-Altman analysis shows that the level of agreement between the calculated stroke volume and measured is plus 11 to minus 10 cc's. This is the widest range of the level of agreement of all cases. Now, these are graphs showing the performance of the stroke volume calculation in a balloon pump as compared to the computer program that the algorithm was developed in. The performance of the algorithm in the pump is virtually the same as the algorithm as it was originally developed. These graphs confirm that the pump is able to calculate and follow the stroke volume changes. This graph shows us from pump off to pump on, again, the worst case scenario for accuracy, comparing the algorithm's performance in the balloon pump as compared to the original computer algorithm. Again, this confirms that the balloon pump algorithm is implemented correctly and working as well as the original. So in conclusion, the ability to accurately calculate stroke volume and cardiac output from the arterial pressure during balloon pump therapy without any additional equipment introduces an important conceptual tool for clinicians to determine if the balloon pump is the right therapy for a given patient and to determine if it is meeting the goals of therapy. The first paper on the performance of this algorithm was published in 2021 and confirms the accuracy range for 4 to 11% with an average of 7% and the ability to follow the changes in stroke volume even during balloon pump support. This is well within the accepted accuracy of thermodilution cardiac output. With new tools such as stroke volume cardiac output calculation shown by this method, clinicians will be able to determine the best course of therapy for a specific patient and see the impact of therapy decisions from the start of therapy. We believe that this will help clinicians provide the best patient care possible and make decisions based on available data. Thank you.
Thank you, Casey. James Filipich asks, can this new technology be retrofitted to current equipment?
We are not at that stage yet, so we are still just in that development stage. This is all preclinical, so that will be developed and decided down the road. So I don't have a solid answer for that right now. I wish I did. Okay, thank you.
Okay, thank you, Casey. Our next section is coming together right now over you. This is for all of our companies to be able to tell you where they are right now, where they're looking to go, any new products that are coming up. For those of you that are in the audience, you're able to see all of this, or at least things that are FDA approved, out on the floor. For all of you at home, this is really for you to be able to experience the manufacturers without actually being here in person. So our first is Eva Casamento from Humanetics Corporation. Eva? Thank you.
Good afternoon. I'm so pleased to be here live with all of you. It's so much better than last year when we were all virtual. And today I want to share a little bit about my company, Haemonetics. You know us as a pioneer in patient blood management, and we've certainly strived to continue to be innovative and emerge as one of the leaders in patient blood management in the world today. Last year, we actually celebrated our 50th anniversary as a company. It was probably a little low-key because we weren't in person in very many places, but for all of you, it means that during your entire career as perfusionists or other clinicians, Haemonetics has been with you for your entire career. So we were founded by Jack Latham in 1971, and he lived in the Boston area. There's a lot of startups, as you know, in the Boston area. And he actually invented the disposable Latham bowl in 1968 and then founded the company in 1971. And he was driven by a vision to improve the safety and quality of the world's blood supply. And that's all Haemonetics is still about today. We are all blood, all of the time. Every one of our products has to do with the safe acquisition of blood, collection of blood and plasma, the safe storage, the safe distribution in hospitals, and of course, where possible, the prevention of unnecessary blood transfusions by the use of things like Cell Saver. And if you heard Dr. Morant's talk yesterday, you heard him talk about the use of TEG as a way to reduce the use of allogeneic blood in his hospital, Toledo Hospital. So the blood supply, maintaining blood supply, safe blood supply, high quality blood is all about what we are at Haemonetics. So you can imagine the concern that we had when the American Red Cross declared a national blood crisis in mid-January. Now, we'd been monitoring the situation all throughout the pandemic, and interestingly, there is not one central point of information for the status of the nation's blood supply at any time. And it's, typical of the United States, it's about the free market, people's willingness to donate blood, their ability, they have to be healthy enough, of course, to donate blood, and it has worked well for decades and decades, right up until mid-January. So we have a scientific advisory council, and some of them are leaders of blood banks at large hospital systems in the United States. And even at the beginning of the pandemic, they were expressing their concern, their fear that there might be a blood shortage in the United States and in fact around the world. So it's something we monitored. And New York Times actually broke a story in June of last year talking about the emerging blood crisis, and there were multiple stories through the fall, right up until we heard the ARC make this declaration. And it's something we really took to heart because the mission of why we're around is about blood. And if you heard John McCaskill's talk yesterday, he talked about start with your why. Remember, he talked about his why as a Navy SEAL. And our why is about the safe collection, storage, distribution, and use of blood and helping patients and helping hospitals. So let's look a little bit deeper about how this crisis happened. There's always fluctuations in the supply of blood in the United States, but we had forces that were acting on both the supply side and the demand side. So let's talk about the supply side. So as everybody quarantined in the early days of the pandemic, of course, blood collections plummeted. And about 25% of the blood collected in the United States is from high school and college students. So when high schools went to remote learning and colleges went to remote learning, they canceled all the blood drives. And they really haven't rebounded at the pre-pandemic levels. And blood collections haven't rebounded to pre-pandemic levels. So there's been a struggle to rebuild the blood supply. On the demand side, I think it's first important to understand, well, what is the demand for blood in the United States? So again, according to American Red Cross, every 2 seconds, someone in this country needs blood or platelets. And in the course of a year, there are 16 million units of blood transfused in this country. And if we look at a daily rate, there's 29,000 units of red blood cells, 6,500 units of plasma, and 5,000 units of platelets. So that's the typical demand daily and annually in the United States. So the other forces acting on the demand side, it's starting in about mid-2021, and you all know this very well, there was a rebound on elective surgeries. So if you think back to the early days of the pandemic, some of you might have been sitting at home because cases were getting canceled and only the most emergent ones were finally being scheduled. So we started to see more regular patterns of surgeries in the middle of last year, and that continued into the beginning of this year. And in some cases, if patients waited, they were sicker by the time they got their surgery, and they may have needed more blood than had the surgery occurred on its original time schedule. In addition, very regrettably, there was a double-digit increase in the numbers of traumas in the United States. And some of that was, again, people going from being quarantined to, I am vaccinated, I'm gonna get on a plane, I'm gonna get in my car. And unfortunately, there's a lot more penetrating traumas as well as other people got out and about. So both of these things, both of these sets of forces were acting, and it really put things out of balance in our blood supply in this country. And all of a sudden, this became the image in the blood bank. Empty bins and empty shelves. This is from a large hospital system in the United States where almost every shelf is empty. There's more empty shelves than full shelves. And again, a lot of empty bins. So in mid-January, the reason the crisis was declared is type O blood, which in a blood bank is about 3 to 5 days of supply, went to less than half a day. So some really hard decisions had to be made about who was going to get that blood, which surgeries, did we have the right blood to cross-match to the patient, did we need to save that half day of type O blood for trauma patients that might come through the ED doors that particular day. So a really dire set of circumstances that were just unprecedented really since the establishment of what we currently have as the American blood supply. And so you can imagine at Haemonetics, if we're all blood all the time and we care deeply and passionately about patient blood management, you know, we did a lot to do more messaging about the use of our products because we have the privilege of being able to benefit both the demand side and the supply side. So on the demand side, you're all so familiar with Cell Saver that can help to give a patient their own blood, the best kind of transfusion there is. And TEG, if you heard Dr. Morant's talk, he talked about the importance of a TEG system as part of a patient blood management program, and he talked about the significant reduction of every blood component in his hospital system, Toledo Hospital, since the use of TEG 5000 11 years ago. On the supply side, should a patient need to have donor blood, we are with you every step of the way. So MCS stands for Mobile Collection System. That is our blood collection system. PCS is a plasma collection system. So we collect whole blood, we have blood apheresis, and we have plasmapheresis. And then, should it make its way to the hospital, something you may not be as familiar with, we have two products that help with that, SafeTrace TX and BloodTrack. So SafeTrace TX is a blood bank information system. It is what is used to manage the blood in the blood bank, and it connects with the hospital information system, things from Epic and Cerner and Allscripts. BloodTrack is a point-of-care blood management system. So it's also software. It works with SafeTrace and other types of software. And there's a hardware component to it as well. There are refrigerators for the storage of blood components. And it works a little bit like a Pyxis system, but for blood components. So an authorized employee can go and get the blood that's been in blood components that have been prescribed by a physician, deliver them safely. They're stored at the right temperature. They're cross-matched to the patient. And again, every step of the way, from collection to distribution, Haemonetics has a role in that. But it's not enough to rebalance the scales. We actually have to tip them more. Ideally, supply is more than demand. And so it's a really great moment for me to take some time and appreciate all of you in your role as perfusionists. The work that you do every day in ORs in the United States and throughout the world absolutely make a difference in making sure that patients first get their own blood back, and if needed, a lot of you run TEG and other viscoelastic testing machines, and you help to assure that the right component gets to the right patient in the right quantity and at the right time. So in closing, I think back over the innovation that Haemonetics has delivered in the last 5 decades, and we have a very robust pipeline where we have new product development, product improvements, and clinical studies that are all in process across that whole portfolio I told you about, from blood collection and plasma collection, the software products, Cell Saver, as well as TAG. And I really look forward to sharing that with you at a future Sanibel Symposium. Thank you very much.
Thank you, Eva. Our next speaker is Jim Kamsa from Cytosorb. He is the Vice President of Sales and Marketing.
Hello, I am Jim Kamsa. Sorry. Let's put it in presentation mode. Maybe not. There we go. Hi, I'm Jim Kamsa. I'm the Vice President of Sales and Marketing at Cytosorbents, and I do appreciate the work you do, and I really appreciate the chance to give you an overview of our company and our products and why we're here. And thank you again to Perfusion.com and Carla for putting on a nice intimate meeting like this so we could share these ideas and thoughts. If we go back 10 years, Cytosorbents was a relatively small company. It had about 20 employees. We were funded by some grants, DARPA grant, military grant, NIH grant to study blood purification and some of the applications of that. Originally, it was like a think tank, and these projects take a long time to get to market. The outcome of some of these have resulted in products that are launched over in Europe or outside the US, and we have a couple of things here as well. But one of them is a polymer, and I'll show you exactly what that is. Oops, sorry. This is one of our cartridges. You can see it out on the floor over there, but inside it is I would say it's a biocompatible, highly biocompatible porous polymer bead that acts like a tiny sponge to absorb different molecules of different sizes and hydrophobicity. The image on the left is just one of our cartridges cut in half, so it's packed with the polymer. The second image is showing the blood flows upward through it. That third image is a bead itself, and the bead is, they're round, they're about the size of a grain of sand, and the image on the far right is a very close-up of the surface of inside one of these beads. So while they're very small and it's a small 300 ml cartridge, it has a surface area of 7 football fields. So it's very effective at absorbing molecules. From a perfusionist perspective, leveraging the technology is very straightforward. It's plug and play on most systems in hospitals that you are familiar with, dialysis or CRRT, ECMO, hemoperfusion, or cardiopulmonary bypass. If you jump forward to today, fast forward, we are a publicly traded company on NASDAQ. Our ticker symbol is CTSO. We have 230 employees and growing every day. We've been on Deloitte's Technology Fast 500 company for multiple years in a row, and we're just building out a brand new facility in Princeton, New Jersey, much larger, I would say 5 times as large, to accommodate some of the rapid growth that's coming. The current technology is used in 70 plus countries, but in the US, it's really a tale of two products. The first one is Cytosorb. And some of you may have heard of that, but we have an emergency use authorization for critically ill adult COVID patients with imminent respiratory distress. Dr. Hyanga spoke of it, others have spoken on it already. Under the EUA, cytosorbents can become available for a very specific set of uses, but typically this is the more detailed EUA that comes with it. If you're interested in that, we can get that to you at our booth. Cytosorb's emergency use authorization is defined, it's for acute lung injury, severe disease defined as, and you can read through this, life-threatening diseases, septic shock, multi-organ failure, but typically you'll see it has been used in about 50 accounts here in the US hospitals, and as Dr. Hyanga said, the results of our CTC registry were quite compelling, increasing survival when selected on the right patients and used at the right time. I won't go into all the detail here, but you have a number of hyperinflammatory or inflammatory mediators like ferritin, C-reactive protein, IL-6. The cartridge can absorb and reduce the levels of those, reducing the inflammation. And we've seen common findings are inflammatory mediator reduction, reversal of shock and weaning off vasopressors, and objective improvement in lung function. I will not go into too much detail here because Dr. Hyanga already discussed it, but this was a multi-center registry that was published, and we saw survival of 73% versus around 50% on a much larger ELSO registry. If we continue to look at 2022 and focus on another product, it's DrugZorb. You'll see out on the floor a DrugZorb display. We have two breakthrough, and DrugZorb is based off of a similar technology but a little bit different configuration of a system. We have two breakthrough device designations, two pivotal randomized clinical trials, and they are called STAR-T and STAR-D. I'll get into that in a little more detail. We have the actual rationale and design of the trial paper out on the floor if you're interested in it. If you think your facility might be interested in exploring this, what these are called the safe and timely antithrombotic removal of ticagrelor. So STAR-T and STAR-D is similar but for DOACs. So we already know from some use of similar technology outside the US that it is a very effective remover of these drugs. And in patients that are undergoing urgent or emergent cardiac surgery, real-time placed into the CPB circuit, you can remove the drugs, theoretically reducing bleeding complications and providing some economic benefit. But these are not available in the US yet, and the trial has to bear out those results. JCS published a study out of Canada that identified bleeding risk as the most significant consideration when performing cardiac surgery on patients loaded with ticagrelor. The authors concluded that ticagrelor bleeding complications were a major concern and recognized a significant unmet clinical need. We've heard similar data from around the world and feedback, and in the US as well. So we're quite anxious to get these underway. The DrugZorb timing. Looking forward, while we are already enrolling, but we are still recruiting centers and investigators. If interested, we can put you in touch with our clinical research team. We're looking for the interim results this fall with the STAR-T trial expected to wrap up by the end of the year, and the STAR-D trial would be wrapped up approximately a year later. These are estimates based on enrollment rate. Again, DrugSorb is investigational and not available for sale in the U.S. at this time. So really, just to give to summarize here, our why is we were a small company funded by some research grants to look at different blood purification techniques. During the course of this research, we found several that can be commercialized. We have a company that is publicly traded based on sales and results outside the U.S. In the U.S., you're available for EUA for COVID patients, and we have these 2 trials enrolled. So I really want to thank you for what you do. We appreciate the work you do, and perfusion is a critical part of how our products are used, and perfusionists play a big role in that. So thank you. And to Carla and the Perfusion.com team, we really appreciate these small meetings and the way we can form relationships, help patients, and bring these technologies to market. So thank you.
Hey, Jim, we have one question from Alyssa. Is there any research or any papers out there that shows the percentage that CytoSorb increases level of survival in a COVID patient?
There's the CTC registry is published at 52 patients, and it showed a result of 73% survival at 90 days. That is comparable to some larger databases from ELSO that show survival at about 50%. So there is a significant increase shown in that study. I think it was referenced earlier. That study has continued, or that registry, and there are now over 100 patients in, and the numbers are still the same. It's still over 70% survival. So pretty good results. Thanks.
Thank you, Jim. Our next speaker is Courtney Novello. She is with Specialty Care. She is Director of Operations, the South Atlantic region. Courtney?
Thank you. Let me get it in my slideshow. There we go. Maybe. Did I mess it up?
Wait a second. There you go.
Okay. Good afternoon, everybody that's here or at home. I'm actually really happy to be here. I was thinking about this, haven't been in person at a meeting since, I think, 2019 at a Florida Perfusion Society meeting. I've met many of you there helping put that meeting on. I was asked to get up here for Specialty Care by the ladies in the back, the recruiters, and talk about some of the great things that we have had going on. And in preparing this, I was kind of like, all right, I don't sell a product, but then again, I do. I sell people and I sell our service. And so I'm just going to go through a couple slides here. This one says, what are the people saying? So in preparing for this, in my new role as a DO, I reached out to my teams, some people that have been around a long time, couple that were hired in the last year, and I wanted to know, what are you thinking? Because if you're not thinking what I'm thinking about the company, we need to talk. And I got some of the best responses you just wouldn't believe, and I just wanted to highlight a few. And what my staff were saying about our company and saying, everyone cares for and takes care of each other. The next one I think is super important, access to an abundance of education and knowledge. And as a perfusion staffing company, education and making them feel that, they have someone to reach out to is really crucial. It says, the next one, which I think is pretty funny, one of my area managers says, specialty care does not try to micromanage my accounts. My team has the freedom to manage day-to-day operations as we see fit. I think that's pretty funny, and that we're allowing them to do what they need to do in their accounts. I'm thankful for our wonderful supply chain team. I have to say that as a company, we have been able to make sure our teams have the products they need, and we haven't canceled any cases due to pack shortages that everybody's experiencing. It may not be exactly what everybody's been used to, but we've been able to get something into those accounts. The last one says, specialty care has encouraged our team to continue to grow and use our strengths to better develop the service line and welcomes our input. These are just a few photos I found of our great teams around. We aren't just a perfusion staffing company, we have other service lines. And so on here, there's some of the IONM folks. I have surgical assist folks, some of my ECMO specialists, and then the recruiters are on this picture on the end here. I just keep having to highlight them. Some of our service lines that you may not know we have besides perfusion, we have a very large intraoperative neuromonitoring service line across the country. We also provide surgical services that include sterile processing and helping the hospitals with that service line, and also autotransfusion. Speaking of perfusion services, since this is a perfusion meeting, we are the market leader. We are in 1 of 8 open heart procedures in the United States. We are accredited by the Joint Commission. We have a huge database that Al helps manage, but has over 40,000 cardiac surgical cases in it, has over 1,000 ECMO cases and 65,000 ATS cases in order to help us do our quality reporting and standards for our hospitals. We're innovative in our field. We use that data to detect and diagnose any kind of outliers and help make changes so that our hospitals see what's going on. We're very open with our hospitals, and if we need to make changes to something we're doing, we do it. In clinical education, I talked about that already. We have a program to help our staff perfusionists move on up and keep going so that we can hire from within our company. And then I wanted to throw this in here. This is my last slide. I'm going to give you guys back some time, but this is, ECMO is huge. You guys are seeing all the talks about ECMO. It's all of our world. These are some of the ways that we've been partnering with hospitals lately and going in and either looking at the ECMO program that you already have going on and helping you tweak that, add things to it, provide education. We have turnkey where we can come in and do train ECMO specialists, train RNs. One of the things that just started within the last couple months is a cannulation program. We're actually teaching the physicians to cannulate. We all know our physicians can cannulate, but when they want to bring it over to the cath lab, maybe they need a little bit more education. So we've partnered with a bunch of great ECMO people across the country to get all these different educations going on. If you have any questions about anything that we offer, if you're looking for a job, if you're, anything, myself, Sarah, and Courtney, we will all be at the bar. Al, Alicia will all be at some bar within the next 2 days. Come up and ask us some questions, okay? Thank you.
Thank you, Courtney. Is Dave DeWint here? There you go. Our next speaker is Dave DeWint with Medtronic. He is the Senior Product Director.
Hi, thank you. Dave DeWint actually just had an emergency, so I'm going to take over for him here. My name is Neil Nye. I'm in Dave's organization in the global marketing team with Medtronic in the extracorporeal therapies business. I lead the ECLS and Perfusion marketing team. So I'm going to share what Dave had planned. He just had an emergency come up, so I apologize for the change. Thank you for your patience here as we make a pivot. Do I need to? Oh, okay, it's coming up. Do I need to change the display setting here? 2 more seconds to come up. Yeah, thanks so much. Apologies for the technical challenge here. I just want to just start off just talking a little bit about Medtronic. You know, we've got a legacy that started in the late 1940s in a garage in Minneapolis, and our founder Earl Bakken had a dream, and you know, inspired by Frankenstein, inspired by Popular Electronics magazine, he developed the world's first wearable pacemaker, and you know, starting off with a partnership with Dr. Walt Littlehigh. So we have a long heritage in cardiac surgery, and years after that, we've had an enduring mission to alleviate pain, restore health, and extend life at its foundation. But there's a lot more to it than that, and you know, from that first battery-powered pacemaker to you know, everything else we have across the broader Medtronic organization. You know, our purpose and our foundational mission is still the same today. And, you know, it doesn't just inspire us just to show up every day and deliver the best products we can and best service and solutions, but just to show up and be extraordinary in everything that we deliver here. And, you know, to the point now where we're impacting 2 patients every second of every hour of every day, you know, with our products across Medtronic. And we're really proud of that and wanting to, we can only do this with you, our healthcare providers, as our partners in this. It's not something that we can do without you. So we really appreciate the partnership. If I take a step back and just like look at like our cardiac surgery business here, you know, our vision and plan, we've got our therapies, and then we've got all of the enabling pieces of it that fit into that extracorporeal therapies piece, whether it's our cannula, our oxygenators and reservoirs, and also we have the ECLS therapy that is where I'll focus mostly on today, talking about our extracorporeal life support, as that is becoming a big focus for us and our energy investment in the extracorporeal therapies and the cardiac surgery business right now. And with ECLS, you know, really just want to say that our mission is your mission. We want to be a partner and a comprehensive solution provider, and we've been building a pipeline of products, and you know, we've been really proud to be able to be delivering this cadence of new products as we've been moving along here. And part of this has been enabled just through our partnership with MC3. You know, this is Bob Bartlett's you know, baby in a way, and they have some fantastic engineers and have developed the Nautilus Smart technology, as well as you know, the Crescent and Crescent RA cannula. And we would love if you'd stop by our table tonight during the reception. We could talk with you more about the details of these products. You know, at a high level, really looking at, you know, how do we provide that comprehensive solution across the entire portfolio here? And, you know, whether it's through vascular access, VV with dual lumen, or VA with single lumen, you know, building out different offerings there. We just received clearance for our LS line of cannula, and we have those here on hand and planning on launching those here in the coming months in the U.S. We'd love for you to take a look at that and just see how they might fit into your practice. First cannula indicated for both long-term use and also for bypass. So a lot of flexibility and options with those cannula. And then also just all the support products, whether it's for gas exchange, tubing packs, vascular access, and we also have patient monitoring there with INVOS, the cerebral monitoring, and diagnostics as well. There's been some conversations about HMS during this show, and we'd love to talk with you more about that in terms of your blood management strategies. So just getting into a few of the high-level details with some of the products here. For Nautilus Smart, the best way to look at this is just to come by, stop by, and I'll talk with you personally about the product here and the features and benefits and our design approach to this gas exchange module. Really a few different things here that we're focused on. A lot of it really around just creating this circular flow path, looking to improve long-term gas transfer and durability. And I would love to show you the details of that with the product at the exhibit. The other thing with this that is a real differentiator is just the integrated monitoring for this. So if your aim is to have a simplified circuit and you want to have some of that fundamental information that's going to help you understand what's going on with your circuit and with your patient, the sensors are built directly in to this gas exchange module. So, if you can see the display on the bottom, the left side are the venous measurements, and on the right, the arterial. So pressure on both venous and arterial side with the delta calculated in the middle, so you can keep an eye on that pressure delta across your gas exchange module, and then the saturations inlet and outlet there as well. And across the top, you can see on the right there's the top right, green bar when everything is within the parameters that you want. And so you have the opportunity to set alarms wherever you would like, or not have alarms on there. When it alarms, there's a tone, and you'll see the gold light. So, during COVID, especially if you just wanted to look in the room, see if everything's okay, see the green light, you got your parameters set, then you don't necessarily have to just have that burden of being fully gowned going in and just to take a look at what the levels are there. So fully customizable in terms of where you set your limits and parameters on this one. Going to the vascular access side, really excited about our dual lumen cannula, both for the adult and pediatric side, the Crescent. Really come take a look at the flow curves for this thing. Really exceptional flow on the product. Positioning is really improved with the tantalum markers on there. So, if you're doing a fluoroscope, you can see right away if the return is going into the RA. And then the securement piece. A few different ways to attach this, make sure it's not going to rotate out of position. Just looking at where things were in the market before we came in, and how do we take things to the next level and improve things and just alleviate some of your concerns that you might have around just securement and rotation of dual lumen cannula that's jugular access. And then recently released a pediatric version of this, Crescent RA. You can see that it has that right atrial design, and just you can see in the image there where it just sits down for the return. Really happy to have a product back in this part of the market for pediatric, but a lot of the same features that we have on the adult size Crescent with really great flow for the catheter size and great securement on this. And again, the visualization, being able to see where the tip is and how it's positioned. Now with our biomedical life support, all of our single lumen cannula, a lot of different options on here. You can see the ones with the white caps on the top. We call those a flex because you can use those both for drainage or return. So a couple of options to use for those. We also have the drainage cannula and also return cannula, including the mini ones there. And so these are a full range that are approved and have 2 IFUs, one for ECLS and ECMO, and one for cardiopulmonary bypass. So a lot of flexibility in what you could do with this range of cannula in your practice. So with that, really high level overview of where we are right now with ECLS. Not really giving you a lot of clues of where we're going, but really just wanting to say that You know, we want to be your partner. We want to develop that full comprehensive solution for ECLS, and would love to talk with you one-on-one. Thank you for the time. Appreciate your attention.
Thank you. Our next speaker is with Fresenius Medical Care, Chris Pearson, VP of Marketing and Product Management. And for all the manufacturers, if you will go onto our live stream, we have people that are asking questions about your product. Some of them are requesting information about your product. Some of them are putting their emails down for you to be able to respond to them with specific questions. So when we finish, if you could go back in today's session and look at those comments and respond, that would be great. Thank you.
My name is Chris Pearson, and I wanted to thank the Perfusion.com organization for organizing the meeting. Heard some outstanding presentations earlier today, and appreciate the opportunity to provide an overview for the group. You'll hear Fresenius Medical a fair amount, and the focus of our company at Fresenius used to be having a tough time advancing these. Not sure it's
All right.
This is page down, right?
Yes.
Sorry about that. A bit of a false start. Anyway, Fresenius Medical Care, as you may be aware, has a large dialysis presence in healthcare. That's one element of the company. The other element of the company is what Fresenius has been working on for about the last decade, and that's expanding our portfolio beyond renal. So we have made some very conscious efforts to extend and advance beyond renal, specifically the heart and lung area, as well as other multi-organ system failures. So Fresenius is an umbrella company. We are going through a bit of a transformation, which is exciting, but within that umbrella company, we've got the heart and lung division of Xenios that we refer to as Novolung in the US. I'll also speak to briefly our ongoing commitment to product development. In terms of our vision, we really are looking beyond the organ. We're looking at the quality of life. We're looking at the overall care within patients that find their way into the ICU that have multi-organ system failure, and we're doing this globally. I'll get to that in a bit of a second. In addition, as we look at healthcare and the economical challenges, the clinical challenges, we're looking at bringing the simplest and safest methods or therapies into the market. And we've started this in Germany with Xenios recently, and we're just starting off in the US. In terms of our care model and what this kind of matters or means to you, the organization has a significant amount of assets and resources that we're stepping back and saying, okay, where do we apply these in the ICU? And we're squarely looking at the heart and lung space and across all organs, but we're squarely focused on heart and lung, and you'll start to see that in the U.S. more frequently. In terms of Xenios, this is the company that Fresenius acquired, and just a bit of history, just in terms of who we are. I think that's probably the important starting point. And Xenios was acquired by Fresenius Medical Care. Within Xenios launched into the U.S. in 2020. It was right in the January time period in 2020, which coincided, imperfectly or perfectly, with COVID. So right now we're sitting in a position where while we rolled out and we received approval and we were excited about that, we're the only clear device for ECMO in the U.S. We were kind of put on hold for about the last 2.5 years. So attending these meetings, being able to have an opportunity to share what the broader Fresenius is really a pleasure, and we were focused on doing this a couple of years ago. We're expanding into the U.S. now, and we're in a number of centers of excellence, including West Virginia University. I'm not sure if folks had a chance to hear Dr. Hayenga's presentation a few moments ago, but we're proud to be part of the care team in some of the universities that are providing the best care. In terms of what our footprint looks like, we're very focused in the Xenios headquarters, which is in Germany. We've got a medical center that has been working with thousands of patient runs. We've had over 15,000 ECMO patient runs over the last decade. And we've got a data repository at Rheinigen University. Heilbronn is where we're headquartered. In terms of the employees, the Xenios group, including the US, has over 300 employees. We've got 14 countries that we're selling directly in, and we've got 46 countries that we're distributing in. Again, I would say to be frank about what we're doing in the US, we're really just launching as we speak. And we've been in a handful of teaching institutions with strong success over the last 12 to 15 months. In terms of our heart and lung therapy system, compliance has me focused, as it should be, on speaking to our indication. And we are indicated, I'll just read this, we're indicated for long-term over 6 hours respiratory cardiopulmonary support that provides assisted ECMO and physiologic gas exchange of the patient's blood in adults with acute respiratory failure or acute cardiopulmonary failure where other available treatment options have failed. So as we look at where other clinical treatment opportunities have failed, this is where our approval is focused on. And we're proud of this clearance. We're proud of being the only clear device with over 6 hours of treatment. In terms of a flavor for what the product is, I wanted to tee up a video, and then it's less than 90 seconds, so I think it'll be right to the point, but this provides you a real clear overview of the Novolung product.
It's time to go further. Fresenius Medical Care is the trusted global leader in renal care. Now, we're taking our commitment to patient health even further with Novolung, the first extracorporeal membrane oxygenation system cleared for use for more than 6 hours. The Novolung system is an extracorporeal life support system that provides extracorporeal circulation and physiologic gas exchange for patients with acute respiratory failure and acute cardiopulmonary failure, providing a new option where conventional treatments have failed. Novolung offers a single integrated heart and lung therapy platform. The system is focused on supporting critical patient care, reducing the need for intubation, allowing mobilization, improving survival for patients in cardiac arrest, and impacting postoperative recovery. Novolung features innovative technology. A powerful membrane lung provides gas exchange and hemocompatibility for long-term applications. Integrated pressure sensors enhance safety due to the elimination of pressure measurement lines, and an intuitive touchscreen, hot swappable battery packs, and a central sensor box create a single, fully integrated system. Insist on safety. Deliver accuracy. Provide new treatment options for your most critical patients. It's time. Choose Novolung.
I know that felt like a bit of a commercial, but I wanted to just underscore a couple of points. And we are proud of our safety profile. And as perfusionists and ECMO specialists in the audience and at this meeting, that there's two elements that we believe may make your job a bit easier. Those are the pressure sensors, number one, which I know are available in other devices. But we've got highly accurate pressure sensors and easy to read readings on our screen, so you can get a clear idea of when failure or clotting is happening in the oxygenator. Separate of those pressure sensors and separate of the assessment of the oxygenator is the assessment of our pump. Our pump head has a pump index that measures power. And over the course of the treatment, failure can happen through a number of avenues. When I say failure, I mean the therapy either becoming less efficient or stopping. The first is the oxygenator, if that's a culprit, and the second is the pump head. And if the pump head is working too hard and pumping too hard, and you're not getting the results you need, we've got a graph that shows that as well. So that gives a clear indication of when the pump head may need to be changed. While that doesn't happen all that frequently, it's a safety measure that we're proud of. And you might have noticed the second pump head in our system. A second pump head is a backup, so no hand cranking. And we've got 2 backup battery supports. So our ability to have safety measures to measure pressure and to measure how hard the pump is working are allies that, as care providers, perfusionists and ECMO specialists, we hope you find valuable. Of course, we're always looking to develop, and as the leader of product management and product development, I'm looking forward to continuing the pipeline of products in the future. Thank you for listening.
Thank you, Chris. Our next speaker is Levanova, Larry Petrie, Senior Marketing Manager. Larry?
Very good. Thank you, Carla, for the introduction, and I appreciate you notice that I am not Elizabeth Martin. Her name is in the agenda, and it was left over from last year. She gave our talk, so I'll be carrying that on today, and hopefully do as good of a job as Liz did for us last year. Many of you are familiar with LivaNova because of the products that you use, but you may not be familiar with all of the different products we use or the company in whole. We are nearly a $1 billion company in terms of sales. In fact, we're about as close as you can get to that without going over the line. We look forward to doing that. Our focus every day is to improve the quality of patients' lives. We do that by targeting underserved markets in the medical device space and looking for those areas that are going to grow where we can participate. And we have strong positions in advanced circulatory support, also known as ECMO, cardiopulmonary, which most of you are familiar with, and then neuromodulation as well. If you look at a breakdown of our sales from last year, what you'll notice is that we're pretty well balanced between the extracorporeal space and the neuromodulation space. That gives us a great synergy between the two and the ability to build in both platforms. We also were able to achieve a 17% increase in sales last year, which, given all the present challenges that we face, we were quite pleased with, and we look forward to that growth continuing. Most of the products that you are familiar with are in the perfusion space, and that includes the S5 heart-lung machine, which controls a really large portion of the market share worldwide and builds on 40 years of experience with heart-lung machines. The Inspire oxygenator, which has crossed the threshold for 2 million patients treated, and very soon will be crossing the 3 million threshold. And then the Extra Auto Transfusion System, which treats over 500,000 patients a year. So that's the platform most of you in the perfusion space are familiar with. We build on nearly a half a century of experience in life-sustaining technologies, going all the way back to the Stockert pump, which was originally introduced in 1973, and then the S5 pump, which came out in 1994, a very long list of oxygenators that all represent incremental improvements to oxygenator design, leading into the Inspire family, which we distribute today, along with the S5 that I mentioned earlier. In 2015, Sorin merged with Cyberonics, and that's how LivaNova came to be. And we continue that innovation, and with the rest of the time that I have, I want to spend a little bit of time showing you what might be in the future for you that we can offer. The first one is an innovation on the S5 platform, which we call the S5 Hybrid. It's hybrid because it's a smaller footprint. It's designed to fit into operating rooms where floor space may be at a premium, and it's 27% smaller than the S5. It also takes up a little bit of a different form factor in terms of having a wider footprint than the SCPC did, which makes it much easier to maneuver into these smaller spaces. The S5 Hybrid also can be used with many of the optional accessories that many of you are familiar with the S5. That includes multi-display control panels, our new blood gas system called BCAPTA. We have new alarm software that has been upgraded to match new standards and help you better manage cases, along with the ability to do either base or mass-mounted pumps. We are also very, very pleased to introduce at this meeting and a couple weeks ago at AMSECT the Essence Perfusion Patient Monitor, which represents the new generation of our development in this space. In developing a perfusion monitor and an electronic medical records platform, the first thing you think about is the clinical needs for it. And that was primary in our focus. And what we're able to do is, with this system, reduce the time that you spend on manual entry and remove some of the guesswork around interpreting the data that comes out. We also want to pay attention to helping advance patient care. And we do that through some quality indicator improvements that I'll go into in just a minute, and then also the addition of the goal-directed perfusion monitor built into the system. But these are just in the OR aspects. There's other aspects we have to consider when we develop a system like this as well. All of you have had interactions with your IT department, and you know some of the challenges and some of the appropriate concerns and restrictions that they put on these systems. We've given that a lot of thought on how we interact and how we comply with those requirements. We've also considered the people that are actually purchasing and maintaining the systems, and we have a variety of different ways to provide service level agreements that fit in with your program needs. Taking a closer look at the Essence Patient Monitor quality indicators, we spent a lot of time optimizing that system from our prior experience. Perfusionists can now set desired reference times for their quality indicators. You can set thresholds for different parameters that are of interest, and then that threshold management list is available throughout the case. If it's exceeded or you go outside one of those parameters, on the display that number turns orange. So it's the right amount, we believe, of catching your attention without being intrusive to let you know that that parameter has been exceeded. And then we've also added some calculations that were commonly requested for things like area and time under a curve for a given parameter. My favorite feature on the perfusion monitor is the addition of the goal-directed perfusion graphic user interface. So you're able to view both in a table format and in a graphic format how you're doing against goal-directed perfusion parameters that you set up into the system that, again, work well with your practice. This is going to be available on every case that the Essence perfusion monitor is used, and you'll be able to, again, customize it to the way you'd like to see it. We have the Essence perfusion monitor here with us. It will be available in the exhibit hall when this session ends. So if you're interested in seeing more, touching it, seeing how it looks, come by our booth. We'll be happy to show that to you. I also want to draw attention to the LifeSpark platform, which is our ACS platform. It's built on 20 years of life support experience through Tandem Life. And it provides up to 5 to 6 liters per minute of flow when you're using peripheral cannulation, and it is the only pump that can go up into the sterile field and does not require an infusion line. We've had a great deal of success with this. This is also available in our booth to take a look at. It's a very simple system. If you haven't had a chance to come up and play with it, it's something that you can learn very, very quickly, very easily, fits into a lot of different practices, and helps fulfill our goal for treating more patients in more places. The LifeSpark system is also available on a variety of platforms, depending on your support. So it fits well into traditional VA and VV ECMO. It also works well with RA and PA and LA and FA bypass. So again, come by the booth and you can have a chance to look at it. We're also hosting an event tomorrow afternoon in the garden room, and we'll have a workshop where you can get a little bit more hands-on with that. So with that, Carla, I will say thank you and be happy to take questions online as they come in. Oh, that's probably a good thing.
I know that we're getting a lot of questions about products coming in through our portal. So all of the sales reps are going to be going back, looking through this. So all the questions that you've been asking will be answered probably either later tonight or tomorrow. So be on the lookout. If they're not answered and you need more information, then please just contact me privately or personally or through email, text, or however, and I'll make sure I get the information for you. Our next speaker is Bill Nikotra. He is the Medical Science Liaison for Essential Pharmaceuticals. Bill?
All right, thank you, Carla. And again, thank you, Perfusion.com. Sanibel has always been a great meeting, and it continues to be that again this year. So I'm Bill Nicotra. I'm with Central Pharmaceuticals, as was just mentioned. I'm their medical science liaison and perfusionist. So I have clinical experience with custodial, many years, and so I'm here to pass on some of that experience to you. So today I wanted to talk about what's new with custodial HTK. We have new protocols. I'm going to ask the audience a quick question, just raising your hands. How many perfusionists in the audience has ever had to make a decision on giving a redose, whether it should be high K, low K, no K? Sure, everybody in the audience is, yep, hands are going up, for sure. Wouldn't it be nice to have a studied protocol that works every time and you don't have to make those decisions? That's the goal. That was the goal of putting together new protocols that could take care of all the patient populations that we see in the clinical practice. So I'm going to go over these protocols, and then I welcome any and all clinical questions about this. So for years, custodial HTK, we used this standard protocol. This was the gold standard of custodial, and it still is. It does a fantastic job of protecting the heart. And so the standard protocol were for any cases that you would expect cross-clamp times of greater than 60 minutes. So we're talking concomitant cases, valve cabbage, redos, these type of cases that we know for sure are going to have cross-clamp times of 2 hours or more. And the protocol hasn't changed in many years for this. I'm going to go over this. This is the protocol that's listed on Perfusion.com. So if you need a copy of this particular protocol, it's easy to pull off of their website. But custodial, if you don't know, needs to be refrigerated, but it has a 1-year shelf life. So you hardly ever throw away custodial, as you may have to do with some of your mixed formularies. And then any standard ratio kit can be used. You can use whatever you're currently using to deliver cardioplegia, so there's really no capital upfront cost to start using custodial HTK. And it has to be delivered at 3 to 4 degrees centigrade. And 20 mils per kilo is the pediatric dose, so I typically use this protocol whenever I've got a patient that's 60 kilos or less, or they're coming in with a very low crit. And then it has to be given for up to 2 liters for the full initial dose. And then if you need a subsequent dose, it's half of whatever your loading dose was. And that's going to provide you with 2 hours of uninterrupted protection. So that 1 dose of custodial HTK is going to provide protection for 2 hours, up to 2 hours of ischemic time. And so the surgeon just has that entire uninterrupted time to perform their repair. And you give it just like you give any other cardioplegia in the beginning, enough to close the aortic valve, and then as soon as you start to get to arrest, you back off and you give it about 80 mils of mercury, which is usually a retrograde rate. So typically you'll be delivering the rest of the dose a retrograde rate. And in bold it's more important that the time is delivered over 5 to 6 minutes and not the actual total volume, because we want to make sure that that sodium is depleted so that there is no action potential and that heart stays arrested for that entire time. And common sense, make sure that you have good drainage and you're not distended, and so that you get really good uniform delivery of custodial. And then, like I said, up to 2 hours of uninterrupted repair time before you'll need an extra dose. So if you give 3 doses of custodial HTK for a procedure, you're in a really tough case. I mean, it's a big case. But if you can't vent or sequester that volume, then sometimes hemoconcentration is necessary. So what were the benefits when I was practicing using custodial HTK? The low viscosity. It was talked about today at lunch about the question about viscosity and distribution of cardioplegia. And so with this is the viscosity of water, you have no distribution issues. You actually get to the microvasculature, and that heart is very cold. And it doesn't hardly have any potassium in it, so you're not going to have that high potassium load, and you're not going to have to deal with typically Ks of 7, 8, 9, and having to figure out how to take care of that. And it's got superior buffering capacity to any other cardioplegia on the market. It is the only cardioplegia available in the United States that has histidine. And we all know histidine is a powerful amino acid buffer, and it'll buffer that pH in the anaerobic environment for an extended period of time. And that's why you can literally go 2 hours with a full dose of custodial. And really, for the high dose protocol, just one recognized protocol. So no matter what institution you go to, if they're using custodial, they're doing the same protocol that another hospital's doing, because there literally is only one protocol. And so there's no confusion. And I think that when there's no confusion and you're all on the same page and it's been studied, you should expect better outcomes. And no additives. There's no compounding. So if you've got an emergency case, you run to the refrigerator, grab a bag of custodial, and you're on your way. Sometimes you don't need retrograde because of that even distribution and that length of time of delivering. And also, we have a cold agglutinin protocol. So if you've got a patient that has cold agglutinins, you can actually protect the heart with temperature and not just try and give tepid cardioplegia and hope for the best. You can actually protect the heart with cold cardioplegia. So those are some of the benefits that I saw when I utilized it. But here's what's new. Here's the low dose protocol. And Dr. Ganaydin was, if you saw the Wednesday talk, and if you haven't, I would recommend going back and taking a look at it since it's available. He came up with this low dose protocol because of COVID and having to change techniques. And what he found with this low dose protocol is that for cases that were 1 hour or less expected cross-clamp time, he could give half the loading dose. He could give up to 1 liter of custodial for expected cross-clamp times of less than an hour. And he would give it at the same typical rate that you would with the high dose protocol. So at 4 degrees centigrade, 10 millimoles per kilo, and then at a retrograde rate of 100 to 80 to 100 millimeters of mercury. So it would afford him up to 60 minutes of ischemic time before he would need to redose. And typically, if he was doing a CABG patient, he would take a third of that dose and give it retrograde, just to make sure that he gave the heart really good protection. And then if we went over 60 minutes and he knew it was going to be a little bit longer, then he would just go ahead and repeat the initial dose. So give another liter if you know you're going to be a little bit more. So if it does end up rolling over, then it's almost like giving the full dose. And so what were the benefits? What were the reasons to consider doing this for some of the patients? Well, in single dose techniques, which are very popular right now, we believe that you get better long-term outcomes with a single dose technique of less than 60 minutes. Obviously, now that you're reducing the total volume from 2 liters down to 1 liter, you're going to have reduced hemodilution. I mean, common sense there, but the hyponatremia mostly wasn't evident anymore. Sometimes it wasn't even noticeable, so that's that definite benefit to this. And they didn't use hemoconcentrators for any of the cases that he ran these. I think it was, and I have to refer back to his paper, but I believe 90% of the patients that he did, somewhere around there, he didn't use a hemoconcentrator when he used this protocol. The caveat is, and that's why I have it highlighted, is obviously there's a higher propensity to redose, because now you don't have that 2 hours of protection. You've pulled it back down to 1 hour. So if you do get stuck or things happen, you might have to give a redose. And if you saw his talk, you'll know that there is some concerns about redosing. The questions have not been answered yet about the effects of redosing and long-term outcomes. And then started to take a look at modified custodial. And this is something really new. We just started implementing this into practice. And this is basically adding 1 part blood to 4 parts crystalloid. So we have a modified Del Nido. And for modified HTK. And for this, we give it the exact same way as we gave for the low dose protocol. We give it 4 to 8 degrees centigrade, up to 1 liter, and the same rate. And if it's a cabbage, a third of it in the retrograde cannula, and redosing, same thing. Repeat the induction dose. So why even talk about adding blood to a crystalloid solution that's tried and true, that has reproducible results? Well, here's the reason. Because now we have a direct comparison to Del Nido. You can now do a prospective study. Go up against the original Del Nido formula and go ahead and try it. See what you get. Because I can tell you there's no studies out there currently that are looking at custodial versus Del Nido. They're just not. Now you can do it at your institution. We're already doing it right now. And here's an example of some of the data you can start collecting when you're looking at now, 1-to-1, apples to apples, modified custodial to modified Del Nido. So here it is. It's coming, and there's more data. This is early data, so all the numbers aren't in yet, and this likely will be published when we do have all the data in, but here you go. There's an opportunity to start actually measuring outcomes. And here's something that I've heard in the field for many years, is that I don't use custodial for cabbage patients because you're using a 100% crystalloid solution and it can bleach out the heart. And surgeons can have difficulty tracking some of the coronaries and where they actually need to do their anastomosis, and then whenever they do a vein graft, being able to test with just pure crystalloid. They like to have that blood so that they can actually see the distribution of the crystalloid, because if you're giving straight crystalloid into a vein graft, you can't tell if it's penetrating where you want it to be penetrating, but with a little bit of blood, now it makes the visualization so much better. And so we're hearing it, and so now that's something that now you can use custodial for every case. Valves, cabbages, aneurysms, etc. So a lot of cool things are happening. Here's my email address, so if you do have questions, you want to hear more about this, I'm definitely easy to get a hold of, and I appreciate your time, and I'll take any questions if there is a quick question now.
You said that the protocols were on perfusion.com. Is the cold agglutinin protocol that you do on perfusion.com as well?
No, and that's a good point. We should probably discuss that.
You have people requesting that?
Yes.
Okay.
They can contact me. I will give you my protocol that I used personally, and it works very well. Great question.
Thank you, Bill. Our next speaker is Hemasonics. We're going to have Jeff Light, who is the Senior Product Manager. Jeff?
Hi, everyone. I think it's getting close to wrap up. Happy to be here. I'm Jeff Light. I can take these off because I don't have my notes, so we'll just go with the flow. Great. So, Jeff Light with Hemasonics. Thank you guys for sticking around and listening. So, this short, quick talk is going to be about how viscoelastic testing really fits under the umbrella of patient blood management and the management of critical bleeding. As you know, rapid decisions need to be made quickly, when critical bleeding happens. And importantly, that coagulation is dynamic. Essentially, without my notes, I really did write it out. But essentially, the coagulation being so dynamic, we understand that, wow, just forgive me for a second. You lost me for a second.
Let's get out of here. Okay, interesting. Kind of embarrassing, but I guess we have to live on, right? So anyway, coagulation is dynamic. This is the title slide. What we need here is fast, effective, and accessible tools to make informed decisions in bleeding management. There's been a bit of a shift, and you heard about it a little bit yesterday, in terms of the awareness in patient blood management. This came out from WHO last year, this urgent policy brief of this need to implement patient blood management. I think a lot of you saw it yesterday. But essentially, it defines patient blood management, and the interesting piece I think about it is it starts language that is talking about patient blood management in terms of the patient and not the blood product. And it defines it as, is the broad concept of not just focusing on decreasing blood product use, but improving transfusion decisions when clinically indicated. And I think that's interesting, and also goes on to say PBM decreases risk for adverse outcomes in the iron deficient, anemic, and coagulopathic or bleeding patient. Further last month, actually, so this came out, and I actually really did enjoy this paper, this short paper by a series of authors, a long series of authors you can see, and they gave both a professional and a public definition of patient blood management. The important thing I think about this is that it's a global alignment of a concept or a definition of patient blood management. And it's globally aligned among perfusionists, perfusion groups, anesthesia groups, patient blood conservation groups, patient blood management groups, nursing, pathology, laboratory, hematology, etc. And again, they provided not only a private healthcare professional definition, but also a public definition. And that says something as well. I think what it says is that the concept of patient blood management is transcending the Jehovah's Witness and entering the public domain. And right, so the concept and the drive to be exposed to less blood product is going to be driven not only by the hospital, but also by the patient community as well as we move forward in the world. And so that PBM cultural shift is really transitioning from blood transfusion and blood component focused, which is product centered, very hard cost centered, very product centered, conserve what's on the shelf, to a patient blood management focused and a patient centered approach, which, as we know, really needs to, A, be patient centered, and B, really has to be a team sport. So there's many people involved in a comprehensive patient blood management program. So moving back to coagulopathic bleeding, some patients we know will bleed, and what can be done to prepare. I think the important thing first is to have alignment across the team, right? So clinical and laboratory alignment across the team, and to have an open dialogue about the diagnostic tools that are available that might support that best support that patient, to have a team discussion aimed at that optimizing the goals, talk about test timing, location, accessibility and interpretability, reliability and ease of use, support and training, efficiency, cost, value, and ultimately the goal is to have effective, efficient, and timely treatment decisions to best support your patient's needs and your patient-centered PBM initiative. So, all of that aside, and the rough start, Hemasonics from the University of Virginia came this device called the Quantra. It was created there in an incubator program. Actually, the inventor and founder is still with the company as our CSO. It's headquartered in Charlottesville, Virginia, but really the base of operations is in Durham, North Carolina, where everything happens. We affiliated with Diagnostic Astago in 2017, achieved CE mark in 2017 for the Quantra and the Q Plus cartridge, and then in 2019 for the Q Stat cartridge, another cartridge. And then received FDA clearance, de novo marketing authorization in 2019 with the Q Plus for cardiac and major orthopedic. And then we've achieved about 100 employees worldwide, and we're expanding global clinical partners throughout the USA, Europe, and Asia every day. So that's Hemasonics. That's what we are and what we do. Why, though? Why the Quantra? And so it really is designed to meet the challenges of both the clinical and the laboratory, based on much feedback and many, many years since viscoelastic testing was invented 70 some odd years ago. And it was designed to meet the challenges that are inherent to classic viscoelastic testing technologies, methodologies. Those being an ease of operation and competency, really allowing for use at the point of care, allowable by both laboratory and clinical, and allowing for that ease of operation. Ease of interpreting results, really aimed at increasing confidence, improving communication across and between teams, decreasing complexity in critical situations, speed to actionable results from the blood draw, of course, and then Quantra Q Plus. It provides complete results in 12.5 minutes, 15 minutes maximum. And it is, Quantra is the first viscoelastic test to be explicitly tested and indicated by the US FDA for use at the point of care. Really quickly, 30 seconds is all it takes to run this test. I think you saw this yesterday. It is literally a closed tube sample, scan, push it in, push it down, push start, and you have your results. Also, in terms of ease of use, ease of compliance, a little bit that will make your laboratory happy. 2 levels of liquid quality controls, LIAFA's liquid quality controls. Every single parameter is measured. This is just a look at what it looks like. It looks like a little blood tube. So testing a control is actually just like testing an actual sample. Once it's prepared, you just push it down, just as I showed you in the previous slide. Real-time quality assurance, the internal quality controls, again, another need that every 8 hours the system runs an internal quality control. Won't let you proceed if something doesn't pass. This is another important piece that the laboratory will enjoy to help ensure that the test is going to output the correct result. Again, enabling point of care use. So cartridge QC with every single test and at startup, and as I already mentioned, the liquid quality controls. So really the only thing in your hands as the clinical user is to get the tube filled to the right level. It's completely closed tube, and stick it into that cartridge and hit the start button. As you can see, Quattro Connectivity Solutions, we have both remote view and drivers and middleware through all of the major players. But quickly, talking now about interpretation and speed, I just want to draw your attention to the top left-hand side of the screen. We're looking at that top row, and at the top left we have CTH, as you can see. The top middle we have CT, and the top right we have CTR. Those are all of our clot initiation parameters, and what we're looking at there is we're looking at the combination of both the initiation, meaning the upstream factors, or those that would be contributed to by those factors that would initiate clotting, ones you might find in FFP or PCC, and then also the influence of heparin, for example. CTH is a heparin neutralized clotting time. So it is a clotting time in the absence of the effect of heparin. Clotting time in the middle is heparin sensitive. And then clotting time ratio, which is CTR, is really just one over the other, right? So clotting time ratio over 1.4 would indicate the likelihood of residual heparin, which is fairly helpful to know post-protamine, especially if you're not using an HMS or low-level ACT, as well as in ICU if you suspect rebound. On the bottom, we're looking at clot stiffness parameters. Clot stiffness parameters across the bottom on the left, we have CS, that stands for clot stiffness, PCS, platelet clot contribution to clot stiffness, and FCS, fibrinogen contribution to clot stiffness. They are what they sound like. Clot stiffness is your total clot stiffness. It is the platelets, the fibrinogen, the factor 13 cross-linked, the whole kit and caboodle, if you will, that makes up the clot. The platelet contribution to clot stiffness is, of course, that isolated but within the context of whole blood platelet contribution to the sample as it clots, and the fibrinogen contribution to the sample as it clots. You can see the green reference ranges, and the white arrows are pointing to the area where the clot has happened. If anything is out of range, it will turn yellow. We did go through this yesterday. I think a lot of you saw it already, but it can't hurt to look at it again. Of course, on the screens, if you're interested to look at the dynamics of the clot, you can take a look at the curves, and then on the right here, you can see that you can trend your patient over time. So if your patient is exposed to a treatment, or if your patient is being tracked through the surgery and you want to see how they're progressing, how they're doing, in what direction perhaps some of those parameters are headed, you can do that. So for example, you can see how your on-pump sample, your rewarm sample, looks as compared to the baseline sample, as compared to the post-protamine sample, or post-intervention, if that hopefully doesn't, but sometimes does happen. Interestingly enough, coagulation, as I mentioned in the beginning, it is dynamic. And reference ranges are great, but reference ranges are based on normal, healthy volunteers. These people that are being tested with Quattro are not normal, healthy volunteers. Everyone starts in a different place, right? And some of us, me and you and everyone in the room, we all have a different coagulation profile to start with. And I may right now be falling in that normal reference range. I may not be, right? So it's important to know and look at that baseline and say, well, this is where the patient was when they weren't bleeding, okay? So it is interesting, and you can see in the trend screen that green bar that kind of goes all the way across. That is the normal reference range. It's a good cue, but in terms of positive, negative, I don't know that that it's an absolute. So, that being said, I do want to talk a little bit now about speed. Why is that so important? Again, coagulation being dynamic. Well, the more blood you lose, the more factors you lose, the more you bleed out, the more you're treated, the dilutional coagulopathy can happen, and the more factors are consumed, the worse things get, right? So, say you have a bleeding patient at 300 mils per 30 minutes here. This is actually an excerpt from Tanaka Bader from 2013, but it's a great example of what you can do with a short test versus a long test for results. So here we have the lab sample sent, and a borderline fibrinogen is reported from the lab at, 90 minutes, 80, 90 minutes. And so cryo, it says borderline fibrinogen, let's get some cryo. Cryo is thawed and taken and isn't actually infused into the patient until 130 minutes later. So you can see what the fibrinogen level has done. It has gone from 100 mg per deciliter down to less than 60 mg per deciliter in that time frame. It's a long time to bleed. Versus if, for example, you have a point of care test and you can get results in less than 15 minutes from the draw, the sample can be sent, and maybe 15 minutes later or so, well, if you have access to purified fibrinogen concentrate, you could make that decision. Really 30 minutes, 20 to 30 minutes later, that could be done, and the patient has now their fibrinogen level has actually gone down from 100 to about 90, only 10 mg per deciliter. But, as is mostly the case in the United States, we're using cryo. And so you can see if that were the case, my arrow's off, but you can see there that at 80 mg per deciliter, you've really lost about 20 mg per deciliter from where the lab sample would have been sent. And so the patient doesn't bleed as much, bottom line, right? Bottom line, patient doesn't bleed as much, is exposed to less product, and probably you're not chasing your tail trying to get that resolved. Less complicated, a little bit less stressful, and a little bit less risk. So moving on, I think a lot of people do ask, they sort of see the Quantra, it's a black box, and it's like, what's going on in there? And it's kind of interesting. It's based on a technology called SEER, which stands for Sonic Estimation of Elasticity via Resonance. Quantra is the only viscoelastic testing which is using medical grade ultrasound to test the sample, and it's actually because of that technology that Quantra is able to do what it does, and that means able to test in a completely closed system with a completely closed tube. There's no exposure to air or moving parts or anything. In fact, the cartridge itself doesn't have any moving parts. The sample's drawn up into a small well, where in that well, an ultrasound pulse pings the sample, or it actually rings the sample like a bell. And every 1 second, ultrasound hits that sample and listens to the clot basically change over time. What it's doing is it's directly measuring the shear modulus of that sample. It rings that bell, in a completely closed system, and it is hearing the change. So what shear modulus is an absolute property of all solid materials. Like this podium, right, has a shear modulus. Blood is a liquid. It has a shear modulus when it's a liquid. It has a shear modulus at every second of change as it transitions into a solid or a semi-solid viscoelastic material. The higher the modulus, the stiffer the material. And it is expressed on the Quantra in that scientific unit of a hectopascal. So it is directly measuring, and because of this, we can measure this, so we can do this very quickly, and we can also provide the range of parameters that are unique to Quantra. So that's it. Why Quantra? Again, it's ease of operation and competency, allowing for point of care, ease of interpretation, speed to actionable results, and so forth. Thank you. I'm Jeff Light.
There we go. Thank you, Jeff. Well, this concludes our session tonight. We want to thank everyone for joining us. At 6:30, we're going to have our soiree, which is sponsored by Perfusion.com. We hope all of you come by the booth, get your PDC swag. We have amazing new traveler package that we are offering to those of you that are wanting to travel. You can contact either me or Susan Englert if you're not here to come by and talk to us in person. So if you're doing with us virtually, go grab a glass of wine, a beer, and be with us in spirit as we go to our soiree. Have a great night, and we'll be back tomorrow.
Check 1 2 1 2 3 4. Check 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 check. Check 1 2. Check 1 2. Check 1 2. Check 1 2. Check check. Check 1 2. Check.